네, 여러분 반갑습니다. 저희 이렇게 세 번째 연세 Exercise Oncology 심포지엄에 참여해 주셔서 감사합니다. We thank you so much for participating in our third Yonsei Exercise Oncology Symposium. This time, this symposium is co-organized by our lab and also Yonsei Cancer Center, Cancer Prevention Center, and also National Cancer Center. So three organizations are organizing this very important, we believe, symposium. And thank you so much for participating. Some people in person, but many people online, not only in Korea, all over the world. So we welcome all of you. So I'd like to invite Jisoo Park, and she's the head of Yonsei Cancer Prevention Center. Would you please come here? Yeah. And she's gonna say opening address.
Good morning, everyone. On behalf of Yonsei Cancer Prevention Center, it's my great pleasure to present a congratulatory address at this great symposium today. As you know, Professor John and Carthrin have devoted themselves to academic activity and as well as the education of our cancer patients for a long time. We are very proud to work together with his team with infinite inspiration, passion, and outstanding achievement in the field of exercise oncology. And today, I would like to sincerely thank you for all joining us with the collaboration.
Seoul National University, and I pass the baton to both of you. So please.
This mic.
네.
Let me start with this first session and integration of exercise oncology into standard cancer treatment protocol.
마이크가 안 켜져.
아 그래요? 갑자기 카톡이 마이크는 따로 해야 되나요? 예. Again, let's start the first session, integration of exercise oncology into standard cancer treatment protocol. My name is Jisoo Park from Yonsei Cancer Center. This session will be moderated by me and Professor Jiyeop Choi from Seoul National University. I will preside over the first and the second topic, and Professor Choi will the third topic and panel discussion. Without further delay, I'd like to introduce the first speaker, Professor Esan Shin. She is a professor in Department of Preventive Medicine and the Chief of Clinical Epidemiology Unit, Seoul National University Hospital, Seoul, Republic of Korea. She has played a leading role in academic activity and research in the field of colorectal cancer epidemiology, cancer survivorship using real-world data, gut microbiome, and cancer screening. Please give a talk, Professor.
Thank you. Good morning, and Chair for. Good morning. Thank you, Professor Park, for a kind introduction. I especially would like to thank to Professor Jeon Yong-kwan and Professor Choi Ji-yeop for including me to this exciting symposium. So today I will talk about physical activity after cancer diagnosis, evidences from real-world data. So I will briefly mention about the definition of real-world data and real-world evidences, and the current physical activity guidelines for cancer survivors. Then I'll give you some 3 examples using the real-world data, Korean National Health Insurance Database, KQR Library, and the prospective cohort study, HEXA study. So the real-world data are data related to patient health status and or the delivery of health care routinely collected from a variety of sources. So there's wide range of definition, which is the real world data and which is not. But it seems that current consensus is that the real world data is the setting other than randomized controlled trial. So in that concept, all the observational studies like cohort studies and disease registries are included in the real world data territory. So real-world evidence is the clinical evidences regarding the uses and potential benefit or risk of a medical product derived from analysis of real-world data. So the real-world data resources real data resources covers not only claim data and prospective observational study data and disease registry, which I will cover during this topic. And then EMRs and patient surveillance data, mortality database, social media, and mobile information from the mobile devices are useful sources for real-world data. And now, in the drug industry, they uses this information not only for the drug discovery or discovery phases, but this information also apply to the FDA approval process and some part of a clinical trial, like phase 3 clinical trial, using the real-world data as a control of the RCT patient. And for the post-marketing evaluation period, the real-world data has been used widely for a long time. But today I would like to talk about the cancer survivorship. So now, approximately 43 million cancer survivors diagnosed within the previous 5 years worldwide in 2018. In Korea, in 2019, more than 2 million cancer survivors exist. So it's almost 4% of total Korean population. And most prevalent cancers are thyroid, stomach, colorectal, and breast cancer. And as you can see, many of the cancer survivors of the common prevalent cancers, they survived more than 5 years. So it's very important to see how these survivors can manage their lifestyle and diet pattern and physical activity, etc., for improve their quality of life and survivals. So there are some recommendations for cancer survivor from the American Cancer Society. The general recommendations say that physical activity, assessment, and counseling should begin as soon as possible after diagnosis with the goal of helping patients prepared for treatment, tolerate and to response to treatment, and manage some cancer-related symptoms and treatment-related side effects. So I think this aspect of exercise right after cancer diagnosis and during treatment will be covered during the whole symposium today. But I am more interested in the second part, recommendation to improve long-term health and increase the likelihood of survival. So the guideline says engaging in regular physical activity with consideration of type of cancer, patient health, treatment modality, and symptoms and side effects. So it's quite general recommendation. And what about the World Cancer Research Fund and American Institute for Cancer Research? Actually, they do not have specific recommendation for cancer survivor, but they do have specific recommendation for breast cancer, because the breast cancer is most prevalent cancers in the United States and in the Western world. But in general, the only items for cancer survivors that follow our recommendation for cancer prevention, if you can. So what about the physical activity? They just mentioned that be physically active, but actually they have a scoring system, so higher level of physical activity has a higher score. So now I would like to move to the Korean health insurance system. So the Korean government initiated universal coverage health insurance system for all citizens in 1963, and the universal coverage was achieved in 1989. So at the time, there was more than 300 individual independent medical insurance organization. The government decided to merge all of these small organizations into one big single insurance system, which is the National Health Insurance Services. And that NHIS was launched in 2000. And the National Health Insurance Services provide their data for the research community. So this is the design paper of the data resources. For the research purpose, not only the National Health Insurance Service, but also HIRA, Health Insurance Review and Assessment Services, we can use the data from HIRA. But the claim data can be obtained from HIRA and NHIS, but epidemiologists like me, we are more interested in the lifestyle factors. And the National Health Insurance provide the biannual health examination, health screening for the every beneficiary. So we can use the result of the health examination as well as the questionnaire information that was collected during the health examination. So that's the data we used for these two studies. So one is for the smoking habit for the colorectal cancer patient, and the second one is physical activity, also for the colorectal cancer patient. So using the customized database of National Health Insurance Services, we asked two data for the all colorectal cancer patient with the diagnostic code for the from this C18 to 20s. So for smoking, the female smoking prevalence is very low, so we only included the male colorectal cancer patient. And after colorectal cancer diagnosis, not everybody, but 37% keep smoking even after the cancer diagnosis. But if the smoker quits smoking after colorectal cancer diagnosis, their mortality become lower. So compared to the continuous smokers, the group who's quit smoking shows the hazard ratio of 0.78. So around 20 to 22% of mortality reduction was observed among the quitting smoking groups. So what about the physical activity? So before the cancer diagnosis, around 53% men and women colorectal cancer patient achieved the advised level of physical activity. And after the cancer diagnosis, the proportion is slightly improved, but not so big. But the satisfying the activity recommendation also showed a reduced overall colorectal cancer specific overall mortality and colorectal cancer mortality around 20 to 25%. But the most important limitation of the health insurance claim data is that the data source do not have detailed clinical information such as cancer stage. And we all know that cancer stage is the single most important factor for prognosis of cancer patient. But from last year, the National Cancer Center of Korea, they provide a new data set named KCure, the Korean Clinical Data Utilization Network for Research Excellence. So this is sort of the library that combined the clinical library and the cancer public library, such as the data from National Cancer Registry data from National Cancer Center, and health screening data from National Health Insurance Services, and claim data from HIRA, as well as the clinical data from each hospitals. So from this data, we can have we can more convince that the cancer patient clinical information like stage is more accurate than when compared to we use the health insurance data only. So our graduate Dong-hyun, she uses this data for her master thesis. So she used the KCure collaborative staging link data. So from this data, the National Cancer Center provide around 20,000 colorectal cancer patient information and the stomach cancer information. So at the time of diagnosis, we can divide their health screening point before and after the cancer diagnosis and use the questionnaire information about the physical activity. So the frequency of moderate and vigorous physical activity was combined, and if they exercise more than 5 days per week, we define them as a full adherence, and 1 to 4 days per week is a partial adherence, and no exercise was non-adherence groups. So what about the results for gastric cancer? Actually, the physical activity in aspect for cancer prevention, we all knew that physical activity lower the risk of colon cancer, especially. But among the survivors, we do not see very clear dose-response relationship with the frequency of exercise and the prognosis of colorectal cancer patient. But compared to the no exercise group, moderate level of physical activity shows around 35% reduction of mortality among colorectal cancer patient. But interestingly, we see more clear association for the gastric cancer survivors in this group. And we also can see the changes of physical activity level before and after. So compared to the stable poor behavior, the poor to good or stable good groups, which means that good to poor to good means they increase the frequency of physical activity after the cancer diagnosis, and good to poor means the patient decreased the frequency of physical activity after the diagnosis. So for both gastric and colorectal cancer patient group, poor to good and stable good physical activity groups both shows the reduced mortality compared to the group who maintained the low levels of activities. And the association was prominent of both gastric cancer and colorectal cancer patients who stably maintained their physical activity levels. So to take advantage of this cancer stage information in the K-Cure library, we stratify the cancer patient by their stage at diagnosis. But for the colorectal cancer, although we cannot see very clear association in the advanced stage, the beneficial effect of the higher frequency of the physical activity was more prominent among the early stage cancer patient. So early stage cancer patient, we expected longer survival after cancer diagnosis. So this group, the lifestyle, especially physical activity, could be more important than the patient who are in the advanced stage. And the similar pattern also observed in the gastric cancer, and you can see that most of the gastric cancer patients are stage 1, which is very unique feature in Korea, because the gastric cancer screening is very popular in Korea, so most cancer patients is early stage, and they have very high relative survival. So the stage 1 gastric cancer survivor, after some years, like 3 or 5 years after diagnosis, their expected mortality reaches to the same level with the general population. So they are basically the same probability of dying compared to the general population, even they have the gastric cancer. Okay, so now I would like to move to the last examples. This is the prospective cohort study. It's part of the Korean genomic and epidemiology study organized by Korean CDC. And the health examining study recruited more than 160 participants from more than 30 participating centers. And we have comprehensive information, questionnaire information like dietary information and lab data. And this data is linked to the death certificate information as well as cancer registry data. So by using this detailed dietary information and lifestyle questionnaire, we can analyze more detailed about each dietary recommendation from the WCRF. So this is the result. So from this cohort, we can identify cancer survivors at the baseline based on the questionnaire information whether they ever diagnosed with cancer. And also during the follow-up examination, we also asked them whether they diagnosed with cancer between the baseline survey and the most recent survey. So we can identify more than 5,000 cancer survivors in this cohort. And about physical activity, higher adherence group shows like almost 30% reduction in the mortality compared to the lower physical activity groups. Okay, so this is my last slide and the summary of my talk. The real-world data has a relatively low cost to conduct research, and also its representativeness and generalizability of the result are the main advantage of this data set. And especially for the Korean researchers and many students who are today here, there is some opportunity for us to use this data set, like the National Health Insurance data set, have the health check-up questionnaire on physical activity, and also the KQR library have a more advantage, which include the cancer stage information and the cause of death data from the Statistics Korea. But there is also limitation of KQR library, which I did not mention detail today. But overall, from this data, we see the gastric cancer and colorectal cancer sample data set as an example for how you can use this data for research. So the physical activity before and after cancer diagnosis can conclude that the higher level of post-diagnosis physical activity will reduce the mortality among cancer survivors, and the improving or maintaining good adherence to physical activity recommendations also improve survival of gastric and colorectal cancer patients. Okay, so this is my last slide about acknowledgement. So I would like to acknowledge my previous and current student and lab members who contributed the work that I present today, and also would like to acknowledge my colleagues of the Department of Surgery of Seoul National University. Thank you for your attention.
또 안 되는데요. 마이크가 안 돼요. 네. 어제도 듣다가 죄송합니다. Thank you for the good lecture, and please give a round of applause. And we will take the question and comments for all the topics together. So at the panel discussion next to the third topic. Let's go to the next topic. Let me introduce the second speaker, Dr. Jung-won Do. She is working at the rehabilitation team at a medical center, Seoul, Republic of Korea. She has outstanding ability and expertise in the field of physical therapy and exercise program for the cancer patient with lymphedema. I'd like to call on Dr. Do to deliver her lecture. Please.
Thank you for having me. Today I'm going to talk about exercise in lymphedema after cancer surgery. Okay, so lymphedema occurs when the lymphatic system is not functioning just properly, has been damaged, or in some cases is completely just absent. The result in the accumulation of protein-rich fluid in the interstitial spaces, which can lead to swelling. And to understand lymphedema, let's take a brief look at the lymphatic system. From the initial lymphatics, lymph is transported to the collecting lymph vessels and then lymph nodes, and eventually returns to the venous systems. And lymphatic system is characterized by an open and unidirectional flow. And however, when there is a decline in its function, lymphatic reflux can occur, leading to the development of lymphedema. This photo shows an example of arm lymphedema following breast cancer surgery and radiations. There are some risk factors and progression factors, and there are three main risk factors, especially a body mass index of 25 or higher, and lymph node dissections and radiation, which can damage the lymph vessel and surrounding tissues. And let's look at the progression factors too, and the number of lymph node metastasis, which can make the condition worse. And also, the maximal circumference differences show the severity of the lymphedema. It is one of the progression factors. So knowing these factors helps us detect and manage lymphedema early. And now let's talk about some common myths surrounding exercise and lymphedema. And first, there's the belief that you should never lift 10 pounds for the rest of your life sometimes, and exercise will overload your lymphatic system, so worsen swelling more. And some believes that people with lymphedema should quit jobs or activities that require standing or even just lifting. So with appropriate management strategies, most individuals can continue their usual activities and maintain their physical health and quality of life. So it's really important to challenge these misconceptions so that patients don't unnecessarily limit their activities or avoid exercise, which is an essential part of their recovery. Exercise plays a crucial role in activating extrinsic mechanisms, especially deep breathing creates pressure changes that help move lymph, and also skeletal muscle contractions during movement act as a pump to push lymph through the vessels. Exercise can improve and increase lymphatic flow, helping to reduce swelling and support our just lymphatic health. This is a diagram illustrated, and especially just the both two above here, you can see the transport capacity and lymphatic transport volume always just lower than transport capacity. But after lymph node dissections, especially in cancer patients, can lead to reduction in transport capacity of the lymphatic system like this. So at the same time, excessive or unprepared strenuous activities can increase the lymph obligatory load beyond what reduced system can handle. So as a result, unprepared and overly demanding activities in daily life can become a contributing factor to the development of lymphedema. So today, I will talk about whether exercise can help prevent lymphedema in high-risk patient group and what effects it has on patients who already have the lymphedema. This is one of the research regarding the prevention. This study provides insight into how structured exercise program can potentially prevent lymphedema in this population. This study populations including women undergoing breast cancer surgery with lymph node dissections, and the study includes 20 weeks of supervised session had 3 times per week. And following this, participants continue to 30 weeks more of self-administered exercise. And finally, the primary outcome measures was arm lymphedema. So this was defined as an interim volume differences more than 3%. Phase 1 covered weeks 3 to 23 post-surgery, after surgery, and the exercise load was carefully tailored to each participant, and it was initially determined 7 RM, so 7 repetition maximum muscle test, and with the starting load kept below 60% of 1 RM, and progression was gradual and guided by monthly supervisor test. And from week 12 onwards, the intensity was increased and participants reported fatigue. And the exercise focused on the major muscle group in the upper limb and lower limb and core exercise too. And phase 2, which took place during weeks 24 to 53 after the surgery, involved in self-administered exercise conducted 3 times a week. And the presence and severity of lymphedema-related symptoms were evaluated using the pneumatic NRS score, pneumatic rating scale, which ranges from 0 to 10, and participants were asked to rate their symptoms based on this scale in aspect of swelling and accumulation of fluids in the arms, and arm heaviness, feeling of weight or pressure in the arms, and arm tightness, restricted movement, and discomfort feelings. And NRS score are assessed on weekly basis and track the severity of the symptoms. And a participant's NRS score indicate a significant increase, the trigger further assessment. If symptoms remain severe or worsen, they delay the progression of exercise until symptoms stabilize, and compression sleeves sometimes are provided as needed, and patients are advised to seek support whenever needed to ensure proper guidance and management of their symptoms. In terms of preventions, there was no significant difference in the development of lymphedema between the intervention groups and control group. However, intervention groups show significant improvement in strength compared to the control group, but just a slightly increase in the rim volume, possibly due to the muscle growth, but it is quite great insight in the progressive resistance training found to be safe for high-risk breast cancer survivors. And this is another systematic review for the prevention study. This is the systematic review analyzed 304 relevant articles, of which 9 studies met role of therapeutic exercise in preventing lymphedema secondary to the breast cancers. The key finding from this review is that therapeutic exercise was associated with a reduced incidence of lymphedema compared to standard care practice. Overall, these findings underscore the role of therapeutic exercise as a critical component in improving outcomes and quality of life for these populations too. And now I'm going to talk about research on exercise for individuals with already lymphedema. This study reflects the latest trend, I think, in this field, so I chose it. It examines the effects of tissue compositions, changes in both the affected and unaffected areas of women with lymphedema after engaged in weightlifting exercise program 1 year. The method was used in this study was dual energy X-ray absorptiometry and lymphedema severity scales. It is a self-reported survey, and they are just intervention was weightlifting. So the exercise program included upper body exercise such as dumbbell bench press and lateral front raise and biceps curls and triceps extensions. It also incorporated core exercises and lower body exercises too. All exercises were performed 90 minutes in 3 repetitions per set, with a progressive increase in weight over the times. And in the baseline, unaffected are more fat and more lean mass and less BMC, bone mineral contents and bone mineral density. But after in post-interventions improves in the lean mass and body mass density, and fat percent quite decreased. So slowly progressive weightlifting programs was linked to improved outcomes in women with breast cancer-related lymphedema. This research was published in 2015. I published this study. At that time, some research already started scientific evidence that resistance exercise is not only effective but also safe, is no additional burden or harm to patients in clinical care. But many patients had asked me whether it was safe to exercise if they had severe lymphedema in their arm or legs. So to address this, I conducted a study on progressive resistance exercise programs, especially that designed for patients with severe lymphedema, offering tailored interventions to ensure safety and effectiveness. The result was Just the upper body resistance exercise demonstrated positive effects on the arm function and muscular strength without increasing arm volume in breast cancer-related lymphedema during and shortly post-intensive treatment periods too. The method I used this study involved a therapist supervised program with a focus on progressive resistance exercises. For the upper body, each exercise was performed 10 times per set and with a total of 3 sets, and intensity was gradually increased over the time. And actually, this kind of band, this is the video, so you can see. This is video demonstrated the exercise focusing primarily on the wrist and elbow and shoulder. It provided just therapeutic band. It is easier and useful in the clinical cares, so I used it. So, okay, and last. And then other study, I also conducted a study on lower extremity lymphedema in my patients with gynecological cancer using the same design just before. I published this one 2017 in Gynecological Oncology. The title was Effects of a Complex Rehabilitation Program on Edema Status and Physical Functions and Quality of Life in Lower Limb Lymphedema after Gynecological Cancer Surgery. So this was a prospective randomized trials, and I divided the participants into 2 groups, and the control group and the rehabilitation group. The rehabilitation group followed a structured program that included aerobic exercises and stretching and strengthening training. And the strength exercises were performed using just the previous you saw, the resistance band with the intensity kept below a rating of 13 on Borg scale of perceived exertions, and each session lasted between 30 minutes and was designed to maintain exercise intensity 40 to 59% of predicted maximum heart rate. And the result, CRCDT, it is the intervention group, cancer rehabilitation applied group. So physical ability on quadriceps strength and sit-to-stand test and physical functioning and fatigue symptoms were improved after the interventions. And you can see this graph, and the physical functioning and muscular strength is quite improved, more than just the CDT group. And also fatigue is decreased. And on the right side, in aspect of leg volume and lymphedema, just aspect, leg volume is quite similar. And also GCLQK means Gynecological Lymphedema Questionnaire Korean. It is the questionnaire for the lymphedema symptoms. It is quite similar, decreased in both groups. Patients who underwent surgery for gynecological cancer reported only 19% were able to reach the recommended exercise level set by American College of Sports Medicine. Additionally, obese patients were less likely to meet the recommended weekly exercise levels compared to the non-obese patients. So the obesity is one of the significant factors contributing to lymphedema, and also it is cause of doing exercise. It exacerbates the condition by worsening lymphatic dysfunction and promoting fluid retentions and inflammations and fat accumulations. These factors collectively impair lymphatic drainage and have a substantial impact on disease progressions too. And the study concluded the obesity reduced the efficacy of complex decongestive therapy. Early treatment is critical in preventing fibrosis and fat accumulation in obese patients with lymphedema. While the obese group initially, in the obese group, initially quite higher portions volume in pre-CDT, and post-CDT a little less improved in the obese group, but in 1 year follow-up, it's just returned to the same stage. So early treatment is critical in preventing for the fibrosis and fat accumulations. So it is not quite result in the quite good result in the obese groups. So just the weight control is one of the important factors. So we recommend the exercise, especially in obese lymphedema patients. While the obese group initially showed reduced limb volume after CDT, but their condition returned, just as I mentioned, baseline after 1 year, unlike the non-obese group, which maintained good results. This study emphasizes the importance of prospective surveillance in home for breast cancer-related lymphedema. The reason why I included this research, if somebody has a lymphedema, they can monitor regularly. They will do exercise more easily. So this study is about the prospective surveillance in home for breast cancer-related lymphedema. Regular monitoring such as bioimpedance checks aids in early detection of lymphedema and encourage patients to engage in exercise without exacerbating symptoms. The finding underscore the potential of home-based surveillance in early detections and management and lymphedema. So just the bioimpedance checking is quite meaningful for the early detection and management for the lymphedema. And also regular volume check, particularly focusing on the segmental limb volume changes in the 20 to 30 centimeter range, can be a significant predictor of lymphedema onset in women with early breast cancer. So this kind of monitoring also, it is very great way to encourage exercise and manage early lymphedema symptoms. So it means just only checking above the 20 to 30 centimeter, the circumference checking, it is quite correlated to the total limb volume. So it is effective way to monitor their symptoms. So this is the, actually I included here, just in the first page I included the photo. Can you remember just the photo, the breast cancer, just after breast cancer surgery, lymphedema photos I just share you. And so this was case report. This patient who case I reported in 2017 experienced an exacerbations of lymphedema due to physically demanding activities. She peeled garlic for 7 consecutive hours a week, which mimicked unprepared exercise. This likely increased the lymphatic load and contributed to the limb volume changes. So, exercise should enhance lymphatic flow, but without causing a sudden increase in lymphatic load. Achieving this balance is the key to effective lymphedema management. So with proactive monitoring and, structured progressions, and including custom compression garments and symptom monitoring and comprehensive program that combine resistance and cardiovascular and flexibility exercises can greatly improve outcomes. Thank you for listening.
Thank you for the excellent lecture, and please give her a big hand. And from now on, I'd like to hand over moderation to my co-chairperson.
we have online. Finally, we have Dr. Justin C. Brown from Pennington Biomedical Research Center, a leading researcher in exercise oncology. Dr. Brown's innovative studies on the role of physical activity in cancer treatment and survivorship are reshaping clinical care for cancer patients. His presentation today is titled The Role of Physical Activity in Colorectal Cancer Survivorship.
Hello and welcome. My name is Dr. Kathryn Schmitz, and I'm a professor at the University of Pittsburgh School of Medicine and the UPMC Hillman Cancer Center. I am absolutely delighted to be introducing Dr. Justin Brown. Dr. Brown is an associate professor with tenure at Pennington Biomedical Research Center. He has very, very quickly in his career become a leading voice in the space of exercise oncology and cancer metabolism. Let's turn the floor over to Dr. Justin Brown.
Thank you, Dr. Schmitz, for the very kind introduction. It's really a privilege and pleasure to be able to contribute to this really important meeting, and special thanks to the conference organizers, Dr. Justin Jian and Dr. Dong-Hoon Lee. I received grant funding from the National Cancer Institute of the United States, Cancer Research United Kingdom, and the American Institute for Cancer Research, which is paid to Pennington Biomedical Research Center to support my program. I also received consulting fees from Novo Nordisk and Nestle Health Sciences for topics unrelated to what I'll discuss today. I've outlined 3 learning objectives. We have 1 clinical objective to formulate an evidence-based physical activity prescription for colorectal cancer survivors, 1 biologic objective to describe the mechanisms by which physical activity may reduce morbidity and mortality in colorectal cancer survivors, and 1 methodologic objective to recognize how innovative causal inference methods and methods developed in parallel fields can inform cancer survivorship care. First, I want to orient you to where we're going to be in the cancer prevention and control continuum. So I do research all along this continuum. I have funded studies in the pre-diagnosis phase to understand how weight loss by metabolic and bariatric surgery may prevent incident cancer. I also have funded studies at the end of life to identify potential drug treatments for cancer cachexia, or the muscle loss syndrome that happens in many patients with advanced cancer. But today I'm really going to focus on this survivorship window. And I spend about half my time doing observational studies and the other half doing clinical trials. And today I'm going to really focus and present on the unique value that observational studies can offer the field of exercise oncology. We use colon cancer as a disease model because it's a very common malignancy, and many patients will develop tumor recurrence despite receiving optimal surgical and medical therapy. And the median overall survival after colon cancer recurrence is about 30 months. Now, many patients are aware of their risk of recurrence and they understand what may happen afterward. And consequently, many patients are motivated to understand if there's anything that they can do to improve their probability of a good clinical outcome. That is, they want to be cured. And physical activity may be an intervention that interests patients because it can be empowering. It's something that they can do. And as I'll show you, it has some good data to support its use. And so this whole field really started about 18 years ago. And it was this paper published by my postdoctoral mentor, Dr. Jeff Meyerhart, who showed that physical activity after a diagnosis of colon cancer is associated with a lower risk of disease recurrence and death. Now, up till this point, there was a lot known about the association between physical activity and the primary prevention of colon cancer. But it was really this paper that began to shift our thinking about the potential benefits of physical activity or exercise after a diagnosis of colon cancer. So the study that I'm going to describe today is, it's a randomized trial that had a nested observational cohort study. So this is Alliance Trial 8702, and it used a 2x2 factorial design in patients with surgically resected stage 3 colon cancer. And the first randomization was to 2 different lengths of a standard chemotherapy regimen called FOLFOX, and patients were randomized to either 3 months of FOLFOX or 6 months of FOLFOX. And the second randomization was to an anti-inflammatory medicine called celecoxib for 3 years daily, or a matching placebo. And the primary endpoint of this trial was disease-free survival, and the key secondary endpoint was overall survival. And the results of each of these randomizations have been published. And patients who enrolled in this trial, but right after they were randomized to their groups, were given the opportunity to participate in a nested cohort study of biospecimen collection, where they provided a blood sample, as well as completion of some lifestyle surveys at the start of treatment, right after randomization, and about a year later. And the lifestyle surveys assessed physical activity and some other factors. Now, the benefit of nesting observational studies within randomized trials is that the patient sample is homogeneous because of screening and inclusion and exclusion criteria. In this setting, cancer therapy was standardized because it was a treatment trial, and the endpoints are ascertained systematically, so disease-free survival and overall survival. And so this really creates an outstanding opportunity to be able to answer correlative questions in a really rigorous manner. So building upon the initial publication 18 years ago, we showed that more physical activity is associated with a higher probability of being alive and cancer-free 3 years after surgery. So on the x-axis is the total physical activity volume, with less than 3 METs equivalent to the energy expenditure of less than 1 hour per week of brisk walking, and 18 METs equivalent to the energy expenditure of 6 or more hours per week of brisk walking. And on the y-axis is the percent of patients alive and cancer-free at 3 years. And 3-year disease-free survival is an outstanding surrogate for long-term overall survival or cure from colon cancer. And the RDs that you'll see is the absolute risk difference and 95% confidence interval from adjusted models. So you can see the more physical activity, the higher the probability of being alive and cancer-free at 3 years. And from a public health perspective, if we could move all patients up one category, so patients here to here, patients in this group to this group, patients in this group to here, and keep these people here, you could theoretically prevent up to 22% of cancer recurrence and death events. Now, the problem is when this type of information is implemented into clinical practice, most patients ask if one type of activity is better than another, or they just want more specific guidance about what they should be doing. And up until now, we really haven't known. We haven't had the data. And so we used 8702 to be able to go a few steps further to begin to answer these questions. So aerobic activity of any intensity was associated with an improved 3-year disease-free survival. And this is light to moderate intensity activity. This is akin to brisk walking. This is the same y-axis as before, and the x-axis is the amount of light to moderate intensity activity. You can see that patients derive the largest benefit by moving from doing no light to moderate intensity activity to even a small amount, up to about an hour and a half per week. And if patients do more activity, they continue to benefit more. And on the right is vigorous intensity activity. Now, this is akin to jogging or running. Now, note that the x-axis categories are slightly different than the light to moderate categories. But again, moving from doing no vigorous intensity activity up to 1 hour per week, you derive the largest benefit. And unlike light to moderate activity, doing more than 1 hour doesn't appear to confer additional benefit. So this data begins to provide some clarity on the issue of aerobic activity intensity and the volume necessary to achieve a clinical benefit. And we also showed that muscle strengthening activities like weightlifting or calisthenics are also associated with an improved 3-year disease-free survival. Again, the same y-axis as before, and the x-axis is the number of hours per week engaging in these types of activities. And note that we're looking at fairly small amounts of activity, 10 to 30 minutes per week. Now, many patients will want to know if they already do aerobic activity and they add muscle strengthening, does that give them additional benefit? And so here is the analysis after adjusting for the amount of aerobic activity that patients do, and there remained a statistically significant benefit of weightlifting up to about 30 minutes per week. So I've been asked, how would I operationalize these results into clinical practice, recognizing that oncologists and oncology nurses are not exercise physiologists? And this is how I would implement these data into practice. You assess readiness for physical activity. If patients are not interested or not ready, you mention the potential health benefits and reassess readiness the next time you see them. If they are interested, you figure out what types of aerobic activity they like. These are the probing questions like, what types of activities do you enjoy? Or what types of activities do you want to learn to do? And if they cite activities like walking, that's light to moderate intensity, you recommend that they slowly increase to at least 1.5 hours per week. If they cite activities like jogging and running or tennis, that's vigorous intensity, you recommend that they slowly increase to at least 1/2 hour each week. And the way to remember this intensity decision point is the talk test. If they mention activities that they're likely able to be talking while they're doing it, it's likely moderate. And while they're doing the activity, if they're unable to talk or carry a conversation, it's likely vigorous. And typically, patients prefer aerobic activities. So I recommend to start with aerobic modalities, and then down the road, you can integrate muscle strengthening and calisthenics. But if you have a patient that prefers the muscle strengthening, you can definitely start with that and then add aerobic activity down the road. So we know that physical activity is associated with a longer disease-free survival, but a longer disease-free survival could be achieved by preventing recurrence entirely, preventing the bad thing from happening, or simply delaying the time needed to develop the recurrence. And I've been really interested in trying to figure this out, because knowing if physical activity prevents or delays recurrence is really relevant to patients, they want to know, but it's also relevant to the delivery of cancer care and may contribute to our understanding of cancer biology. So to figure this out, we applied a method developed in causal inference called continuous time modeling to compare the hazard rates in physically inactive patients versus physically active patients. And if you graph the confounder-adjusted hazard rates, how they compare can really clarify the concept of prevention or delay. So on the left panel, you can see a hypothetical example consistent with the prevention hypothesis. On the x-axis is time, and on the y-axis is the hazard rate of recurrence among physically inactive and physically active patients. You can see that the hazard rate in the physically active patients is consistently lower than in the physically inactive group, and the two lines never cross. Conversely, on the right panel, you can see a hypothetical example of delay, where the shape of the hazard rate is similar in magnitude, right? Same apex, but it's shifted to the right. And the physically active group is not consistently lower than the physically inactive group, and the lines cross. And then using these confounder-adjusted hazard rates, we can then calculate what's called a continuous time hazard ratio to quantify the relative treatment effect size over time. So here's the real data. These are the confounder-adjusted hazard rates for cancer recurrence for physically inactive and physically active patients. This pattern here is consistent with the prevention hypothesis, such that physical activity may prevent recurrence in at least a subset of patients. And this is the plot of the hazard ratio of these two hazard rates. Physical activity is associated with a lower risk of cancer recurrence in the first postoperative year. And to me, this is informative biologically because it suggests that physical activity may be doing something to eradicate micrometastatic disease that remains after surgery. And it's also informative to cancer care delivery because it suggests that patients who want to do physical activity to derive a potential recurrence benefit need to become physically active early in the postoperative treatment phase. And for those who are curious, we did show that the prevention of recurrence in the first postoperative year did convert into an overall survival benefit for the first 3 postoperative years. So you can see that the hazard rate of death is lower in physically active patients, which makes sense because we're preventing recurrence, and recurrence is the #1 cause of death in the first 3 to 5 years after a colon cancer diagnosis. So the lines separate, and then they converge around year 4. And at this point, most of the recurrence benefit attributed to physical activity has been achieved, and the lines converge. And then thereafter, the lines begin to separate again out in years 4 and 5. And this is where patients begin to die from other competing causes, such as cardiovascular disease and type 2 diabetes, which is also reduced by physical activity. And recall at baseline, patients provided a blood specimen. And from that biospecimen, we analyzed various inflammatory biomarkers, including high sensitivity C-reactive protein, interleukin-6, and there's one more that's not shown here, tumor necrosis factor alpha. And all of these biomarkers of inflammation were associated with an increased risk of cancer recurrence or death compared to those with the lowest inflammation. As inflammation increased, so did the risk of death. So we wanted to see if physical activity could intercept or block the negative prognostic effect of inflammation on disease-free survival and overall survival. So we classified patients into 3 broad buckets, those with low, intermediate, and high inflammatory burden based on the number of elevated inflammatory biomarkers that they had. And after creating these 3 groups of patients with increasing inflammatory burden, we looked at the association with disease-free survival and overall survival by physical activity status. So the reference group in this analysis is patients with low inflammation who are physically active. 88.4% of them are alive and cancer-free at 3 years. And patients with low inflammation who were physically inactive had a numerically lower, but not statistically significantly different 3-year disease-free survival rate. Among patients with intermediate inflammation who were physically active, the 3-year disease-free survival rate was not worse than the reference group among those who were physically active. But among those with intermediate inflammation who were physically inactive, they had a significantly worse 3-year disease-free survival. And among patients with high inflammatory burden who were physically active, the 3-year disease-free survival rate was not statistically significantly worse than the reference group. Conversely, those with high inflammatory burden who were physically inactive had significantly worse 3-year disease-free survival. So while physical activity doesn't appear to completely intercept or block the negative prognostic effect of inflammation on disease-free survival, it does seem to attenuate at least some portion of it. And so this is consistent with the hypothesis that physical activity is doing something that intercepts a process along the inflammatory cascade. And here's the data for 5-year overall survival, which shows a very similar pattern. And the patterns here are very similar if you look at individual inflammatory biomarkers, so C-reactive protein by itself or others. And collectively, this evidence suggests that we might be able to use inflammation as a biomarker at the time of starting chemotherapy to identify patients who may be most likely to achieve a disease-free survival benefit from physical activity. So in this sense, we can use inflammation as a predictive biomarker to identify patients likely to derive a meaningful disease-free survival benefit from physical activity. And the last analysis I want to present is a method that we borrowed from the field of demography. So until now, I've shown you comparisons of colon cancer patient A versus colon cancer patient B. For example, those who are physically active versus those who are physically inactive. But enabling patients with colon cancer to understand how physical activity may influence their prognosis relative to a similar population without cancer can be really valuable to healthcare providers and particularly policymakers who are always seeking innovative and evidence-based messages in order to promote physical activity to improve population health. So this was a study of 32,000 early-stage colon cancer patients, and for each patient, the expected long-term survival based on the general population matched on age at cancer diagnosis, sex, and calendar year was calculated using life tables from the National Center for Health Statistics in the United States. And overall, at 8 years, the overall survival disparity was 14.1% lower in patients with colon cancer than in a similar age, sex, and year-matched general population. And the main factor that accounted for this overall survival disparity was cancer recurrence. Patients who developed cancer recurrence had an overall survival experience that was 61.5% worse than the general population, whereas those who did not have a recurrence had a 1.8% worse survival experience. Both of these were statistically significantly worse than the general population, but recurrence status accounts for a major fraction of the variability. So with this in mind, and the data that I showed you earlier that physical activity may prevent recurrence, we wanted to see if physical activity attenuates the survival disparity between colon cancer patients and the general population. So here's the data stratified by physical activity category. The red lines here are the observed overall survival experience for patients with surgically resected stage 3 colon cancer. And the blue lines are is the overall survival experience for the age, sex, and year-matched general population. So with increasing volumes of physical activity, the magnitude of the survival disparity decreased from 10.8% to 5% to 4.4%, suggesting that physical activity may be a means to reduce the overall survival disparity between colon cancer patients and the matched general population. And then we went one step further and stratified these groups by their cancer recurrence status. So here's the overall survival experience among patients who developed cancer recurrence. And you can see that increasing amounts of physical activity very modestly attenuated the overall survival disparity. And this is not really surprising because recurrent colon cancer, in the nature that it metastasizes, is typically fatal and incurable. And so the overall survival disparity is quite large, irrespective of the amount of physical activity. Now, here is the overall survival experience among patients who did not develop recurrence. So among colon cancer patients who engaged in very little physical activity, the magnitude of the overall survival disparity was 3.1 percentage points worse than the matched general population, and that was statistically significant. However, as physical activity volume increased, the width of the survival disparity narrowed, and then it eventually reversed, such that patients with colon cancer who engaged in high volumes of physical activity and remained recurrence-free had an overall survival experience that was 2.9% better than the general population. So the results of this analysis may be particularly relevant for patients who want to understand how physical activity may improve their long-term health and how physical activity may compare to their friends and family members without cancer. And so this data can provide a powerful teachable moment for some patients that physicians and policymakers could leverage in order to use physical activity to improve population health. So this set of observational analyses nested within a randomized trial begins to answer some of the most common questions that the oncology care team is asked. If patients are trying to achieve a disease-free survival benefit, the best type of physical activity is the one that the patient will do. And how much physical activity the patient needs to do really depends on the physical activity that they choose. Remember the flow chart? And patients really ought to start increasing their physical activity after they recover from surgery. So as soon as their surgeon clears them to resume their activities of daily living, they should start low and progress slowly. And if the association between physical activity and disease-free survival is causal, and we don't know if it's causal, this is all observational research, it might be operating at least in part through the blockade or the interception of some inflammatory pathways. And for patients who say, why would I care about any of this? Physical activity may help colon cancer survivors achieve a potential survival outcome that approximates their age and sex-matched peers who do not have a serious illness such as colon cancer. So if I've done a good job, you now know how to formulate an evidence-based physical activity prescription for colorectal cancer survivors, describe the mechanisms by which physical activity may reduce morbidity and mortality in this population, and recognize how innovative causal inference methods and methods borrowed from adjacent fields such as demography can inform cancer survivorship care. Cancer care is a team effort, and cancer research is no different. So I want to thank all my colleagues and collaborators at Pennington Biomedical and other institutes. I also want to thank the National Cancer Institute in the United States, who has continuously funded me for the last decade, starting in my PhD with Dr. Schmitz, as well as these other funding agencies listed here. A colleague created this illustration for me when I was a master's student more than a decade ago. And my goal is to try to create the evidence base so that this illustration becomes an evidence-based reality. And everything that we do at Pennington Biomedical is designed to help cancer patients and their families understand how the choices that they make outside of the walls of the cancer center impact how well they feel, how well they function, and ultimately how long they survive. Thank you so much.
For cancer patients, it could be very challenging to do the exercise. So I just want to ask you, what's your strategy to help cancer patients to do more exercise?
My strategy has always been we have to meet patients where they are in their journey. Some individuals will come into a cancer diagnosis being very physically active, and the hectic nature of treatment just kind of slows them down and distracts them, and they just need a little bit of a boost, but they know what they need to be doing. So in that sense, I kind of view myself as more of a cheerleader, right? I'm just providing the motivation, the support, the positive feedback. For other people, thinking about doing physical activity or exercise for the purpose of achieving a health outcome, they've never thought about it in their life. And this is all very new and very overwhelming. And so ultimately, the goal is really to work with individuals to try to find activities that they like to do, because the intent is for them to do it for the rest of their life. And so it's very iterative, where I may make recommendations to individuals and they come back and say, I don't like doing that, right? So that means I have failed in my job of providing helpful recommendations. So I provide other recommendations. And so it's really trying to work with individuals to find a solution that works for them within their family, their built environment, and a solution that may work for one patient may not work for another. And so really it ultimately comes down to kind of individual decision making, and really encouraging patients to understand that little things make a big difference when integrated over the lifespan. And so I'm not asking you to run marathons. I'm not asking you to run 5Ks unless you want to, right? I'm asking you to do just a little bit more today than you did yesterday. Right? We can't change tomorrow, or we can't change yesterday, but the decisions we make today can impact how we feel tomorrow. So it's really an individualized decision, working with the patient to try to find a solution that's acceptable to them, because it comes back, if they don't like the solution, they're not going to do it. They're not going to derive the health benefit. And so it takes time in order to try to figure out what that combination is. But then once they find it, they're able to do it for the rest of their life.
Is it possible that exercise is a marker for people who will do well? Is it possible that we can reverse the causality in what you've shown to say that, in fact, what's really happening is that the people who are well enough to be able to exercise are the ones who survive?
Yeah, it's a great question. I think from people outside of the field of physical activity epidemiology, there is a legitimate concern that physical activity is really just a surrogate for performance status, right? How the functional ability of a patient, which is known to be very strongly related to clinical outcomes, particularly overall survival. The thing that I will note is in all of these analyses that I've presented today, they're all adjusted for performance status. So we've tried to account for that. The other thing that I would say is, given what we know about the biology of exercise, although we don't have a randomized clinical trial with a disease endpoint showing benefit yet, we know that exercise improves a lot of other health outcomes, whether it's related to glycemic control or blood pressure or blood lipids. And so I think it's within the realm of biological reality to say that exercise may prevent cancer recurrence, and it's not simply reverse causality. The other thing that I will say is and there's not a lot of studies, but there are some studies that have shown that when they measure physical activity before a cancer diagnosis and after, it's the patients who increase their physical activity that derive the survival benefit. So it's those studies that have measures before the diagnosis of cancer, before symptoms may have emerged, or before a lot of the syndrome that may have prompted the workup that diagnosed the cancer have started to develop. And so that provides additional credibility to the fact that it certainly looks causal, but as with any observational study, there's always the possibility of unmeasured or residual confounding, which is why, the randomized clinical trial remains the gold standard.
I mean, it was excellent talk. Thank you so much.
Thank you, guys. Thank you all for being able to put on this symposium. And I'm sorry that I can't join you in person. I will be with you in spirit, because what you all are doing is so important to being able to help cancer survivors and help their families and be able to move the field forward in a meaningful way. Thank you so much for the invitation.
Now we have invite you to join us for our Q&A session and panel discussion.
Health problems or metabolic disease and others. What's your opinion?
Yeah, so that is very critical and important issue. So, so stage 1 cancer, especially gastric cancer, their relative survival rate is almost close to 100%. That means their probability of death is very similar or the same with the general population without cancer, because they are very good prognosis. But the goal of our life is not only survive from cancer, but also we wanted to live healthier and longer. So yeah, you're right about the cause of death of the early stage gastric cancer as well as the colorectal cancer. The cancer death is less than 10% of their cause of death. And other causes like cardiovascular disease or other cancer, the causes the death of the cancer patients. So the physical activity not only prevent recurrence of the cancer, but also they have another benefit like cardiovascular benefits that this. So overall is their effects not only directly through the preventing or reducing cancer recurrence, but also other metabolic and metabolic disease and status. Yeah.
Thank you. Any other comments or questions?
Thank you so much for your excellent talk. I have a question for each one of you. It was very surprising to see that you have a survivor benefit with physical activity for colorectal cancer when they do 1 to 4 days. But then if they do more than 4 days, they have a survivor benefit disappear. I want to ask you, what is your thought on that? And also I have a question for Dr. Do. You have shown in your study that exercise is beneficial for lymphedema, increasing the muscle strength and other benefits. But then how soon after the surgery do you think is best to prevent lymphedema from your clinical experience? So that's the question for you.
The health insurance data is a real world data. The data was not collected for research purposes. And the physical activity questionnaire, if you are a student made questionnaire like that, you will reject the questionnaire. Because if you're familiar with that questionnaire items, it is basically the short form IPAC, but without duration of exercise. So yeah, there's critical flaw for using to the research purposes. For the vigorous and moderate activity, they only have frequencies. So yeah, we cannot make a calculation like total METs per week, something like this. So that's the inherited limitation of the data itself and questionnaire item itself. But what we saw was that for the gastric cancer patients, at least for the gastric cancer patient, we see some kind of dose-response relationship with the survival with a higher frequency of physical activity, but we didn't see for the colorectal cancer patient. Yeah. So yeah, that I don't have any clear answer, but we need to look at for other data sources. But the promising side is that the changes of physical activity is consistent with our hypothesis to increasing the physical activity level after diagnosis is beneficial for them. So yeah, maybe the colorectal cancer paper has not been submitted yet, but we need to look at, I think we need to look at the characteristics of the patient who has a higher physical activity level at the diagnosis, whether they have some differences in the basic characteristics or their basic other lifestyle factors. Thank you for your comment.
Thank you for your great questions. Actually, I had asked from my patients like those kind of questions. Depending on the diagnosis, such as breast or gynecological, sometimes head and neck cancer, also just includes lymphedema. So in cases of the breast cancers, that's why I just introduced one research in my presentations. The study was included only just after the 3 weeks, it was started to do the progressive resistance exercise even in the surgery arms. So it is quite safe and effective. So, but depending on the patient's type, surgery types, just such as sometimes just breast cancer, just sentinel lymph node dissections, very small, just lymph node dissections. Sometimes axillary total dissection and axillary lymph node dissections. And sometimes, and after that, they are doing some just flap kind of breast reconstructions. All those cases are different. So depending on the patients, it is quite different just stage. So I always recommend just after the surgery, you need to check again from your just own doctors, and it is available to do the exercise in their just surgery part, affected part, and they are starting the exercise with a resistance exercise. But except that, just walking or cardiovascular exercise, it can be included right after just 1 day or 2 days. It can be involved, but in just areas, some part in cases of gynecological cancer patients, resistance exercise on the lower leg, it must be started from mostly just after 4 weeks, 6 weeks, or 8 weeks, mostly recommended. And in cases of breast cancer, it is recommended after 1 month. It can be just with the monitoring very carefully, they can start the resistance exercise.
So I'm asking Dr. Shin and also the exercise experts in the field. Most of the study shows post-diagnosis exercise is effective for the survivorship. But can we differentiate the pre-diagnosis exercise and post-diagnosis exercise? Because exercise initiation is very difficult. My question is, can we differentiate or confirm the post-diagnosis exercise, and if we can, how to initiate the person to start the exercise at the diagnosis, because it's very difficult and also it's related to self-efficacy as well.
So the cancer diagnosis is a sort of lifetime event for most cancer patients. So, and even for their close family members and caregiver, there is some pressure. The cancer patient should correct their bad behavior. So in line with that, so the colorectal cancer patient, although 1/3 keep smoking, at least 2/3 quit smoking after cancer diagnosis. So I think the same apply to the physical activity. The exercise is difficult, but after cancer diagnosis, the patient are more motivated to the better lifestyle to improve their health. So the cancer diagnosis actually could be a good cue to change their behavior. That's my opinion. Okay.
그냥 진행하시면 돼요. 또 녹화 들고 하셔야 돼요.
들고 해야 돼요? 네. Thank you for your great talks. I have very general questions. We have put in a lot of efforts into treating and preventing cancers, like exercise and nutrition, and rehabilitation, things like that. So I'd like to know how successful they have been in terms of reducing cancer recurrence and prevalence and mortality, things like that.
누가 답변하시겠어?
Anybody who can answer?
네? 아니요, 저는
You mean in general?
In general, we put a lot of money and research and development into treating cancers and even cancers. I'd like to make sure how those efforts have been successful.
So I think it's really complicated questions. So yeah, so in Korea, compared to the 20 years ago, so cancer survivor improved dramatically. So it can be explained by mainly two factors. One is early detection by screening, and another one would be the development of cancer treatment. So I think the leading the attribute of the surviving better survival is the introducing of new treatment, especially the new cancer chemotherapy drugs and immunotherapy drugs. That will be the first one, and it will be a little bit hard to say about what was the role of the behavior changes on the cancer survivor, but there's some evidence for the aspect for the cancer prevention. Like for colorectal cancer, we calculate the population attributable fraction, which means that the health behavior how much proportion of cancer incidence could be prevented by the changing the health behavior. So the physical activity is accounted around 10 to 15% of colorectal cancer occurrence, and the obesity and alcohol consumption are another important factors. So yeah, so in terms of cancer prevention, I think that at least for the colorectal cancer, around 1/3 to half of the cancer could be prevented by the early detection and the primary prevention like diet or management of health weight and physical activity, etc.
How about genetic or environmental factors? Which one do you think is more important?
So what for do I need to answer because it's really general question. So the genetic factors besides the hereditary cancer, genetic like common polymorphism like SNPs and GWAS study only can explain around 3 to 5% of cancer occurrence. So their role is not so big compared to the environmental lifestyle factors. And I wonder whether you mentioned about environmental, you mentioned about the, air pollution or something like that, or climate change or
Other than genetic factors, that's what I mean by environment.
Yeah. So environmental factors definitely more important than hereditary or genetically predisposing factors, especially for colorectal cancer and gastric cancer. Okay.
Thank you.
In general, the genetic factor is the environmental and combining. So some recurrence is inevitable, and the recurrence and the occurrence of cancer is progressing accompanied with the cellular aging, I think. But it's very important factor is that behavioral change is we provide something to do the patient themselves. They will want to try something to prevent recurrence of cancer. But many trial is not important, and not as the 한약 and the other. We recommend some very important and effective factor to the patient is very important, I think. 그냥 클로징 제가.
네. 오케이. 항상 첫 번째 세션이 제일 어렵거든요. 사람들이 이렇게 들으시는 분들이 계시고 어떤 사람들이 위해서 딱 발표해 주셔서 너무 감사드리고. 네. So this is the end of our first session. But before we end our first session, I'd like to acknowledge a few people. This time, actually, we have 8 people who organized these sessions together. And Professor Ji-Yup Che is one of them, and also Min-ji Hee, raise your hand, and then Kim Jin-su 박사님, and then Lee Kyu-wan 교수님, and Kang Dong-woo 박사님, and Lee Dong-hun 교수님, 그리고 양은주 교수님, who is not here. She also was part of the organizing committee members, so I really appreciate them. And we have a coffee break, 2 minutes. No, we have maybe, so we'll resume our session at 10:45. So we have a 7-minute coffee break, and then we'll come back for the second session. Thank you.
Now we start the second session of this outstanding symposium. Thank you very much for inviting me to this very interesting, very informative symposium. I'm Dr. Yonsei. I'm actually doctor in rehabilitation medicine. Currently work at SRC Rehabilitation Hospital in Korea, and also support some IT digital health techniques in some startup company.
Nice to meet you. Thank you for inviting me to this wonderful symposium. I'm Yonsei Kim, is professor from Department of Physical Education at Seoul National University.
We start the first sessions of this second session. The topics of this session is targeting cardiovascular health and frailty in cancer survivor. The impact of exercise-based cancer rehabilitation is speak by Professor Kyung-Han Lee. Professor Kyung-Han Lee is a PhD in exercise physiology in University of Southern California, and currently professors in Department of Kinesiology and Sports Medicine, Women's University. Professor, please.
Thanks for the kind introduction, and also I really appreciate the opportunity to speak about my research targeting cardiovascular health in cancer patients with exercise-based cancer rehabilitation. So when you talk about exercise-based cancer rehabilitations, we just don't do like exercise. We try to stratify cardiovascular risk factors based on what they have before, during, and after cancer treatment. Based on the stratification strategy, we try to individualize the exercise programs based on their needs or fitness levels or goals or physical limitations. And we just don't do this with exercise professionals, but we also work with oncologists and cardiologists, nurses, physical therapists, and dietitians, and even psychologists to make the exercise-based rehab more successful. This is really important because cancer patients already have pre-existing cardiovascular risk factors such as obesity, smoking, type 2 diabetes, and etc. But also with the pre-existing cardiovascular risk factors, cancer related cardiotoxicities increase another cardiovascular risk of cardiovascular disease, which eventually develop heart failure several years later. So when we deliver exercise-based cancer rehabilitations, we try to deliver different types of exercise, including resistance type of exercise, also moderate intensity endurance type of exercise, which we call conventional type of exercise. We can also combine these two. But recently, we also have more evidence on high-intensity interval training, which can also improve multiple health-related outcomes in cancer patients. So in our previous trials, we try to target cardiovascular risk factors, specifically traditional cardiovascular risk factors such as cholesterol, type 2 diabetes, and also high blood pressure and smoking habits, which can calculate Framingham risk scores. We recruited 100 breast cancer patients who completed most cancer treatment except the endocrine therapies, and we recruited mostly breast cancer patients who were mid 50 years old, pre or postmenopausal women with multiple ethnicities, stage 1 to 3 breast cancer patients. With the conventional type of exercise, which included resistance type and also aerobic type of exercise, we have shown that this conventional type of exercise can reduce waist circumference, also body mass index, and cholesterol, HDL cholesterol level, and also LDL cholesterol level after 16 weeks of conventional type of exercise. Also, we have shown the positive effect of exercise on systolic blood pressure, and also diagnosis of type 2 diabetes, and also include metabolic syndrome, therefore Framingham risk score after 16 weeks of interventions. So we basically have shown that this traditional type of exercise, including resistance and also aerobic exercise, can really reduce the cardiovascular health, specifically the traditional cardiovascular risk factors. But more recently, we have more evidence on high-intensity interval training, which can be conducted by stationary bike or treadmill, even bodyweight exercise. And we also conducted another type of exercise interventions targeting cardiovascular health, but also more specifically to the cardiotoxicity level, because the previous trial that I just introduced is more targeting traditional cardiovascular risk factors, but now we're focusing on the cardiotoxicity level with the imaging modalities and also with more newer type of exercise called high-intensity interval training known as HIIT. And we try to deliver this type of intervention based on the bike exercise, which included 90% of their peak power output followed by low intensity, more recovery phase, which repeated 7 times in about 20 minutes, a total of 30 minutes of session per week, a total of 8 weeks when they're actually receiving anthracycline chemotherapies. And we chose the high-intensity interval training because the high-intensity interval training has a greater benefits on cardiovascular functions and even with less time commitment. So, for example, if the high-intensity interval training of 30 minutes may elicit 60 minutes of cardiovascular function improvements compared to the moderate intensity level. And although it's called high intensity, studies have shown that this high-intensity interval training is safe in multiple clinical populations such as heart failure, coronary heart or stroke, or even testicular cancer patients. And because of the dynamic properties of exercise strategies, patients are more preferred and they have higher adherence to the prescribed exercise sessions. So, we're not just focusing on traditional cardiovascular risk factors, we also use the imaging modality, the echocardiography. And we compared to the exercise group on the left, compared to the right, on the delayed control who actually didn't do exercise during their chemotherapy treatment, we actually haven't shown anything within 8 weeks, which actually can be expected before that intervention. But we actually saw more specific evidence on the vascular function measured by flow-mediated dilation in the exercise group, which actually increased significantly within 8 weeks compared to the delayed control who actually didn't do any exercise during their cardiotoxic chemotherapies. Importantly, we also measured cardiopulmonary exercise testing to see the improvements in VO2 peak in cancer patients with the anthracycline-based chemotherapies. And I don't really need to emphasize the importance of the VO2 peak in breast cancer patients, which actually included not just the heart, but the lung function, and also blood and blood vessels, as well as the skeletal muscle function. And with the exercise intervention, we even just 8 weeks, we were able to maintain the VO2 peak measures in the exercise group with the 30 minutes of HIIT exercise. But the control without any exercise, their VO2 peak actually reduced significantly after the 8 week. This is not just shown by our studies, but there are multiple studies have shown that the HIIT, the high intensity interval training, actually has superior benefits over moderate intensity continuous exercise, even more severe heart conditions such as heart failure. And most studies that have shown and previously comparing the high intensity interval training compared to the moderate intensity or even combined exercise have shown that high intensity interval training is better than the moderate intensity exercise, improving peak VO2. And importantly, this high intensity interval training didn't really impair the adaptation of resistance exercise when they're actually simultaneously conducting the two different modalities. So now maybe we have answers that we can deliver the exercise with the resistance exercise, but also including aerobic exercise together. Maybe you can also implement high-intensity interval training in cancer patients. But the answer is not really simple because there we have more challenges in these populations. And when we look at the data from 1975 to maybe until recently, we have about 80 million cancer survivors in the United States, which actually is projected to be about 26 million by 2040. But if you look at the graph more closely, these patients are much older. From the green to above is the age of 65 or older. We have more prevalence of aging cancer patients in these days. So when we have the aging cancer patients, especially it's a concern with the hematological cancer patients such as leukemia, lymphoma, and myeloma. So these cancers are more aging-related cancers. And these patients are mostly likely to receive the hematopoietic cell transplantation called HCT. And this HCT is actually very successful to improve their survival rates. If they actually receive the treatment and survive first 2 years, they're actually approaching their survival almost to the population level. However, these cancer patients with hematological cancers, they are having a pre-existing aging effect, but also the treatment effect, and now they become more frail. And when we talk about frailty, it's not just weak, or they are not just having low energy, but also it involves sarcopenic effects such as unintentional weight loss and also exhaustion, also weak strength, and they also walk very slow. And if they have 3 out of 5 characteristics, we call them as a frail patients, and they have more frail characteristics compared to before cancer treatment. After we see more frailty effects because of the accelerated aging. So why does this matter? Because frailty involves multiple health-related outcomes, especially adverse effects. So this is a large study, over 300 patients who actually have pre-frail or frail. And when you look at the data, the frail patients, when they don't have any cardiovascular disease or cancers, they have much higher prevalence of hypertension, type 2 diabetes, and other cardiovascular risk, also dementia and lung disease, and even arthritis. And even when we look at the hospital data, they have more hospitalization, also emergency visit, and also more hospital admissions than the major cardiovascular events and deaths and myocardial infarction, and even other severe cardiovascular outcomes in these frail patients. More specifically to the cancer patients, this data is coming from City of Hope, where I worked previously, that we look at the patients who were who actually have the hematological cancers, who also treated with the hematopoietic cell transplantations. And with the transplantation, which is a standard therapies for this hematological cancer, they are having much higher prevalence of frailty, 8 times higher. And even look at the data with the frail patients compared to the non-frail patients, frail patients have about 3 times higher all-cause mortality compared to non-frail hematological cancer patients treated with the standard therapy. So because they are very frail, they don't want to move, they stay at home mostly under their bed or couch, it's very hard to deliver this type of exercise, especially if we require them to come visit center-based exercise programs. And recently, we have more technologies available to deliver the exercise interventions. We call it telehealth exercise interventions, and there are now more studies or evidence that comparing these two types of exercise, showing that we have a similar reduction in risk factors in telehealth exercise and hospital-based exercise programs, but also we can also improve similarly compared to the traditional center-based exercise program to improve functional fitness level or risk factors and quality of life in telehealth exercise programs. So this is an example that our team's been doing the telehealth exercise programs, especially for the cancer patients. We utilize pre-recorded videos, and also we prescribe this pre-recorded video uploaded to the Telos exercise platform. So the patients can have access to the platform, and whenever they can do exercise, they can watch video and they can follow it. And also we offer a real-time exercise session as well, where we actually meet on Zoom or other video conferencing method to teach and monitor their exercise when they're exercising. And this is not just doing exercise remotely, but we also utilize Bluetooth-enabled sensors such as blood pressure monitor and also heart rate monitor to track their physical activity level, but also intensity-wise, we want to see they can meet the prescribed exercise intensity with the wearable devices. And we also utilize gait sensors, so we're not just focusing on the supervised session, but also we want to know if they are exercising more after we finish the supervised exercise session as well. And this is not just, we really don't need like a specialized exercise machine, because these patients are mostly weak. We can actually utilize simple exercise equipment such as exercise tubing or resistance band or loop band. We can also deliver and ship it to the patients. And what about the outcome measures? So patients, whenever we want to know the outcomes pre-post exercise interventions, we want to know if we can really improve their function. And even their function-wise, we don't have to require that the patients visit to the center. We can ship the Bluetooth-enabled sensors and also other equipment, and they can actually measure the physical function or gait speed, balance, or hand grip strength, and blood pressure, and heart rate monitor at their home or wherever they choose to measure. And also we can simply utilize the Telos exercise platform to get the patient-reported outcomes such as fatigue, pain, and quality of life. So we wanted to know if this is really feasible in specifically the frail cancer patients. And we recruited 20 frail cancer patients, mostly about the mid-60 years old age, a little bit overweight of the exercise group, and female and male patients who actually received allo or auto transplantation. And the frailty characteristics, they have no energy, they're very tired, and they walk very slow, and also they have no strength, or they're very weak, but not really having low BMI. When you look at the feasibility with this exercise interventions with the Telos exercise technology, we have shown that these patients, like older frail patients, can complete remote assessments. They're like, for example, like physical function and gait speed, etc. And most of our patients were retained over the 8 weeks of exercise interventions, and the exercise group specifically, 9 out of 10 patients met 70% of prescribed exercise sessions, and also the exercise intensity, which actually showed 94% of compliance within 8 weeks of exercise interventions. With the more physiological outcomes, we want to know if this is really improving the health-related outcomes. Although we measure multiple outcomes, mostly the gait speed was significantly improved after the 8 weeks of exercise intervention. We may just think that, just walk a little bit faster than previously, but maybe it's just the obvious. But when we look at these frail patients, they are almost not able to walk by themselves. And when we look at the patients after the 8 weeks of exercise, we can now see that they can walk more independently, and also they can walk more faster, which actually also shows more clinical significance of these patients. But control group, we don't really have any improvements in these populations. So this is really a small data set, but from now on, we are trying to move more larger trials to see more beneficial outcomes, not just gait speed, but also strength or other frailty-based measurement. So just in summary, I wanted to show how we could implement the exercise and what kind of exercise can be delivered to the patients. And even we were able to show that traditional conventional type of exercise such as resistance or so moderate intensity can improve traditional type of exercise. But also we have more evidence on the high intensity interval training in cancer patients. But when we look at the frail patients, it's not really easy, straightforward method to deliver the high intensity interval training to the frail patients, because we have more frail patients who are unable to follow the exercise prescriptions. So we want to better stratify their risk factors, especially before participating their exercise programs. And based on more specialized or in more specific stratification strategies, we can individualize exercise program and better, and also with more technologies, with the telehealth exercise technologies, with monitoring or intervention strategies, we can make them engage in the exercise program more successfully. They don't have to come to the center every time they have to do exercise. And lastly, I didn't really have time to show the physiological mechanisms, but we want to better stratify the risk factors and individualize exercise programs based on the physiological mechanisms as well. So I'd like to highlight, lastly, that we now have the telehealth exercise strategy, but also center-based exercise program also has own benefits as well. And with this combined exercise programs, the hybrid model may be able to improve the survivals and health outcomes in these cancer patients, specifically targeting cardiovascular health and also frail cancer patients. So thank you for your attention, and this is my end of my talk. Thank you.
Thank you, Professor. We will have a Q&A session after the three speakers finish their presentation. I apologize that I missed introducing the titles of this session. This session is about the innovations in exercise oncology and monitoring and prescription. And I'd like to introduce the next speakers. Professor Kang Dong-woo. He is professor in Fred Hutchinson Cancer Center, Seattle, USA. And he was a PhD in University of Alberta, PhD in faculties of kinesiology, sports and recreation, behavioral medicine laboratory. He will present anti-cancer properties of exercise, insight from the clinical research. Dr. Kang, please.
Thank you so much for kind.
Pleased to give a talk here, and thanks for organizing this important symposium. I'm very excited to share some of my my special interest in some particular topic in exercise oncology, and then I'd like to share some of those current evidence in this particular topic. So just a really quick disclaimer, I haven't started my position at the Fred Hutch, but I am at the Dana-Farber and Harvard Medical School at the moment as an instructor, but I'll be starting next year. So it's a really quick disclaimer. So the question regarding what exercise can do with the cancer outcome is really about the what exercise can do in terms of mechanistically to do with the cancer progression, the tumor itself. When I say cancer progression, it can mean about the tumor sizes or cancer recurrences or metastasis, and whether exercise can improve treatment-related outcomes, and it can be treatment response rate or adverse events. So we do have some evidence, particularly in epidemiological evidence. We have quite a bit of evidence in epidemiological data and also in animal studies, but we do not know a lot in clinical settings that I'm going to kind of summarize as concise as possible. This is a larger topic. So really briefly, in epidemiological evidence, there are a number of studies in different types of cancers. Also, there are some meta-analyses that are pulling all this data together, and we see that there's a pattern. Not all cancers, but there are particular cancers that are benefited from physical activity, and then it's repeated in a multiple meta-analysis in the past couple of years, and we see some of those dose-response relationships in physical activity levels and mortality. How about in animal studies? So there are also a lot of studies in animal studies in different cancer types, but also there are some meta-analysis where they showed that the exercise was implemented and then tumor volume in animals have been reduced favorably in exercise groups. And there are particular mechanisms that I'm really interested, but really briefly, exercise seems to increase some of those hormones like epinephrines and norepinephrines that can mobilize particular immune cells in our body that can be also helped by some of those myokines or muscle cytokines that can be infiltrated in tumor cells that can kill them. That's one of the mechanisms, but I'm not going to go over everything. One of the other mechanisms or effects of exercise is to improve treatment efficacy. So these particular panel on the right side is showing that exercise was given with chemotherapy, and then it had a better outcome in terms of reducing the tumor volume compared to other combinations. And it seems to be there's an effect of vasculature. Effect exercise can improve tumor out of vascular size and then delivery of the chemotherapy. Maybe it can be combination, additive effects, but it can be also independent. So these are some of those mechanisms that can explain how exercise can improve tumor outcomes or treatment outcomes. But how about in human? So there have been approximately 300 articles published in this exercise oncology area, focusing on based on clinical trials. But most studies are focusing on cardiopulmonary fitness or the quality of life, other body weight or body composition. There's a few, or it's a little attention to some of those mechanisms, and then survival or tumor specific outcomes. So that's where I am very interested in, and that's where I think we could focus more on in our future exercise oncology trials. So now I'm going to kind of summarize what we know about these particular outcomes in exercise oncology. But before that, I'd like to show some challenges to do those studies in human settings. So some of those studies, we know that exercise if we want to know the exercise is beneficial in shrinking tumor, there's just very few window or limited detective tumor windows. For example, once you are diagnosed with cancer, then especially in Korea, most of patients are receiving surgery as soon as possible, maybe a few weeks later. And then there's a very limited opportunities to provide exercise within that period and to see the effects of exercise on that tumor. How about measuring cancer progression? So it is also very challenging if you want to know tumor, if exercise can change any of those microenvironment of tumor. Then we have to have the sample of tumor, but research-purposed biopsies of tumor is very limited because it may increase the risk of micro or macro metastasis. So it's not really preferred in clinical settings. How about cost? If you want to really know the clinical events, when we have hundreds of patients in a larger trial, it costs a lot, and it needs a lot of human power to conduct those studies. So there are also some opportunities to see whether exercise can improve these oncologic outcomes. So there are some prehabilitation where there are patients who are not receiving, or they're having tumors, but they don't have any they have any treatment, so we can provide exercise when they have the cancer, or there are patients who are metastasized. So there are particular measures we can do to kind of measure if exercise has progressed, or cancer has progressed or not. And there are some other non-invasive measures like liquid biopsies and some imagings and some pathology or some of those medical records we can measure or induce some of those treatment outcomes. So this is a very brief summary that I put together, or the Dr. Carrie Corney had put together in terms of what we know about cancer progression and cancer outcomes. But there are many different scenarios where exercise can be beneficial, but I would like to just focus really, kind of put together really simply in this setting. I would like to show you the treatment naive, where those are patients who have not received treatment, and there are patients who are actively receiving treatment. There are patients who have completed treatment. So I just divided the patient groups into these three, and then I'd like to show what evidence we have in each of these 1, 2, 3 scenarios. So there are patients who have not received any treatment, and then what can we do in these patients to answer the question about the effect of exercise on cancer progression? There's almost zero observational evidence, but there are some growing evidence, including those patients who are on active surveillance, who are having tumor, but they are not receiving any treatment, just getting monitored until they have any clinical progression. And also there are some patients who have very low risk or very less advanced cancer. They are just getting monitored. And then there are particular liquid biopsy markers that we can implement in this clinical setting, where we are providing exercise interventions, and we can just monitor their liquid cancer progression outcomes. And sometimes we can also even use a tissue biopsy result to see if there's any changes in tumor microenvironment. And I'd like to show an example of one of the studies I conducted that's focusing on the patient with prostate cancer on active surveillance. And this study with these particular patients is very, very in a unique clinical setting where they are living with the cancer, but they are not treated. So they have a tumor at baseline, and then after, just before surgery. So we may be able to see the progression of cancer after exercise. So the hypothesis was that there are multiple biological pathways that may slow their cancer progression and can eventually improve their survival. So I was focusing on this pathway, just checking, seeing there's a liquid biopsy result or biochemical progression of those patients after exercise intervention. So I randomized 52 patients into exercise group and the usual care group, and they were given 3 months of exercise. I'd like to go over really briefly. So the exercise intervention was, as Dr. Kywan Lee mentioned, the high-intensity interval training, which I thought that it might be more beneficial in this population. And it was periodized. It was given 3 times a week. It was supervised setting. And the most interesting finding that I saw was there's a prostate cancer specific antigen, which we see it as a biochemical progression of tumor. And there's so this little yellow dot is usual care group, and this blue dot is the exercise group. Exercise group had a lower progression of this particular cancer progression marker. And then PSAV is the velocity, which is the direction and the speed of the marker is reducing. So there's a lower velocity in exercise group. in terms of this marker. And then we also looked at the cell line of prostate cancer tumor. It's very interesting. You can see the pattern. The upper panel here on the right side is the exercise group. And overall, exercise, the tumor cells, prostate cancer cell line in the exercise group had a lower progression versus usual care group. It's approximately 5% difference, which is statistically significant. I'm gonna really briefly that there's a particular mechanisms I think that might be explaining some of those cancer biochemical progression benefits of exercise, and one of those was we saw that there's an NK cell count, which is a natural killer cell count. Its immune cell was increased in the exercise group, and also their cytotoxicity, which is their capacity or their ability to kill cancer, was also improved in the exercise group significantly. And the second scenario may be the patients who are receiving treatment. So what we can focus on here is we can see if there are patients who received or did the exercise during treatment can live longer, or they may have a higher response rate to the treatment. And then higher response can mean they can live longer in their cancer survivorship. So one example was conducted by Dr. Cornier. It's one of the very first cancer outcome study. It was kind of exploratory study when it was first published. And then this study had a 3-arm. There's one group is aerobic, was given aerobic exercise, another resistance exercise, and the other usual care. But this exploratory study kind of combined these two aerobic and resistance groups and compared with the usual care group, and they followed for about 8 years. And then they saw if there's any differences in their survival rates. So on the left panel, it's the disease-free survival. And the exercise group, which is in red, had a higher survival, which is approximately 7.1%, although it was not statistically significant. But also on the right panel, it's a similar pattern for the distant disease-free survival, which is the metastasis-free survival. It's also showing a pattern that exercise might have benefits, but it wasn't also statistically significant. But we saw there might be a benefit, but we needed a better or particularly focused designed study for doing these type of studies. And there's another study in rectal cancer patients who are receiving neoadjuvant, meaning that they are receiving chemo and radiation treatment before they are getting a surgery. And then patients were given high intensity interval training and before treatment. And this group measured MRI after their surgery after 3 weeks, and then after approximately 11 weeks, week 14 after their surgery was over. It was a very interesting finding here that their tumor regression grade was lower in the exercise group in this light gray compared to the control group. Even though exercise was not done during this follow-up period, their exercise was done actually before the surgery, there was an effect that there's a pattern that exercise might have effects in reducing the tumor regression after their surgery. So there might be some lingering effect after the surgery. In another study that's published by Dr. Cornier was also another group of patients who are with lymphoma receiving chemotherapy. So there are two groups who are receiving, one aerobic exercise and usual care. And they were looking at the chemotherapy completion rate. And they see that there's exercise group is in light blue here, and they had a higher treatment completion rate, meaning that they had lower adverse events, or they might have completion, they have a better 100% completion rate in these patients who are receiving treatment, and the response rate was also higher in the exercise group. This is not particularly meaning that they can live longer, or patients who are doing exercise live longer, but there's indication that they may live longer, or there's a better clinical event outcomes. And in remission scenario, who has completed all the treatment, and I'll really show that really brief, quick example that the Dr. Brown, who just presented, had a study there showing that in colorectal cancer patients who complete all the treatment, he measured circulating tumor cells is one of those cancer outcomes, liquid biopsy markers, and then he found out that their exercise groups, either at the low dose or high dose, they had a lower or higher or lower reduced CRC levels in the exercise groups, which is very interesting. I'm gonna skip this, a very similar pattern in a lot of colorectal cancer patients, but they looked at the cancer cell line. We saw there's an acute effect of exercise on cancer cell lines. So there are some ongoing studies in this particular topic, and just in summary, so there are very largely limited evidence in cancer outcomes in clinical settings. So we really want to focus more on this topic. And then there's an infinite number of scenarios where exercise can be implemented. So we can provide those, kind of think about these scenarios, and then also consider what the types of exercise and intensity of exercise or doses or exercise can be optimal to exert the best outcomes. And then we need to collaborate in this animal and observational and clinical studies together to create the more robust evidence in this topic. Thank you so much. It was very, thank you for your attention.
Thank you for excellent lecture. And also congratulations on your appointment as a professor. Next, let me introduce next speaker. Dr. Nam Byung-ho has been a CEO of the Institute of Advanced Clinical and Biomedical Hearings since 2017. He has had a very interesting career. He majored in French education for his undergraduate studies and in business administration for the master's degree. And he majored in mathematics and statistical for his doctorate. He began his career as a professor at Boston University in mathematics and statistics, and later worked as a biostatistician at several famous research institutes. And then he worked the National Cancer Center as a researcher and professor in Korea. Yeah, he has very interesting careers, and please give us a lecture. Yeah.
Thank you so much for a nice introduction. I have a quite interesting background because I learned French language at the college, and I did study also business administration as a second major. And I went to the United States instead of France, and I did get an MBA degree. And I was fascinated with the statistics, so I went another master's degree for biostat, and I went to Boston University for biostat PhD. I was really blessed and fortunate to have a faculty position at Boston University, and I was involved in Framingham heart study that Professor Lee mentioned for about 10 years. I developed many risk prediction models for cardiovascular disease like stroke, coronary heart disease, and I was invited to National Cancer Center, and I worked there for about 12 years. And now I'm running a small company, Digital Therapeutics, and I'd like to introduce some of the works that we are doing. And my presentation is not scientific at all. So I'd like to introduce some kind of direction in the way we treat and interconnect with cancer patients in the future. So my topic is remote patient monitoring solutions for cancer patients. So we know that digital health is a big landscape. So this cartoon is generated from Digital Therapeutics Alliance several years ago. And then we have 6 components. Mobile health, we know it. And digital therapeutics is one of the rising area. Especially this digital therapeutics should be based on clinical evidence to be introduced to patients or whoever use those. And we know that health information technology and devices, sensors, and wearables, and also personalized healthcare and telehealth. So remote patient monitoring is part of personalized healthcare and also telehealth. This cartoon is introduced from JCO, that's the official journal of ASCO, American Society for Clinical Oncology, that they actually embraced this digital health technology for cancer patients' management and care. And they know that this recent technology should be incorporated into a long journey of cancer patients. So we know that how will digital health technology help? So integration of digital health into healthcare screening, monitoring, management, follow-up, and support for cancer patients. So it can reduce cancer care inefficiencies, including improving clinical research quality and so on. So they want to provide an official embracement and incorporation of this digital health technology into their regular medical care system. So this picture shows the future process of getting information and do some analysis using AI algorithms and then deliver the solutions to the cancer patients and generate information again and then be delivered to the cancer patients. So this circulation of the process would be the future direction. And they even revolutionize these cancer patients using this digital health technology. This cartoon was generated by this landmark trial. There's Ethan Bash. He's the medical oncologist in North Carolina for breast cancer. And he is a medical oncologist. So he treats cancer patients, especially with the breast cancer. And for chemotherapy or other therapies, we all know that the period of time that patients stay at the hospital is not that long. Most of the time they stay at their homes or outside of the hospitals. And they realize that they have to get some information about the adverse event or symptoms that patients have everyday life, but there was no way to collect those information. So he started to use internet to provide a sort of guidelines to his patients that whenever his patients realize the adverse event, then go into internet and just click what kind of adverse he or she experienced. And he collected all the data, and then he finally designed a randomized trial, very large, like about 800 patients with advanced cancer, including breast and other cancers. And then this is the first report from that trial. So this is just a diagram that computer experienced and the computer inexperienced stratified and then randomized into internet intervention or usual care. Usual care means that every time patients can visit hospitals, then doctors ask questions about symptoms adverse event. And even they collect the blood and then hematotoxicity is collected, but everyday life adverse event was collected through this internet intervention. And this is the first graph of the result. It was emergency visit. As you know, regardless of computer experience, those who have this very active intervention through internet has much lower number of emergency visit. So that's the first major report. And later on, he presented this result as plenary session at ASCO in 2017, and it was published in JAMA. And he compared the overall survival. And we saw that there was significant improvement from this internet-based intervention. So from this presentation, I think ASCO decided that, oh, this is great. So drugs or other treatments only are not really good enough for cancer patients. So total care approaches should be implemented for their cancer patients. So I know that 2 years ago, NCI, that's the leading institutions, and FDA, and also leading 50 academic institutions have this alliance, and to decide that this remote patient information should be implemented into their regular medical information system. So they are doing a lot of different researches to actually how to really validate the data and then how to incorporate the data into their regular medical system. This is another very interesting paper. Excuse me. There are many solid cancers that we cannot really have a symptoms of recurrence, but lung cancer has several symptoms that we can detect when patients have recurrence. So Israel company developed a scoring system for detect whether patients have recurrence or not. And then especially for lung cancer, the usual treatment is either targeted therapy or immunotherapy or other cytotoxic treatment. They have a cycle, like a 3-week or 4-week cycle. So every 2 cycles, they have pictures like MRI or X-ray to detect whether patients have recurrence or not. So the regular practice is 6 to 8 weeks is the period that they can detect. But here in the scoring system, they check every week. And if patients have high score continuously in 2 weeks, that it means that these patients has recurrence. So they compare either 2 weeks or 6 or 8 weeks. And they randomize it. And then they finally showed that overall survival was increased. Early detection of recurrence and then provide earlier different treatment for cancer patients who had a recurrence, then the overall survival was increased. So this device we call this digital therapeutics to detect lung cancer recurrence, and it was endorsed in France, and then now it's implemented into regular practice for cancer patients in France. So we know that there are many different areas that we have to consider as a personalized approach, especially nutrition, symptom management, of course, exercise, and other mental and psychological status. So my company is a small company and is AI-driven personalized healthcare platform company. We develop different remote patient monitoring solutions. Remote monitoring, patient monitoring is collect the data and then deliver that data or information into medical staff, so healthcare providers, and then they can provide some kind of care or management action to patients in a remote fashion so that patients can have benefit from it. So we collect 2 different sources of the information from patients. We know that there is a My Data project from the government, so if patient want, they can collect their own data. And also, we can generate some kind of data from EMR. And also, the software application that we developed, we can also collect information. So we just all this data are incorporated into one big data structure, and it was saved as a blockchain base. And then we developed, many different AI algorithms to provide appropriate solutions to the patients. So this kind of data is delivered to medical staff, and then they evaluate all the information and then provide appropriate care actions. The first trial that we did was for gastric cancer patients. We know that some of the previous speakers presented about the gastric cancer. Because this cancer is detected early, like a stage 1 or stage 2, so surgery would be the main treatment, either total or partial gastrectomy. So after the patients are stayed in about a week, and after the surgery, then they have a 1-hour session saying that you do not have a stomach, but your body weight was seriously reduced, so they have to gain back their weights. So eat good food with enough calorie and proteins. So patients and their family members understand the principles, but the question is, what is the best food that I can have? Then they search the internet and watch YouTube. So the first question that we had was, we have to develop a personalized nutrition dietary guides for each individual cancer patients. So we spent about 1.5 years to actually all this literature review, and then divide it into personalized guidelines for each different solid tumors. And then up to like 3 or 4 years ago, gastric cancer cancer was the most prominent cancer in Korea. And so we worked with Professor Han Kwang-yang. Recently, he was appointed as a director for National Cancer Center in Korea. And then we we decided to perform a small pilot study to evaluate our program, personalized nutrition guideline, is feasible, and then also can reduce increase the weight faster than the usual care. It was quite successful that patients and then surgeons really loved the program, because for patient side, after the surgery, they spend about 2 and 3 months, and then they come back to hospital to visit the doctors, and then doctors have 3 to 5 minutes, ask several questions. How are you doing? Did you get some weight? So how was the food you had? But there was no really enough information to discuss with the patients. But in this trial, we provide every single information to medical staff. So before the patient visit to the hospital, doctors already know what kind of food the patients had, what kind of symptoms they had, and what is the track of the body weight pattern. So they didn't ask questions. You are doing good. Let's try a little bit more harder to get more calories and proteins. So the patients really loved it. So especially Dr. Yang actually wants to introduce this intervention as a regular practice, because they think that after the surgery and about in a year and a half, they will really want to have patients back into regular body weight, but they cannot do it because patients are out of the hospital. So it was quite successful, and then we are designing a randomized solid clinical trial to actually compare this personalized intervention, nutrition intervention, versus the usual care, so that we can have many clinical benefits. So our software includes these personalized nutrition guides, having 4 actually important steps. First one is nutritional diagnosis, and then based upon this nutritional diagnosis, we provide a personalized diet, and then after patients get back with their information, then we analyze and then give them a report. And also we have a community so that patients can ask questions and then our experts provide answers to them. There's a little more detailed description. So cancer information and also their personal life information is got together. And then we come up with the goals of nutrition with especially many calories and proteins. And then we actually show them, this is your information and this is your target. And then we provide 3 meals and 3 options for each meal, and then 2 snacks. And they can switch because the food base is from Korean FDA. We have about more than 90,000 foods, and then we carefully selected about 4,000 foods, and then we use the national research data, and then come up with an algorithm so that patients get the food they enjoy and they can have. And this is just a measure of the food they had. First, we thought that taking pictures of the food, but it was not really efficient, so we just provide a simple way to measure the amount of food they had. And then we provide information, this is the goal, and this is the amount that you had, and some persuasive statement to help them to actually have the food that we provided. This is just 2 examples. We found out that the male patients are not really following the instructions, but they have their own reasons. So we try to keep pushing them to actually stay on the guidelines and then stay healthy. And also the second one was breast cancer patients with a little bit over 60 years old. Obesity is one of the risk factors for breast cancer when they are old. So especially this patient is a little bit overweight, so we try to actually push her to lose her weight, losing less calorie and less proteins. And later we actually expanded to not only the nutrition but other modules. So we provide not only dietary analysis recommendation, but also we collect their symptoms and any adverse events or other information. And also we provide a platform to help them to track their drug taking and also a hospital visit. And the only component that we have for exercise was their walking information. There are other softwares that we developed. So Osteocare is especially for colorectal cancer patients. There are about 31,000 new cases every year, and about 8,000 to 10,000 patients have to have ostomy. And then at least like 1.5 years to some patients have to wear for their lifetime. And it's not easy for them to maintain their usual daily life. So we developed a gateway software. There is a pilot government program to actually, help these patients have services remotely from the hospital. So they provide information about their photos, wound photos, and their situations, and then the nurses or doctors actually see and evaluate the status and then provide an appropriate care action. And this action is reported to, Shinpyeong-won, and then they can be reimbursed. So we actually get an approval from Korean FDA because this is a first-class gateway software because they consider this wound photos as a medical information, so we have to have an approval. And then actually we are planning to implement this Osteocare in Luxembourg in Europe next year. So they're very much interested in incorporate this software to their country and then later expand to Europe. And we have different other ones. And the last one, risk prediction models, is for cancer prevention. So when I was in National Cancer Center, we developed many different risk prediction models for solid tumors, especially pancreatic cancer. The risk factors are very, okay, I'm sorry. Yeah, okay, 1 minute. So, exercise. We know that know that exercise is related to cancer prognosis, right? So I'll skip it, and we know that exercise is really good. But what is the definition of physical exercise for me? We need to have a personalized approach to physical exercise for individual patients. That's the approach that we are thinking of. Especially we are interested in sarcopenia for breast cancer patients. And this is just the algorithm that we are developing right now. And especially the resistance exercise is good for managing the sarcopenia. So we are developing 30 to 40 different modules, depending on their intensity, frequency, and the volumes. We know that sarcopenia is a prognostic risk factors. So, and we know that how to measure the sarcopenia, in a usual practice for CT. And this is just Asian guidelines, and also this is European guidelines. So we incorporate these two guidelines into the evaluation of the sarcopenia. And then this is just rough draft of the design. So we like to actually come up with the modules, and then we like to implement these modules to advanced breast cancer patients, and then to see the feasibility of the device and also see some clinical effect of reducing the sarcopenia burden. Thank you so much.
Behind the schedule, as we all understand, lunch is the most important thing for today. So the floor is open for quick questions. Yes, please.
So I have a question for the first two speakers. One of the things that I did not see you speak about was the pool of people from whom you drew for your trials. And so I am very concerned in the field of exercise oncology. I don't know what to do. That we're talking to ourselves, and that a good proportion of patients are not interested. And so, in particular, I don't remember which one of you presented a consort diagram that had 176 patients. I think it was Dong Wu. 176 patients, and then you randomized 50. And I want to know what happened. But for both of you, I'm very interested in, did you talk to 1,000 people to get 20? Did you talk to 100? How many did you talk to? And what do you think is going on with this issue?
So I guess I can answer to that specific question first. So I would say, like in general, in exercise oncology, I think 30% plus minus is more regular recruitment rate from the eligibility patient who are randomized. So we also had a similar percentage, and then 170. The most common reason they were not getting into study was the distance. They're not interested in coming to our center. So the study was more supervised setting. So patients has to come to do the exercise 3 times a week. Plus, there's a baseline and post-intervention assessments. So they seem to feel like there's too much burden to do those supervised settings. So, in fact, there's consequent trials I'm doing right now is mostly done remotely, and then I guess a lot of exercise oncologists are doing those type of remote type of exercise right now. So that's actually removing those barriers. And then another important reason was that the lack of time. They're too busy to do. So that's something that we haven't really studied or haven't really resolved, but there's something that we have, it's really complicated. It's that there's awareness, and then there's a lot of push to the patient to do the exercise, but there's something else we need to make it better.
Yeah, to just follow the question. Yeah, I think the question is more likely because some patients are really not interested in participating in exercise trials. They don't want to do it because, as Dr. Kang said, they have no time for certain cancer patients. They already got back to their work. They also don't want to do exercise at all. But I think it really depending on the cancer population too. I mean, the first trial that I introduced, the breast cancer patients who recently completed cancer treatment, they were more likely to engage the cancer exercise trial. But the last trial that I shared, the cancer patients they already are working and they're not receiving any cancer treatment. They are just having their normal life, they think. So I think that's maybe the reason why they don't exercise. But yeah, I think that it's more like a bias, right? I think the question was really, because we recruited patients who are just interested in exercising, right? But we are not really targeting someone who don't really want to exercise. And how can we deal with these problems? And to be honest, I don't have a good answer to that question. It's a simple question, but very complicated. Answer we can maybe have more approaches. So I mean maybe some theoretical models we could maybe try, or some other innovative approaches, and we could try. But so that's why I also did the telehealth exercise trials so that we could remove the geographic barriers. But to be honest, I don't know what to answer for that questions.
I have a question for Dr. Nam. In the afternoon session, Dr. Lee, Ji-won, will be talking about the beneficial roles of Mediterranean diets for cancer patients, as well ketogenic diets, which is a low carbohydrate diet, has been shown to be beneficial to starve the cancer cells. So you mentioned about best diet. So what would be the best diet from your perspectives in general?
That's a good question, a very hard question. I think most cancer patients have problems with appetite, especially are under treatment. They lose their appetite, so they want to eat, but they cannot really eat well. So my first principle is good, enough food with enough proteins and calories. Those are the best diet, but also try to have the food they can have their usual day. Like if they can cook, it's fine, as long as it's have a good process of making food. I think that's the best diet. Because the algorithm that we developed, we used this national enhanced result that they showed, what kind of food Korean people really like and also frequently have. So as long as they have enough calories and proteins, I think those are the best type.
As well as glucose and ketone index, have you thought about it?
Oh yes, of course. Yes, it's a very important factor. But we are thinking we cannot really solve the problem at once. So we gradually develop considerations that we have to incorporate into develop a better dietary guidelines. So glucose is one of the one, and there are other factors too, because depending on the cancer type, there are certain foods they can eat or they cannot really have it. So many considerations that we have to have in order to come up with the appropriate best diet.
I also have a question to Dr. Byung-ho Nam. First, thank you very much of your enthusiastic presentations. I'm really impressed of you. You're developing the prediction model using deep learning technique. And I want to ask you the general question of the description of the deep learning of the technique that you developed. And second, in general, in the prediction model. So indicators like area under the curve or sensitivity of the specificity, the indicator of the prediction performance of the model, as I know. So I'm gonna ask you is there any method that you examined of the statistical method to verify the performance of the deep learning model technique?
Yeah. I think evaluating the performance of risk prediction model was my PhD thesis. So when I performed a statistical analysis, either it's a cross-sectional study, then you use mainly a logistic regression model. And if you have a survival data, then you use like a Cox or other survival models. When I first began to think about my thesis topic, there was evaluation criteria for logistic regression. But survival data is quite different compared to cross-sectional data because we have a time variable. So the criteria is two. One is discrimination. The other one is calibration. Discrimination is that once you have a higher risk, then the prediction model should produce higher probability, right? So that's a discrimination. And the calibration is real cancer event rate. For example, if we have a 200 out of 100,000 cancer patient and cancer event for particular cancer, then event rate was about a 2%, right? 0.2%. So once you develop a prediction model, and then usually prediction model produces probability of having cancer in like 8 or 10 years, and those probability should be very close to actual incidence rate. If you overestimate or underestimate, that causes serious problem. So discrimination and calibration is a two-part of evaluating your prediction models. So you know the statistics, the concordance measure for logistic regression, that's the usual measure for discrimination. And I developed a new method. You can look at the literature that this method is called Nam's method because we already published my method. And it is incorporating time situation in a survival analysis. So it's expansion of disease statistics. And calibration is another factor because, for example, United States, there are about 30% of cardiovascular event once you have 40 years or older. But for those who live in the United States but have Asian blood, they have a lower incidence. For example, Hawaiian cardiovascular study shows that much lower incidence rate compared to American. Then if you just use the model based upon American people, then you cannot really use it because it overestimates. So there's some calibration method to adjust your model to the target population. So there are those two areas that you have to consider in order to evaluate the prediction model's performance. Do I answer the question? Right? Okay, yeah.
Any further questions? Just last.
Very simple. I asked Professor Kang.
Yes.
So, your data is very good, great your data. Thank you very much. So a very simple question. So high intensity interval training is very not easy in general population in the case of. So during the experimental trial, if you have some problem, please comment.
That'll be really quick. So we did have some problems. Mostly, approximately 60% of our population has some type of arthritis or arthritis in that prior to coming into the study. So there's some patients who have exacerbated symptoms with the high intensity interval training, which was done on treadmill 100%. So there's no bike or other elliptical options for my particular study. So that was one of those kind of side effects from doing high intensity interval training. Now we do have more, right now I have more studies using bikes and other options for the patients to eliminate some of those side effects. And I just wanted to kind of reiterate one more thing regarding this is that many patients are kind of afraid of doing those high intensity exercise initially. But after doing that, we also have some other data, the motivational data that participating in it was much easier than they thought, and it's much doable, feasible, and more enjoyable than actually moderate intensity exercise. There's some other more data that's out there too. So that we wanted to eventually, like Katie mentioned, we wanted to disseminate eventually to as many patients as possible. So we have to kind of consider those things into disseminations in the future. Thank you.
Yeah, I would like to close these sessions, and please give the big hand to three presenters.
네, 안녕하세요.
Hillman Cancer Center at the University of Pittsburgh and the leader of the survivorship program at the Hillman Cancer Center. And throughout her career, Dr. Schmitz has held numerous prestigious positions, including president of the American College of Sport Medicine and clinical research professor for the American Cancer Society. Dr. Schmitz has led numerous groundbreaking clinical trials that have transformed oncology care by integrating exercise as a vital component of treatment and survivorship. Her work has played an important role in advancing the field and shaping the new standards in oncology care. Today, Dr. Schmitz will share her valuable insights in her presentation titled Exercise Medicine in Oncology, Evidence and Translation to Practice. Please welcome Dr. Schmitz.
It's so hot in here. It's so hot. Okay, all right, and we're postprandial, so God help me. Please stay awake. I came so far to speak with you today, so anyway, hi. I am so glad to be here. I am falling in love with your country. I will very definitely accept any invitations to come back, and I'm delighted to have the opportunity to speak with you today about what I care most about, and that is exercise oncology. I'm jumping right in. There's no intro slide. I'm jumping right in here. And what I want to jump in with is to talk with you about what happens if a drug is developed. So if we go through the process of developing a drug, the first thing we do is we do preclinical work in order to find the pathway and the mechanism that we think we can change in order to be able to treat cancer in our case, and then we do phase 1 trials. Those are the early human trials where they're very small and they're looking at dose finding, and they're interested in tolerance to the drug and whatnot. And then phase 2 trials are slightly bigger. And then in phase 3 trials we do large. You actually heard Justin Brown, who was my doctoral student, talk about a phase 3 clinical trial that he linked onto with an observational study. And that was a large phase 3 clinical trial that was trying to approve a particular chemotherapy regimen, FOLFOX with celecoxib. Then if you are lucky enough to be done with all of that, then you go through, in the United States, you go through FDA review. I'm sure there is something very similar in Korea. And then when you've done all of that, you can then release your drug and you do surveillance studies. And there is something called the Valley of Death. Very dramatic. And the Valley of Death is when you have developed your drug, but you actually can't quite get it past the finish line to getting it approved, or you even have it approved, but it's not getting used in clinical practice. And so there is that issue, but this is a well-described pathway, and it's used over and over again for drug development and for getting new drugs into the market. Now, I just want to remind you, though, that if you're developing a new chemotherapy drug, you know that when you've developed the drug, that there are nurses ready to hang the bags of chemotherapy. You know there's a place in the hospital where people go to get chemotherapy. You know that there's an entire infrastructure that is there in order to deliver the chemotherapy. So what's the equivalent for exercise oncology, for any behavioral intervention? And I had a lovely conversation with Justin about the fact that we are, by definition, exercise oncology researchers are behavioral researchers, because exercise is a behavior, and getting people to change their behavior is a challenge. And so what is the behavioral equivalent for all of that work that I just talked about with developing drugs? Well, we start with a significant scientific question on the left side of the slide. And then in phase 1, we define and refine the intervention. And then in phase 2 preliminary testing, we do proof of concept and pilot studies. And then we get to our phase 3 efficacy trials. And then we get into effectiveness and dissemination and implementation science research. So that's the way that we go from having developed an idea and come up with an idea and go all the way to the point where supposedly things are implemented. Well, let's see how that works. Let's see if that works. And I'm going to use as my exemplar here physical activity and lymphedema, breast cancer-related lymphedema. You heard a bit about this earlier this morning. So I'll be talking about the work that I've done in this area. So we start with the fact that advice to breast cancer survivors was to avoid using the affected limb, and that significantly and negatively affected function and quality of life. When I started my career, the Susan Komen Foundation, the National Cancer Institute, the American Cancer Society, and the National Lymphedema Network, all in the United States, all gave advice to women never to lift anything heavier than 5 to 15 pounds ever again in their lives, which is problematic. My babies weighed nearly 10 pounds when they were born. So how are you supposed to live your life and care for your children if you can't lift anything heavier than 5 to 15 pounds? So the early work in this space was done by some folks, some Canadians, Don McKenzie in particular, and some of his colleagues. And they did a case series called A Breast in a Boat. And this was 22 women who did dragon boat training and competition. And they did measurements of their arms before they started training and at the end of the training season. And what they found was that these women's arms were not getting bigger, they were not getting worse. And so lymphedema was not an issue for them. Don McKenzie followed that up with another phase 1 study, a randomized controlled trial with an N of 14 that was, believe it or not, published in the Journal of Clinical Oncology. It showed no harm from resistance exercise, contrary to the advice that was being given to women by their clinicians and by the American Cancer Society, the National Lymphedema Network, the Susan Komen Foundation, and the National Cancer Institute. So I came into the story about then, and I'm going to talk through with you what I did and the depth of the evidence base that exists in the space of breast cancer-related lymphedema and resistance exercise. So there were 2 major trials. One was the weight training for breast cancer survivors trial, which I'll talk through. We made revisions based on that. And then we did the PAL trial, which was quoted this morning. That's very cool. That was great to see the PAL trial. And one of my trainees, Jiachen Zhang, her work was highlighted in a presentation earlier today. And then we've gone on to do dissemination and implementation science research. So that should mean, if I go back to this, it should mean that it's all happening now, right? We've done all this work. We've done the implementation science work. It should mean that all women with breast cancer are getting this program now, right? Doesn't it mean that? That's what it should mean, right? Well, let's see. Let's see what happened. So as background, though, and you've heard some of this before, so I'll go through these slides pretty quickly. Lymphedema is a swelling condition. It's an abnormal accumulation of protein-rich fluid in the affected limb, and it can affect the arm, shoulder, back, or torso on the side of the body where women have breast cancer. It is chronic and can be progressive, and they may develop lymphedema from physical disruption of the lymphatic channels because of surgery, because of radiation treatment, or because of compression of lymphatic channels during treatment as well. So about 30% of the approximately 4 million breast cancer survivors in the United States have clinically diagnosed lymphedema. And the prevalence is 49% if we include self-reported symptoms of lymphedema. So this larger arm size that women experience with breast cancer-related lymphedema may change range of motion and function, impair fine motor function, decrease muscle strength, alter choice of clothing, and alter function in activities of daily living. And in fact, in one phenomenological study that was done in Scandinavia, what they found was that women would rather have a second mastectomy rather than have lymphedema because they could hide the mastectomy, but they couldn't hide the swollen fat arm. There are any number of physical, psychological, and emotional morbidities that come secondary to lymphedema. So the risk factors that you heard about earlier today, which are not particularly well described, My favorite publication on this is 20 years old. 20-year prospective cohort study of 272 breast cancer survivors found that arm infection, injury, and elevated BMI are associated, but interestingly, not associated in epidemiologic research as occupational and leisure time physical activity, which doesn't make any sense because the advice is don't do anything with your upper body after you have surgery for breast cancer and risk for lymphedema. So survivors are at increased risk for chronic disease and morbidity. There are a whole host of other things that breast cancer survivors are going to have problems with. They are at elevated risk for many chronic diseases, including cardiovascular disease, including osteoporosis, and including recurrence for their breast cancer. And exercise may help them with regaining strength and function and range of motion after surgery, as well as reducing risk for all of these other chronic diseases. Re-empowerment, having breast cancer feels like your body has betrayed you, and this is sort of a way of making friends with your body again, and quality of life, and of course the decrease in the risk of many different chronic diseases. But the clinical guidelines from the American Cancer Society, the National Cancer Institute, Susan Komen Foundation, and the National Lymphedema Network all said don't do it. They said don't do it. So this is very, very restricting for these women. And so we were interested in this question, this problem. So if you go back to the orbit model that I showed you, that is the model of, so you start with a significant clinical problem and you go through, sort of the phase 1, phase 2, phase 3, and the efficacy and dissemination and implementation work. So our problem was that survivors are limited in activity and rehabilitation, and they cannot attain the health benefits of physical activity. And there was physiologic evidence, and you saw some of this morning as well, that exercise may actually improve lymph flow and resorption. So the long-held clinical advice was to avoid overusing the upper body, to avoid onset or worsening of lymphedema. Frankly, that's still excellent advice, even today with the evidence that I'm about to show you. But unfortunately, the evidence or the translation of this does something that in the United States we call throwing the baby out with the bathwater. And that analogy is that, we should be careful about overuse of the affected limb, but unfortunately, telling women to avoid overuse translated into avoiding using the upper body at all, doing anything with the upper body. That then leads to further deconditioning of the upper body, thereby exacerbating the possibility that anything that these women do would constitute overuse and actually increasing the risk of onset and worsening of lymphedema. So the advice itself was actually counterintuitive to what needed to happen physiologically. One of the analogies that I like to use to explain the situation is cardiac rehabilitation. So if we take two people in Seoul and both of them have a heart attack, and then on November 26th it snows, which apparently it does in Seoul occasionally. And I have proof, video proof, in fact. So it snows, and they have to go shovel snow outside where they live. They have to go shovel snow, okay? And one person has gone through a program of cardiac rehabilitation, slowly, gradually increasing physiologic stress on their myocardium in order to be able to withstand any kind of stress and activity that they would need to do in their everyday life. The other person has not. The other person has done nothing. They've, used the remote control as their exercise. So they get plenty of thumb exercise, but no cardiac rehabilitation, okay? Both of these people go out to shovel snow. Which one is going to overuse their myocardium while they're shoveling snow? It's going to be the one that did nothing, the one that did not do any kind of cardiac rehabilitation training. So here's the analogy. The analogy is you take two women, they've both had breast cancer, they're both at risk for lymphedema. One of them does a slow increase in physiologic stress on her lymphatic system by doing a slowly progressive resistance training program, and the other one does not. and both of them go to the airport, ICN airport, is that right? Yeah. And they end up at the last gate in the farthest terminal, and the wheels break on their suitcase, and they have to pick up a 30-pound suitcase and carry it through the airport to get to their connecting flight. One of them has done slowly progressive increase in physiologic stress on the lymphatic system on the affected side through slowly progressive resistance training. The other one has not. Which one is going to overuse their lymphatic system? The one who didn't do the exercise training. So it's still outstanding advice to avoid overusing the lymphatic system, but avoiding using it at all is actually deconditioning that system in a way that means that everything constitutes overuse. So the phase 1 research that's been done in this area, I mentioned to you on an earlier slide. They were early interventions like the breast in a boat and like the small study that was done by Don McKenzie. And these observed no increase in incident lymphedema or increased symptoms in women with or at risk for lymphedema. But these studies were really limited in their methodology. There were case series studies, there were uncontrolled pre-post designs, and extremely small randomized controlled trials. So we came into this space to do the phase 2 work, this proof of concept work. And this was a study called Weight Training for Breast Cancer Survivors. It was funded by the Susan G. Komen Foundation. It was a randomized controlled trial on weight training for breast cancer survivors. 14 of the women entered the study with lymphedema, and 71 entered the study at risk for lymphedema. We did twice weekly strength training, slowly progressive strength training. The first 13 weeks were supervised. The second 13 weeks were unsupervised. And this was all done while I was on faculty at the University of Minnesota. The lymphedema outcome was that we found no risk of progressive weightlifting, and this was published by my doctoral student at the time, Rehana Ahmed, in the Journal of Clinical Oncology nearly 20 years ago. So we used that as the basis for one of the trials that I'm best known for, which is the PAL trial, which was really about balancing risks of deconditioning versus weightlifting for this population of women with and at risk for lymphedema. So our hypothesis, based on the phase 2 proof of concept findings, based on the phase 1 findings that came before us, was that supervised, slowly progressive controlled increase in physiologic stress, which is a very fancy way of saying exercise, through strength training may be more beneficial to breast cancer survivors compared to the inevitable acute stress that occurs because women carry things. We carry things all the time. So it's going to happen, so you might as well be ready for it. So the physical activity and lymphedema trial was a 1-year randomized controlled trial of twice weekly progressive strength training compared to a non-exercising control, with the primary aim to determine whether there were any changes in lymphedema outcomes. And it was one grant, but it was 2 trials funded by 1 grant. So one of the trials was in women with lymphedema, and they were randomized into treatment and control, the women with lymphedema, and one for women at risk for lymphedema. There are 154 of them, and they were randomized to treatment and control. These 2 trials were, trials were powered independently. So we did arm volume measurements and validated symptom questionnaires with water volumetry and validated survey. Body composition with DEXA, body image survey that was developed specifically for breast cancer survivors, and quality of life measurements. There were a lot of other measurements. We published a lot of papers coming out of this trial, but these are the ones that are relevant to what I'm talking to you about today. So just to tell you about who these women were, on the left side of the slide is the demographic data for the women who entered the study who already had a diagnosis of lymphedema. You can see that these women, as well as the women without lymphedema, were on average in their mid to late 50s. I'm very proud to show that we had real diversity in the cohort with regard to education and thus socioeconomic status, as well as race. This work was done when I was on faculty at the University of Pennsylvania. in Philadelphia, and the population of Philadelphia is majority African American, and so 35% of the sample of this trial were African American women. This slide is intended to document for you that at baseline, the women that we said had lymphedema really had lymphedema. So we looked at their arm volume by, does everybody remember, people have learned about underwater weighing? Has this generation learned about underwater weighing? Do you know about that? Okay, so think about underwater weighing for the arm. That's what we were doing, okay? So we had these lucite containers, and you would stick the arm in the water, and the water would come out of a spigot, and then you would measure how much water came out, right? And you knew how much water was already in the column. And then you would do the same thing with the unaffected side, and then you would look at the percent difference between the affected limb and the unaffected limb, and that's how you determine the severity of the lymphedema. And we diagnose, you heard this morning, differences of 3% would be a threshold for diagnosis of lymphedema. Well, we had women with 15 to 17% differences in the affected versus unaffected limb. Wow. Okay, so these are women with significant lymphedema that were in this trial, and there were no differences between the treatment and control group. And you can see in the women with no lymphedema that there really were no interlimb differences, 0.1, minus 0.3. So really negligible differences between the affected and unaffected limb. So we did 13 weeks of supervised exercise, just as we had with the phase 2 trial, twice weekly in small groups. We called the people who didn't show up to say, where are you? We need you here. And all of the trainers were trained by me personally to deliver this intervention. And then 9 months of unsupervised exercise, where we again called people weekly if they didn't come to the gym to do the exercise. We did monthly safety measurements with the water volumetry if they wanted to do it, or circumferential measurements, and monthly personal training sessions if they were interested in that. So this is what we actually did during the sessions. This morning it was quoted that it was a 90-minute session. Nope, it was a 60-minute session. They started with 5 to 10 minutes of an aerobic warm-up, range of motion stretching, and then we did 8 to 10 resistance training exercises for all major muscle groups. The secret sauce of the PAL trial was not the choice of the exercises. That was not it. The secret sauce was the slow progression. The whole idea, and you heard Dr. Brown talk about it in his talk, start low, progress slow. Start low, progress slow. That's the mantra here. We did do core exercises at the end because in my hands, when I have patients do strength training and they don't do any core exercises, we end up with back injuries. And then stretching for all major muscle groups. So they came, they really came. So this was done in community settings, and 88% of the sessions that were prescribed were completed in the women that entered the study with lymphedema, and 79% of the prescribed sessions were completed in the women at risk for lymphedema. That's really good adherence over a year-long exercise intervention trial. So strength changes. So I'm only showing you one slide here. I could show you two, but they were essentially the same. So these are the strength changes in women with lymphedema. Take a look at these changes. This is 1 repetition maximum, the most that you could lift once for bench press and for leg press. And we had about 30% increases. Oh my goodness, that's big. That's an enormous change. I actually did a trial before this called the SHE trial that did a very similar kind of strength training protocol that was not actually slowly progressive, and it was in women that were just slightly younger than the women in the PAL trial. And we saw changes that were about 16%, and so about half, a little more than half, of what we saw in the PAL trial. So my explanation for this is that the women who were breast cancer survivors had more to gain, that they had lost more strength, that they were more infirm, if you will, when they entered the study. And so we were able to show really substantive strength changes, thus documenting that the self-report of the attendants was in fact true. We showed similar effects in the women without lymphedema. So now for the primary outcomes from the trial. So there are a number of ways that you can measure lymphedema. And one of them is by looking at the water volumetry, so looking at percentage difference in the limbs, right? And we looked specifically at the proportion of women who had a 5% increase in interlimb difference, and we saw 0 difference between the two groups for this outcome. So that we were disappointed, but that was the truth of what happened there. What we did see, however, that was dramatic was that the proportion of women who required therapist-delivered treatment for a lymphedema flare-up, meaning they needed to go to the physical therapist and see the physical therapist for multiple times in the week over the course of many weeks, which, think about it right now, take your schedule, I know how busy you all are, and add 3 physical therapy sessions a week for the next 5 weeks. Good luck. How do you get that to happen, right? This is very, very difficult. It's very difficult to get women to go to this. So what we found was that 14% of the treatment group required therapist-delivered treatment during the year of follow-up, as compared to 29% in the control group, which gave us a cumulative incidence ratio of 0.47. So we cut the number of lymphedema flare-ups in half, which is a very clinically meaningful outcome. We also saw marginally significant changes in the number of symptoms endorsed and a small significant change in symptom severity as well. So then the women without lymphedema. It was completely null. It was all null. We did nothing to these women. They did not change in interlimb difference. There's sort of a small, like if you did this in 1,000 people, maybe that interlimb difference, 5% increase would be statistically significant. I don't know, maybe not, but it was null. So they were safe. And this was counter to the advice that was being given by all those major organizations in the United States. But when we did our phase 2 trial, one of the criticisms of the reviewers when we were publishing that piece in the Journal of Clinical Oncology was that we were falsely giving people hope because we were including women who had sentinel lymph node biopsy for whom the risk of lymphedema is very, very low. And so when we set out to do the PAL trial, we a priori decided that we would go back and look at the women who had at least 5 lymph nodes removed or more in order to see whether or not there was any greater effect in this subset. And so this is what happened in the subset who had 5 or more nodes removed. What we see is that the proportion of women who had onset of lymphedema, defined in my hands as a 5% increase in interlimb difference, which is even a higher bar than what you heard about this morning, which was 3%. So with 5% interlimb difference increase, 7% of the women in the treatment group had that, as opposed to 22% of the women in the control group, which gives us a cumulative incidence ratio of 0.3. That means that we had a 70% reduction in the likelihood of onset of lymphedema as a result of doing nothing but a twice-weekly, slowly progressive resistance training program. We didn't see any other changes in the other outcomes that we looked at. These findings were published in JAMA for the women at risk for lymphedema and the New England Journal of Medicine for the women who had breast cancer-related lymphedema at study entry. We've published 20 papers based on this trial. We've been publishing on this for a very long time. So the evidence summary is that twice-weekly slowly progressive strength training is safe for breast cancer survivors who have had lymph node removal, including those with and at risk for lymphedema. The risk for lymphedema flare-ups decreased by half among at-risk women with 5 or more nodes removed. The risk of increased arm swelling was reduced by 70%. We showed substantive strength improvements in all of the women, regardless of lymphedema background at baseline. Body image improved as well. I didn't show those data. I'm just summarizing here. And then Justin Brown had become my doctoral student around this time, and he published a paper in JCO in 2015 showing that prevention of decline in physical function as measured by the SF36 survey that we actually were able to document prevention of decline. So this was very popular news. So think about it. Women had been told not to lift anything heavier than 5 to 15 pounds ever again in their lives. And so the media went crazy. It was actually a lot of fun. I spent August of one year doing nothing but giving media interviews because this was such a popular bit of news for people. I was on the front page of the Science Times for the New York Times, USA Today, Wall Street Journal. For Time Magazine named this finding W in a year in review from 2010 for weight training for breast cancer survivors. So, broadcast news, online news as well. So we decided that we better disseminate. So remember the orbit model, and we had the proof of concept, and we have the phase 3 trial, and now we move on to the dissemination work. So how do we disseminate it? How do we go about doing that? The first thing we had to do is we had to go back and take apart all of what we had done with making the PAL trial happen in order to see what the secret sauce was, what the elements were, so that we could make it happen. So we knew that we needed a pre-exercise physical therapy evaluation. We knew that we needed high skill and training of the interventionists. We knew we needed a standardized protocol and an obvious system of referral back to physical therapy if there was a problem. We needed the slow progression of resistance, and we needed a system for what I euphemistically call exercise holidays, which is to say those times when women just sort of decide to stop exercising for a few weeks. So we didn't have those things with our YMCA partners. We did all of this work within the setting of YMCAs up to this point, and we realized that that was not going to be a good setting for us to be able to continue to do this work because they didn't have physical therapists. There was no obvious way to get people the compression garments and get referrals into the program, and we didn't know how to deal with reimbursement either. And we did have data from PAL that told us that women were not willing to pay for the YMCA membership after they were done with the PAL trial. They just stopped going to the Y when they didn't have the free membership anymore. So we sat down as a group at the University of Pennsylvania. I had some brilliant physical therapy colleagues there, and we said, well, what should we do? How would we do this? And we decided that the first thing that needed to happen was referrals from the oncology clinician to the PT clinic. And then at the PT clinic, we needed to have an evaluation with what was called a certified lymphatic therapist. It's a physical therapist. The women needed to be educated about their lymphatic system. We needed to teach them the protocol. It says 4+ sessions there because I'm sure that you all have encountered people who are more kinesthetically aware and people who are less kinesthetically aware. And if somebody really isn't getting the exercises, then we need them to keep coming until they learn the exercises and then discharge so that the person can do the program at home. We decided that the program absolutely could be offered by physical therapists, occupational therapists, athletic trainers, and nationally certified exercise professionals, but the only people who were likely to get reimbursement for doing this work were PTs and OTs. So we tested and compared the safety and efficacy of this new program called Strength After Breast Cancer. Cute story, turns out when we went in to the patients to say, would you like to do a program called Physical Activity and Lymphedema? The women who had lymphedema said, no, I already have lymphedema. And when we talked to the women who didn't have lymphedema, they said, no, I don't have lymphedema. They didn't like the name, so we had to come up with a new name for the program, and it was Strength After Breast Cancer. And this is an eye chart. I do understand there's a lot on that slide, so I'll summarize and say that the safety and effectiveness was maintained after translation into clinical practice. So PAL is now a clinical program called Strength After Breast Cancer. It's paid for by insurance in the United States. It's available in over 1,000 locations worldwide. And the online training, which is offered through Close Training and Consulting, is $125, and anybody can sign up for this course anywhere in the world. So it's in 1,000 places, and that's great. That's a success story, right? But it's not in every place. It's not everywhere. It's not disseminated to the point that go back to the original slide that I put up, the first slide I put up, right? So you develop a drug and you get it to the point where it's approved by the FDA and it becomes standard of practice, and then every hospital in the country is hanging that drug in their chemo suite. It's everywhere. This is good, but it's not everywhere. It's not everywhere. So we did ask the people who took the course to learn how to implement strength after breast cancer, whether they actually did it. And we had 96 clinician surveys, respondents. 76% of them said that they did, in fact, implement strength after breast cancer, and 93% of those were still delivering it years after they completed the course. They said they were delivering about 13 patients per clinician that was referring patients in. Most of the referrals were, in fact, coming from oncology clinics, and 72% of them said that they were finding that it was possible to get reimbursement for their work through private insurance. The primary barriers to getting this to happen were lack of referrals from the clinicians and competing demands. They have, many things that they're dealing with in cardiac rehabilitation. So it's a success, but it's a qualified success, right? So what would it take for this to be just as common as a new drug that is going to be hung, it's going to be used everywhere, everywhere, everywhere? Well, the pragmatist view of all of this starts with the fact that most people think that the PAL intervention, which was originally designed around lymphedema, is only valuable for lymphedema. That's not the case. We actually have plenty of evidence from the American College of Sports Medicine guidelines for exercise for people living with and beyond cancer that strength training has benefit for a broad variety of outcomes among breast cancer survivors. We also need to monetize it. We need to figure out how for somebody to make some money off of this, because one of the reasons why the drugs get hung is because the drug companies stand to make money off of them. We need to make referrals from oncologists standard of care and increase capacity of rehabilitation services. We need to address out-of-pocket costs. What we find is that the copays, I don't know if that's a concept in Korea. Is a copay a concept? Yeah, okay. So copays are very high for a program like this. We need to co-locate these programs with curative care, but ultimately the biggest challenge, I think, for getting this to be standard of care is that it is not associated with cure. It's a quality of life, it's a nice to have issue. It's, nobody wants to have lymphedema, nobody wants to deal with lymphedema, but it's not cancer. So the motivation to be able to deal with it, I think we have to be realistic with regard to what we will actually get cancer patients to do and whether they will actually come out and do a program like this, given the fact that it's not about cancer. So there has been an enormous proliferation of randomized controlled trials in the field of exercise oncology, largely starting somewhere in the mid to, between maybe, this is sort of a discussion point, between 2005, 2010, but really things took off after that first ACSM roundtable. And by the second ACSM roundtable, we'd had a 281% increase in randomized controlled trials. And if you were to go into PubMed now and look up exercise and cancer and look at randomized controlled trials in the English language, you would get over 2,800 hits. And the PAL trial results came right at the start of that join point when everything started to increase. So PAL was one thing. I've given you all of what I've given you so far as an exemplar, as a way of talking about how growth has happened in the field of exercise oncology. We start with a clinical problem, we do our proof of concept studies, phase 2 studies, our phase 3 studies, our dissemination research. All of those things have been happening. They've been happening for cancer-related fatigue, they've been happening for sleep and quality of life. They've been happening for anxiety and depression, body composition, function, and of course, what I've just presented, breast cancer-related lymphedema. We have the evidence base for all of these things, but what's going on? What are we actually making it happen, right? So, one of the ways that we try to push things is by issuing guidelines. And so I've talked to you a lot about the American College of Sports Medicine guidelines for exercise for cancer survivors, but we're not the only ones that came up with guidelines. The American Cancer Society published guidelines in 2022 that agree very much with the ACSM guidelines. And then in 2022 as well, ASCO issued a guideline as well that states, and I quote, that medical oncologists should refer patients receiving chemotherapy to exercise programming to address common symptoms and side effects. So we have all of these guidelines. It should be happening now, right? Further, I was very proud to be a part of the guideline development process for the National Accreditation Program for Breast Centers in the United States, which developed new standards, which were adopted in January of 2024, that include the requirement for breast programs to declare a plan for functional evaluations prior to surgery, radiation, and medical oncology, documentation in the medical record that the woman has been referred to an exercise program while she's under the care of a medical oncologist, and exercise referrals at the point of survivorship. So that doesn't mean that there aren't things for us still to study. There are still many things for us to study. And all of the things that are listed here are still outcomes that we still need to do more work. So if anybody needs a thesis topic or a focus for your research, these are all open for business. And the one that I want to focus on for the remainder of my talk is treatment tolerance. And what I want to show you are, I want to talk through what we're doing in the area of treatment tolerance in the United States right now. This is ongoing research, so I don't have results. I'm just pointing you to the future of where we're going with this. So in the US, there is an initiative that has been started by the National Cancer Institute called ENICTO, Exercise and Nutrition Interventions to Improve Cancer Treatment-Related Outcomes. And the primary goal of this initiative, $40 million initiative, is to evaluate the impact of diet and physical activity interventions during treatment on received or relative dose intensity and treatment toxicity. So I am very proud to lead one of the trials for ENICTO called Thrive 65, which I'll be talking to you about today, along with Dr. Jennifer Ligabell from Dana-Farber. And there are other trials that are ongoing within ENICTO as well, including one on ovarian cancer, one on colorectal and rectal cancer, and one specifically on colon cancer. And the coordinating center for all of this is George Washington University in Washington, D.C. So in order for me to talk to you about this, I need to explain this concept of received dose intensity. So this is getting us closer. I'm going to go back to my first slide and what I was talking about before. And what we really care about if we develop a cancer drug is, does that drug do a better job of treating the cancer? Does the person survive for a longer time as a result of having that particular drug regimen, right? That's what we really, really care about, right? And so we went through all of this work. I, spent a lot of time and energy working on breast cancer-related lymphedema, and we come to the end of it, and it's very difficult to get people to come and do anything because it's a nice to have. It's a nice to have, okay? But here, because we're focused on treatment tolerance, we're focused on the need to have. This is now affecting treatment. So what we're doing with received dose intensity is we're looking at how much chemotherapy the woman gets over how much chemotherapy they were planned to get. How much were they supposed to get, standard dose intensity. So relative dose intensity or received dose intensity expresses how much of a planned chemotherapy regimen a patient received, as well as whether they got it in the timing that was intended or whether there were delays in the schedule. We know that relative dose intensity is associated with breast cancer and recurrence and survival. On the left side of the slide is relatively recent data. This is a Kaplan-Meier curve that shows you differences in survival for women in green who received at least 85% of the planned dose intensity. And in blue, that was the amount of chemotherapy they got was less than 85% relative dose intensity. You can see that the curves separate somewhere around 20 months
after women are done with their chemotherapy. Now that's a relatively recent publication from 2020, but the reason I have it on the left and then something on the right is just to point out that what's on the right is from 1994. We've known this information for a very long time. Very similar curves on the right side from Wood and New England Journal in 1994. We also know that being over age 65, significantly predicts chemotherapy dose reductions and delays. We know that this is a population in whom we're going to have a difficult time getting them to a relative dose intensity of 85% or more. In fact, each of these columns is a study, and the average relative dose intensity in each of these studies. The ones that are 5 that are on the left are in older women, and the 2 that are on the right are in younger women. So if you just squint at it without any statistics, you can see that we're getting better relative dose intensity in the younger women than the older women. The other thing to note is that across these 5 studies, only 50 to 76% of breast cancer patients 65 and older receive a relative dose intensity of 85%. So if we're going to do an exercise intervention, if you're going to do an intervention for physical function, do you go out and find the most fit people you can? No. You go out and find people who need help with physical function. So what we've done here is we have identified a population that we can do an exercise intervention with who need the intervention, who have a problem with the outcome that we're interested in. We know that exercise has been shown to impact several factors that predict lower relative dose intensity, including functional status, depression, falls, sarcopenia, and we have all of our guidelines that we've talked about. And so what we decided we wanted to do with Thrive 65, which stands for Telehealth Resistance Exercise Intervention to Preserve Dose Intensity and Vitality in elder breast cancer patients, it's a long title, is we are recruiting 270 participants who have stage 1 to 3 breast cancer who are starting cytotoxic chemotherapy of at least 10 weeks in length. And they need to be 65 years of age or older, and we're randomizing them to our intervention as compared to a supportive care program. And I'll talk a bit about that as we go. So if I can point your attention to the right side of the slide here, I want to sort of explain what we think the secret sauce is behind this. So we're doing combined resistance exercise and aerobic exercise through telehealth, and we're doing protein intake support as well. And what we're thinking is that that is going to help these women to maintain and improve their muscle mass as they go through their chemotherapy. And we also think that this is going to help them to maintain or improve modifiable elements of what's called the geriatric assessment: physical functional status, psychological state, social support, falls or use of assistive technology, or nutritional status. All of those things are mediators for the effect that we expect to see, which is improved relative dose intensity, as well as fewer grade 3 toxicities. So this is a very busy slide, but it basically is intended to give me the chance to talk to you about what it is we're actually doing with these women. We have learned that we have to do an awful lot to help them to learn how to use the technology. These are older women in the United States, living in Pittsburgh, living in Cleveland, living in Boston, and they vary with regard to their educational background and their technological savvy. And so we have to sit with them and show them how to use the tablet. We give them the tablet. We don't expect them to have something. And then we help them set it up and get all the software set up for them. And then they spend time online with a trainer who's at Dana-Farber. And he is just a gem and works with them twice a week, doing resistance training with them in their homes. And then we ask them to walk 90 minutes a week. We also do a session with a nutritionist, also at Dana-Farber, and that nutritionist first counsels the woman on general nutritional things that should be of interest to a cancer patient, but then also talks specifically about protein intake. And then we watch them for a week to see what kind of protein they take in, and we have them do a protein checklist. And at the end of the week, we then have the option of supplementing their protein or not. We wrote the grant saying that we would supplement about 20% of the women.
we're now finding that we have to supplement 100% of the women. So it's been quite the learning curve to figure out that older women are really in need of protein supplementation. The Thrive 65 team is at Pittsburgh, where I lead the team there. Jennifer Ligabell is leading the team at Dana-Farber. Case Western Reserve, Cynthia Owusu is the site investigator lead at Case Western. We also are working with colleagues at University of Arizona to analyze our nutritional data. We're working with Bill Evans to do D3 creatine dilution for muscle mass measurement. And our implementation scientist for the trial is Karen Bassen-Enquist, because our third aim for this trial, which it pretty much should be for every trial, I'm pretty sure, is to look at the facilitators and barriers to implementation. So, in summary, overwhelming evidence supports the inclusion of slowly progressive resistance training for rehabilitation after breast cancer. There is robust evidence confirming exercise benefits for symptoms as well among people living with and beyond cancer. But ongoing research is needed that will address the effects of exercise on treatment tolerance, and it is hoped that this evidence will help us to translate exercise into standard of care for cancer patients. I'd like to thank you for your attention, and I want to thank all of my funders and colleagues and trainees and friends from around the world, and of course the patients who are in all the trials. Thank you for your attention.
Thank you, Dr. Schmitz, for your wonderful talk. We are now going to have a Q&A session. So if you have any question, please raise your hand and briefly introduce yourself. Maybe I can... sorry, I didn't see.
Thank you for your wonderful lecture. Your study seems like a very grand and monumental study. Yes, you can change the evidence. It's one of our dream as a scientist. We want to change our evidence and guidelines. When I watching the NCCN guideline, your evidence is supports that, and they change the guidelines. And it also it's not just a change in the practice. It also changes the patient life. They can do many things following your guideline. And I want to ask two questions. One is what your main driving force to keeping your study? It may give tips to the young investigators.
Yeah, so I would say it's been pointed out to me that that the trajectory of my career makes perfect sense when you look back at my personal history. If you know that my mother was very politically active in the United States, and she lobbied on Capitol Hill for women's rights for decades, and I'm very passionate about what I do. But what I've learned as I've grown as a scientist is that I used to think that the people developing the evidence needed to stay in their lane, kind of stay in their lane, just develop the evidence, write the guidelines, and then you're done, right? The experience of what happened with PAL and the fact that we worked so hard, and there is a modicum of success there, but it's not everywhere. And I run into people all the time who don't know about these findings and who don't prescribe this kind of exercise to their breast cancer patients. It's just not enough. It turns out it's not enough. So I have taken up the mantle of being an advocate in addition to being a scientist. And I think that we're going to go farther if we can pair evidence with advocacy. And in fact, what I would say is that I think it's dangerous to have a bright line between the scientists and the advocates, because the advocates don't understand the science. Some don't understand the science, right? And you could say that the scientists don't understand the advocacy, but I think that we have to have a lot of crosstalk between those. And so my American Cancer Society clinical professorship is all about this. It's all about, if you will, developing a different kind of evidence that is necessary in order for us to be able to take brilliant work that many, many scientists are doing that are, phase 3 trials, phase 2 trials, and translate them into actual practice. I think we have to start thinking about our work in ways that are realistic, and I think that I get concerned that we are in an echo chamber, that we're talking to each other, and I think we need to start talking to people who think that this isn't important, and we need to understand what kind of evidence they would need in order to change their minds. That was a long answer, I'm sorry.
My second question is that, that there are very confused terms in physical activity, exercise, and rehabilitations. It's a conflict, a lot of conflict in terms. And I want to ask you, could you explain the definition of those terms in your mind?
Yes, so I think it's very much a continuum. And I think we do a terrible job of helping patients to know where they should be on that continuum. And so I'm very glad to say that there's been some wonderful work in the United States by Kelly Wood. She led the work, developing a triage tool called Exceeds. And it really, I think, will help us a lot with defining what it is that needs to be rehabilitation and what can be exercise and what can be physical activity for clinicians. And it really comes down to the capacity of the patient to be able to access all of these programming, all this programming. One of the things that she talked about that I think is fantastic is in order to refer people to a self-directed exercise program, we have to look at motivation. We have to look at whether the person believes that they can carry that out. If the answer is no, then they need to be with somebody who can help them with motivation. Even if they are physically capable of exercising on their own, we have to pay attention to motivation. The difference between sending somebody to an exercise program versus sending somebody to rehabilitation has to do with the severity of the symptoms and some particular medical issues like falls and chemotherapy-induced peripheral neuropathy. There are a number of particular outcomes that, if they exist in the patient, exercise professionals really shouldn't be working with these patients. They should be going to a physical therapist. So I think it's been nicely handled by Kelly Wood's work.
Thank you.
Yeah.
Any question?
Thank you for your great talk. I have a question about muscle metabolism.
Muscle metabolism.
So weight loss is a common problem for cancer patients, probably due to muscle wasting and fat atrophy. So focusing on muscle, the wasting muscle has more to do with decrease in synthesis, muscle protein synthesis, or increase in degradation. And you mentioned about progressive resistance workout increase strength for a breast cancer survivor. Is it due to increase in synthesis or decrease in degradation?
Increase in synthesis. I would say increase in synthesis. That's been my understanding. And those are studies that I think are also really well done in the animal model. I think that's where we need to look in that literature. So I also think that the muscle wasting that you're talking about is in very advanced cancer patients. And so these were women who were early stage breast cancer. So they were actually overweight, most of them.
So you mean RDA for cancer patients should be higher?
Yes.
RDA of normal population. How high do you think it might be?
For protein?
Yeah,
protein. You're talking about? Yeah. So what we're using in Thrive 65 is 1.2 grams per kilogram of body weight. And there are nutritionists who argue for 1.5 or even 1.8. But we're using 1.2 because we're talking about an older population. And so we don't want, we potentially could have some kidney problems in the mix, and we want to be careful with that. So I think we have to titrate the protein with kidney function.
Now we're going to end the session, and please give a big hand to Dr. Schmitz again.
Generation. So we invited young scientists to organize. So Dr. Lee and Dr. Kim, they organized the session. We opened for submission of the abstract for this session, and we have 2 graduate students presenting today. So I'm very excited about this. Please welcome Dr.
Good afternoon, everyone. My name is Hillman. I'm a senior researcher at National Cancer Center. It is a great honor to chair a session for the next generation of exercise oncology. We have 3 enthusiasm presenters in here. The first speaker is Dr. as co-chair of this session. He earned his PhD from Koan University and is now a postdoctoral research fellow at the Exercise Medicine Research Institute. His research explores skeletal muscle-induced myokine cancer suppression to advance exercise medicine for prostate cancer. Today, he will present on exercise in tumor suppression, its myokine candidate molecular. Please join in welcoming Dr. Yonsei Kim.
Good afternoon, everyone. I know it's 1 hour after our lunch, and probably you guys are getting sleepy, but please focus, because after me, there's 2 young investigator are presenting, and please encourage them and support them with the presentation. And before I actually start my presentation, because I have the honor of being a chair and speaker for this session, I want to talk about this session for about a minute. This session, the next generation of exercise oncology, is to discover outstanding early career researcher in exercise oncology field and share the same special experience that I'm about to have today. And I'm very honored to present in this session. So in the next 20 minutes also, I'm going to stress the importance of the integrative and translative research in exercise oncology field while providing my research materials exploring the potential role of myokines in cancer suppression as an example of the translative and integrative research. So to start with my presentation, let me just show you the 2 graphs from the meta-analysis of 71 cohort study from 2015. This graph is about the relationship between the risk of cancer-specific mortality and physical activity level in 2 different conditions. 1, pre-cancer diagnosis, and 2,
post-cancer diagnosis. If you see this graph, there's a consistent and similar reduction in risk of cancer mortality with moderate intensity and volume of physical activity. But what's more interesting is after the moderate intensity physical activity. If you see the post-cancer diagnosis, there is a further 5% reduction in cancer mortality with every additional 10 Met-hour per week, whereas the pre-cancer diagnosis physical activity does not provide these additional benefits. Well, apart from what this graph is saying, I assume everybody in this room agrees with me that exercise is good for the patients with cancer, right? But the next question that we need to actually ask is how exercise drives these survival benefits for the patients with cancer. And then how does exercise benefit the patients with cancer has been long-lasting questions ever since the initiation of exercise oncology research. And thanks for the previous intense research, now we know that the exercise can improve physical fitness so that patients are better fit to fight against the cancer and tolerate the cancer treatment. And also exercise can provide the direct structure, adaptation, and repair before and after the cancer surgery. And exercise can also provide the increase the blood perfusion and vascular adaptations to reduce the aggressiveness of the cancer. And again, the exercise can increase the efficacy of some of the treatments and also reduce the side effects of these treatments while providing the mental and physical resilience. And all this information has provided the right directions for the exercise medicine prescription for the patients with cancer. But today what I'm going to talk about is the concept of exercise-derived endogenous medicine by stressing the importance of the translative and integrative studies. So in early 2010s, several research has been conducted to examine the tumor suppressive role of exercise-induced alterations of blood contents. In this research, in these studies, the researchers recruited the patients, healthy individuals, patients with prostate cancer, breast cancer, and lung cancer, and and collect the blood before and after the exercise. And they also applied the blood directly into the cancer cell lines, and fascinating results were shown. For example, in the cells, the cancer cell lines that were exposed to the blood that was collected immediately after the acute bout of exercise, there was a significant reduction in cancer cell viability compared to the pre-exercise condition, and also similar results were shown in the cells that were cancer cell lines that were exposed to the blood that was collected after the long-term exercise intervention compared to before the exercise. So what this tells you is that there's something has been changed in the blood because of the exercise. But what is it? So before we talk about what has changed in the circulatory system, we need to understand the very important concept from the muscle physiology. In early 2000, skeletal muscle has been identified as the endocrine organs producing and synthesizing and releasing the cytokines called myokines into the bloodstream. And there's always the exceptions, but generally skeletal muscle elongation and contraction facilitate the synthesis and release of myokines and allowing the skeletal muscle to communicate with other organs. So, and also about 40% of the human body mass consists of skeletal muscle mass, which makes the skeletal muscle the largest endocrine organ that have a greatest potential in changing the blood contents. So as I said, that the myokines allow the communications between the skeletal muscle and other organs, and these communications can create the provide the various health-related benefits. I know this picture is really complex, and I'm not going to go details into this figure, but this figure is just to show you that how complex the myokine allow the interactions between the skeletal muscle and other organs to provide the health-related benefits. But I do have some few things to point out from this figure, which is the role of myokines on immune function, body adiposity, cellular metabolism, systemic inflammation, oxidative stress, vascularization. And isn't this something that you talked about every time when you're talking about the hallmark of the cancer? So in 2021, I have evaluated preclinical data and published the article in Nature Reviews Urology about the tumor suppressive role of myokines. First of all, myokines can regulate the adipose tissue and also improve the cellular metabolism, thereby reducing the inflammation in the skeletal muscle mass, thereby reducing systemic inflammation and oxidative stress, which ultimately can create a less favorable environment for the cancer development. In addition, myokine can also increase the natural killer cell mobilization and infiltration into the tumor sites, and also while increasing the proliferation, survival, and differentiation of the immune cells, thereby increasing the cytotoxic activity of the cancer cell by increasing the number of actual memory T cell, allowing increasing the anti-cancer immunity to reduce the progression of the cancers. And lastly, and most importantly, myokine also have a direct tumor suppressive effects, and the acute exposure of myokine interleukin 6 onto cancer cell can reduce the cancer cell growth, and myokine irishing can increase the cancer cell apoptosis while reducing the proliferation and migration of the cancer cells. Oncostatin M and SPARC also can increase the apoptosis of the cancer cell and reduce the proliferation of the cancer cell. And Kathryn can induce the cell cycle arrest of the cancer cells, thereby reducing the proliferation of the cancer cells. And all this cellular behavior has been observed with the significant increase of the tumor suppressive proteins such as P53, and also reduction of cancer progressive proteins such as the vimentin and cadherin. So keep this positive role of myokines in your mind. I have conducted a series of translational studies to examine whether exercise can elevate the circulatory myokine levels in clinical settings, and also examine the tumor suppressive effect of exercise-induced circulatory factors in the patients with cancer. Briefly, for these studies, I have recruited the prostate cancer patients, the patients with prostate cancer with various stages and undertaking different cancer therapy, and provided the long-term exercise intervention or acute bout of exercise session, and collect the blood before and after the exercise intervention and the acute bout of exercise session. The collected blood was underwent to the circulating myokine level analysis, while the collected blood was directly applied to the cancer cell lines to examine the cellular behaviors. So the first pilot study that I have published is titled "The Myokine Expression and Tumor Suppressive Effect of Serum After 12 Weeks of Exercise in Prostate Cancer Patients on ADT." And for this study, I recruited the localized prostate cancer. I recruited the patients with localized prostate cancer undertaking ADT and provided the 3 months of combined exercise program. And when you look at the body composition, there was a significant improvement in the body composition by showing the significant reduction in body mass and increase in percent lean mass and reduction in percent fat mass after the 3 months of exercise. And body strength was also increased after the 3 months of exercise compared to before, confirming the physical benefits that exercise can provide for this patients group. And when we measured the circulating myokine level, the myokine called oncostatin M and SPARC was significantly increased after the exercise intervention. while there was a significant positive associations between the changes of oncostatin M and changes of the skeletal limb mass. In addition, when we directly apply the collected serum onto the living prostate cancer cell line, there was a significant 21% reduction in the cells, prostate cancer cells, that were exposed to the blood that was collected after the exercise intervention compared to the before the exercise intervention. So with this exciting result, the exciting pilot data, I decided to expand the study into the advanced prostate cancer in randomized controlled trial. The study titled "The Exercise in Advanced Prostate Cancer Elevates Myokine Level and Suppresses In Vitro Cancer Cell Growth." We decided to integrate the previously used analytic methods onto larger ongoing trial, which is INTERVAL-GAP4. So INTERVAL-GAP4 trial is the multi-centered global phase 3 randomized controlled trial, aims to examine the role of exercise medicine on the survival of patients with metastatic castrate-resistant prostate cancer, which is very late stage of the prostate cancer. And for this INTERVAL-GAP4 trial, the patients who are allocated into exercise group were provided with a 6 month of in-clinic supervised exercise program, followed by 6 months of home-based exercise program, while the control group were provided with 12 weeks of usual care. And specifically for this particular trial, I analyzed the data and the blood sample that was collected for the 6 month in-clinic supervised exercise program, and the collected blood was underwent the myokine level analysis, while the blood that was collected, while the collected bloods were directly applied to the cancer cell lines to observe cancer cell behavior using the real-time cellular analysis. Well, first of all, when we saw the body composition result, I was a bit disappointed because there were no changes between exercise group and control group. But if you see the patient characteristics for this study, all of the patients underwent the prolonged androgen deprivation therapy, while majority of the patients are currently receiving the androgen targeted receptor agents or chemotherapy as a first-line treatment for the castrate-resistant prostate cancer, and also the patients are having a high load of the cancer due to metastasis. So I speculated that the prolonged exposure to cancer therapies and high load of the cancer may interfere with some of the physical benefits that the exercise can provide for this patients group. The reason I speculated is because of the circulating myokine levels. And consistent with the pilot data, there was a significant increase in oncostatin M and SPARC in the exercise group compared to control group at the 6 month period. And also, although it's not shown in this slide, there was a significant increase in myokine decrene in exercise patients undertaking chemotherapy compared to unexercised patients undertaking chemotherapy, suggesting there's a differential effect of the cancer treatment type on circulating myokine levels. Well, however, when we directly applied the collected blood onto the cancer cell lines, there was about 17% significant reduction in cancer cell growth in the cells that were exposed to the blood that was collected from the exercise group compared to the usual care group. So what this indicates is that the exercise can alter circulating factor, and this create the less favorable systemic environment regardless of the cancer stages by combining two results from the previous pilot data and these specific studies. And last study that I'm going to share with you is titled Acute Effect of High Intensity Interval Aerobic Exercise on Serum Myokine Levels and resulting tumor suppressive effect in trained patients with advanced prostate cancer. From this study, I aim to examine the exercise responses, not the adaptation on the circulating myokine levels in this patients group. And of course, we also recruited the patients from the interval gap for trial from the exercise group who actually completed at least 3 months of exercise intervention from this from the interval gap for trial. The participants were provided with the 44 minutes of high-intensity interval aerobic exercise, alternating 4 minutes of high-intensity bout and 2 minutes of low-intensity bout, and the blood were collected before, immediately after, and the 30 minutes after the exercise. Of course, the collected blood underwent the myokine analysis and cell growth behavior analysis, and this experimental setting allows us to examine the impact of a single bout of exercise on circulating myokine levels in patients with the prolonged cancer therapy with the high load of the cancer, and also provide the information about the exercise intensity and volume that could induce beneficial myokine surge into the bloodstream. Lastly, and most importantly, this study also allows us to examine whether a bout of exercise can have an additional tumor suppressive effect in the tumor suppressive environment that has already been established by the regular exercise because the participants were previously trained for 3 months. So when we measured the circulating myokine level, there was a significant increase in myokine oncostatin M, interleukin-6, SPARC, and interleukin-15 immediately after the exercise compared to baseline. And this increase returned to the baseline level after the 30 minutes of the exercise cessation. Kathryn and Arjun also showed a very similar pattern, but unfortunately the changes were not significant. And again, when we directly applied the collected serum onto the live prostate cancer cell lines, there was about 15% significant reduction in cancer cell growth on the cells that were exposed to the blood that was collected immediately after the exercise session compared to the baseline. And in addition, the blood that was collected 30 minutes after the exercise cessation also reduced the cancer cell growth compared to the baseline. However, the tumor suppressive effect was greatest with the serum that was collected immediately after the exercise. But if you see the pattern of the growth rate and the myokine expression kinetics, you may realize that the pattern of the increase and decrease is exactly opposite between myokine expression kinetics and growth rate pattern. What this indicates is that of course, we cannot ignore the other factors that may influence the tumor suppression, but myokine may be the one that has a greatest potential for the cancer suppression. So, in summarizing, the acute exercise may alter the myokine expression, and this could cause the cancer cell growth inhibition, and also the more than 3 months of exercise intervention is required to change the resting level of myokines and establish tumor suppressive systemic environments. Lastly, and most importantly, every exercise bout is an additional tumor suppressive effect onto anti-cancer systemic environment that has already been established by the exercise adaptation. So before I actually end my presentation, I want to point out the importance of the integrative and translative research in exercise medicine research for the cancer. I personally think the integration of exercise science and clinical oncology can create a positive feedback loop to improve to further inform the targeted exercise medicine, and this could lead to the better patient outcomes. And for example, in my cases, I try to integrate the epidemiological observations, exercise physiology, and cancer biology to add one more meaningful suggestion for the exercise medicine for the cancer patients, which is every bout of exercise is an additional tumor suppression in an anti-cancer environment that has been established by the regular exercise adaptation. So I think the exercise medicine research requires a deep understanding of biological and physiological alteration induced by exercise and capacity to comprehend the preclinical knowledge into the clinical setting, as well as the ability to implement the knowledge into the real-world situation. So this session, the next generation of exercise oncology is to discover young investigators with the potential and encourage their research. And I have two young investigators, very young investigators to introduce to you for next two presentation, who has a potential in expanding biological knowledge and implement that knowledge into the real world situation. So please welcome and encourage Miss Wu from Seoul National University and Mr. Zhang from Inan University for next two presentation. Thank you.
Thank you for a wonderful lecture for us, Dr. Kim. And because of time limit, the Q&A session will follow all the presentations. The second speaker is Ms. Seung-won Woo, a PhD candidate at Seoul National University. Her presentation is titled Exercise Reduce Breast Tumor Growth Through Modulations of Neutrophil. Please give her a warm round of applause.
Thank you for introducing me, and good afternoon, everyone. I'm currently working as a research assistant in exercise biochemistry lab in Seoul National University. It's a great honor to be here and representing my research titled The Effective Exercise on Tumor-Associated Neutrophil Phenotype in Breast Cancer Mouse. I'll briefly talk about my research background. So recent advancement in breast cancer treatment includes the immunotherapy, which activates the immune system of the patients and providing the advantages over traditional chemotherapies and radiotherapies, which often result in drug resistance and recurrence. However, the effectiveness of immunotherapies is largely influenced by the tumor microenvironment, which includes vascular cells, stromal cells, and lots of immune cells. So many of you may have heard of the macrophages that play dual role in TME, and they play both anti and pro-tumor phenotype. And like these macrophages, recently neutrophils has been discovered to present both phenotype, which is anti and pro-tumor. And N1 phenotype is called, N1 phenotype expresses the anti-tumor phenotype, and they activate the immune system. And while the N2 phenotype is usually promote the tumor by suppressing the immune system. And this phenotypic shift is influenced by the interferon beta and TGF-beta. And exercise has been shown to reduce the tumor growth and metastasis and recurrence in breast cancer. Also, they increases the response to immunotherapy by activating NK cells, T cells, and B cells in cancer. And there are evidence that the exercise can shift the macrophages to anti-tumor phenotype. However, there were no research that studies exercise effects on tumor-associated neutrophil phenotype. So in this study, we aim to answer three key questions. So first, does exercise really reduce the cancer growth and metastasis? And second, if it does, Do neutrophils mediate the anti-cancer effect of exercise? And third, which factor alters the observed changes of immune cells in the tumor microenvironment? So to answer the first question, we conducted the mouse experiment using 41 breast cancer mouse model. So we compared the tumor size, weight, and metastasis in exercise and sedentary group. So voluntary wheel running began 3 days after cancer cell injection and continued for 6 weeks. And interestingly, we found that tumor size and weight were significantly smaller in the exercise group. And as you can see on a graph, the mean lung area occupied by metastasis was significantly reduced in exercise group 2. We then extracted blood and bone marrow cells from mouse and executed the single-cell RNA sequencing to compare the immune composition between sedentary and exercise mouse. So focusing on neutrophil, we found that the number of neutrophil has been reduced in exercise group. And next, we investigated whether neutrophils mediate the anti-cancer effect of exercise. And we depleted the neutrophils at the tumor site using the anti-LY6G antibody. And after 6 weeks of exercise and 4 rounds of intratumoral neutrophil depletion, the anti-tumor effect of exercise was abolished. So as you can see on a graph, the exercise group has reduced tumor size. However, the exercise with anti-LY6G group shows the not reduced tumor size. And then we explored whether the exercise affects the neutrophil phenotype. So using microarray analysis, of TAN of each group, we could find that the regulated genes in exercise group were highly related to pathways in cancer and PI3K-AKT signaling pathway and cytokine receptor interaction, which is important in immune system. And notably, we also found that the genes such as CXCR4, VEGF, and TGF-beta and MMP9, which are known as the N2 markers of the neutrophil, were significantly reduced in exercise group. So this indicates that there might be the phenotypical shift in exercise group. So to answer the third question, based on the previous findings, we sought to identify the factor that responsible for the shift. So TGF-beta, a cytokine known to influence the neutrophil phenotype, were analyzed, and we found that within the tumor site, the percent of TGF-beta plus cell were significantly reduced in exercise mouse. So to summarize, the exercise appears to reduce the TGF-beta levels in the tumor microenvironment and potentially shifting the neutrophil phenotype towards the N1 phenotype, which is anti-cancer. And this shift may inhibit the tumor growth and metastasis. And I think our findings highlight the potential of exercise as a complementary strategy in cancer therapy. So for the studies, we plan to focus on 3 key things. So first, we are going to investigate the specific pathway leading to TGF-beta reduction in tumor during exercise. And second, we are going to translate this into human studies. And third, we are going to explore how exercise-induced neutrophils interact with other immune cells, such as NK cells or B cells in tumor microenvironment. And this research was greatly supported by the 2 professors, Hyo-yeol Moon and Young Chan-che. They are not here today, but I feel really appreciated for them, and they helped me a lot, like designing the experiment and other things. And this is our lab members, and we are the Exercise Biochemistry Lab, and we focus on the effect of exercise on other diseases such as stroke and depression. And we also study about the overtraining things. And as for myself, I am nearing the completion of my research in exercise chemistry lab, and am currently preparing for the PhD program abroad. So due to time constraint, I will finish my presentation, and feel free to ask any question about my research after during the Q&A session. Thank you.
Thank you for your wonderful presentation. And we have our final speaker, whose name is Mr. Juno Zhang, PhD candidate at Ina University. His presentation is titled "Exposure to Particulate Matter Alters the Lung Microbiota and Aggravates the Pathogenesis of Lung Cancer." Let's please give big applause to Mr. Zhang.
Good afternoon, everyone. My name is Juno Zhang, and I'm a PhD student at Ina University. And I'm very honored to speak the presentation of the Yonsei Exercise Oncology Symposium. And the focus on my study is exposure to particulate matter, alters the lung microbiota, and aggregates the pathogenesis of lung cancer. To begin with, why this issue is important. Lung cancer is one of the most common cancers in worldwide, but one of the major cause of lung cancer is air pollution. Recent study shows the composition of air pollution, like carbon black or ozone something, but mostly the particulate matter is contributing significantly by generating reactive oxygen species, which cause lung inflammation and which is strongly associated with developing lung cancer. Like the gut and skin microbiome, mostly the microbiome inside the gut, but their lung also have. The lung microbiome helps maintain homeostasis and supports lung health by preventing infection, reducing inflammation, and enhancing immunity. However, the air pollution, especially particulate matter PM, PM2.5, can disrupt this balance. And when that happens, the harmful microbials like Streptococcus and Venerellae getting more in the lung, and these microbials raise inflammatory cytokines. And after the inflammation response can increase the risk of the lung cancer. And how exercise and dietary fibers can have positive impact in the lung microbiomes. The regular exercise is improved the gut microbiota, and which is closely connected to the lung microbiota also. The balance of microbiota in both this gut and lung that helps maintain stability and increase microbiomes diversity and reduce lung inflammation. This reducing inflammation is lead to better immunity function. A strong immunity system helps to prevent lung cancer and reduces cancer-related mortality. So in summary, PM can disrupt the lung microbiome that triggered inflammation and increase the lung cancer risk, which may be mitigating through exercise-induced lung microbiome balance. The purpose of this study is to investigate whether exercise can help maintain a healthy lung microbiome, and that would otherwise have been disrupted by particulate matter. To examine whether exercise can reduce the lung inflammation caused by PM-induced dysbiosis. Our study design is 2 ways, the week 1 and week 12, and during the 12 weeks intervention. The PM exposure, the condition we using our own the equipment in PM, the exercise chamber. My professor made it. And week 1 is we are the control and particulate matter exposure and PM exposure during exercise and only exercise group. And week 1 is collected a lung sample and we analyze the assess using the H&E staining, Mason trichome, Turner assay, and Western blot related to inflammation, the apoptosis related marker. And week 12, it's same as to the week 1, the groups, and we collected the lung sample and collected the 60 RNA and Pennington sequencing, and after we doing next generation sequencing. And we investigated how PMs affect the lung tissue. At the week 1, we found that the PM groups shows lung damage and inflammation and fibrosis and more cells like apoptosis in the lung tissue increase. But these effects were reduced in the PM during exercise and exercise groups. This shows that the exercise helped protect the lung tissue from the PM damage. It took only 1 week to see the change, the inflammation, the effect, but the changes microbiomes can take longer, so we do intervention to 12 weeks to check the lung microbiomes. You can see the left side graph is the phylum level, the proteobacteria and actinobacteria. This both bacteria is a harmful effect. Depends on the lung disease, so there's causing the inflammation and infection. And also the alpha diversity is measuring the richness and evenness compared to group. So, but our data is no significantly different the other. The right side is the broad cuts is beta diversity. The beta diversity is measured the different each groups. But as you can see, there's the values, the difference control and the PM and exercise PME is quite different the other groups. The last one is leaves. There's the effect of size in the microbiome affecting the lung health, such as Muribacillus, and the Prevotella is the increase the inflammation and regulation or effect, but there is increase the PM but decrease the PME groups, and the Ruminococcus is the immunity modulator and inflammation supplement, and this is decrease the PM group and increase the PME group. This finding suggests that specific microbiota can serve as the biomarkers for the lung health and as a potentially therapeutic targets. This study's limitation is the analysis for the inflammation marker is in progressive for the lung sample collected after 12 weeks of the intervention period. But this strength is exposure the animal to particulate matter, which well reflects a serious environment health problem that society faces today, which is known to increase the risk of the lung cancer. Our conclusion is not conclusive whether microbiome change induced an inflammatory environment or whether an inflammatory environment causing change in the microbiome composition in promoting the lung cancer. However, it is likely that exercise has promising the role in reducing the PM-induced cancer development by creating an anti-inflammatory environment and restoring the balance of microbiome composition. Before the thank you, I'm not upload my laboratory's information, but my professor a little upset about this. So I know that the air this on air this YouTube, and thank you, Professor Kang Chung-hoon, and thank you for my co-researchers So Byung-un, Park Jin-han, Eda, and Lee Kyung-kyun. Thank you for my presentation.
Thank you for your presentation, Mr. Zhang. And we will start the Q&A session. So if you have any questions, please ask to any of the presenters. Thank you. Are we setting it?
Everything is very good.
Thank you for the wonderful presentations. It was very excited to see your results and everything. So I have one question for each of you, and for Ms. Wu. Wow, it's howling. For your result, when you're looking at the contributions to tumor volume and you're looking at all those immune markers, did you find anything outstanding, or the person contribution to those reduction based on immune cell types, and then whether neutrophils were more outstanding than others, or if it was more minimal compared to like T cells and B cells and NK cells?
Actually, for the single-cell RNA sequencing, it was quite hard for neutrophils to be analyzed because of their contents of RNA amount. So we focused just on neutrophils. So the amount of B cells and T cells were so small that when I analyzed it, there were not really like huge difference. So yeah.
Thank you. For Mr. Chang, I've never heard actually about the lung microbiome, and it was very, very interesting. And for your one of the last slides, you were showing that exercise group, and we were talking about beta diversity, and exercise group was independently different from others, right? And do you know why would that be, or what that really means?
The lung microbiome is before the previous studies. They said there have no lung microbiome before, but from now after the NGS they founded the lung microbiomes. But I think it's quite hardly to get the lung microbiomes the DNA. So there's a lot of variation, especially the exercise. So I think.
There's a lot to unfold.
Doing more the experiment and find out the problem, solve the problem.
Thank you so much.
Thank you for your presentation. It was really excited. And I have one question to Song-Wan Woo, is that at the end of your presentation, you say you're going to translate into a human study. So do you have any specific plan for this?
So actually for my human study, I've already implemented the human cell study, and we found the significant difference
However, our lab is not the medical lab, so it's almost impossible for taking the data from the patients. So maybe with the help of Justin John, I can get some samples from them and analyze the difference between the patients exercised.
So we will accept one more question. You could ask me as well too. So 'cause I was a speaker too. So.
Just a comment. I think that was an excellent presentation, all three of you, and really commend you for excellent quality of your work and also how you presented your data. I have a question for Dr. Kim, since you asked. So we know that myokines are very important for brain health and whole body health, but also, as you mentioned, the cancer cell growth. So we know that the aerobic exercise and also resistance exercise may have a different effect on the myokines. So what is your thought on that?
I was actually waiting for this question. Because it is true that well, first of all, I need to address that there's about 3,000 proteins that is produced by the skeletal muscle, and about 650 myokines are currently functionally identified. But among the 650 functionally identified myokines, they all have different roles. Well, some overlapping, but they all have different roles. However, the stimulus that requires to induce myokine synthesis and production release is also different. So, the answer to Professor John's question is that we need to find the targeted exercise that could induce specific myokines that specifically have positive effects on different mechanisms of cancer cell growth. And this is going to require a lot of work. It's going to take a lot of time. But as I was talking to Professor Kathryn Schmitz last night, she actually thought that this is a smoking gun, right? So this work in terms of the exercise oncology is at very beginning stages. So we actually have to find and do more work to find out which exercise type or duration or even frequency is required to induce specific myokines for a specific cancer mechanism. Thank you.
Because timely, we would like to closing this session. Thank you so much.
양은주입니다.
안녕하세요. 저도 같이 좌장을 맡은 허진모입니다.
첫 번째 연자분 소개시켜드리겠습니다. 고수진 교수님이십니다. 고수진 교수님은 울산대 또 가톨릭대 박사 과정으로 하시고 지금 현재 울산대 병원에서 혈액주변내과 교수님이십니다. 한국의 마스크 대표이시고 캔서 케어, 서포티브 캔서 케어 우리나라의 차세대의 참 믿음직하고 듬직한 혈액주변내과 교수님이십니다. 발표 부탁드립니다.
네, 크게 감사드립니다. 이렇게 제가 오늘 아침부터 강의를 이렇게 쭉 들었는데요. 강의 내용이 너무 좋았고, 네, 제가 너무 많이 오늘 배우고 가는 그런 자리인 것 같습니다. 그래서 이렇게 국내외 저명한 선생님들께 이런 사이에서 제가 발표를 하게 돼서 감사드리고 또 무한한 영광으로 생각합니다. 근데 우리가 이제 암 환자들이 어떻게 케어를 잘 해야지만 치료를 하는 것도 중요하지만 케어를 잘하는 게 굉장히 중요한데요. 미국의 인스티튜트 오브 메디슨에서는 암의 예방과 진단부터 치료 그리고 서바이벌십과 엔드 오브 라이프 케어에 이르기까지 하이 퀄리티 캔서 케어를 제공하도록 이제 권고를 하고 있는데 여기 내용을 보면은 페이션트 센터드 케어를 제공하기 위해서는 환자의 니드와 밸류에 맞춘 그런 이제 를 고려해서 케어 플래닝을 제공하고 또 팔리에이티브 케어를 제공을 하면서 부작용을 예방하고 또 관리해서 신체적 기능을 유지하는 것과 함께 사이코소셜 서포트를 제공하고 그래서 궁극적으로 암 환자의 삶의 질을 향상시켜야 된다라고 권고하고 있습니다. 암 환자들에게 이런는 사실 여러 가지 암 치료뿐만 아니라 다양한 이슈들이 고통을 가져오게 되는데요. 먼저 가장 중요한 것은 암을 치료하는 것이 되겠고요. 또 암 자체나 항암 치료로 인해서 생기는 여러 가지 신체적 증상이나 기능의 장애, 또 우울이나 불안과 같은 정신적인 문제, 그리고 사회 경제적 문제, 영적 문제, 그리고 뭐 일상생활과 관련된 실질적인 문제들이라든지 이런 것들이 이제 환자들의 삶의 질에 영향을 주게 됩니다. 근데 우리가 아무리 암을 잘 치료했다고 하더라도 환자의 이런 다양한 문제들을 잘 다루어주고 완화시켜주지 않으면 환자나 가족은 암은 치료가 됐지만 여전히 고통 가운데 놓여 있게 되겠고요. 그래서 아스코나 에스모와 같은 그런 이제 종양학회에서는 얼리 팔리에이티브 케어 가이드라인을 제시하면서 암의 진단 시점부터 이런 안티캔서 트리트먼트와 함께 팔리에이티브 케어를 함께 제공하도록 권고하고 있습니다. 그래서 이렇게 암 환자의 삶의 질을 향상시키기 위해서는 다양한 이런 특히 엑서사이즈 온콜로지가 여러 가지로 중요한 역할을 하게 되는데요. 먼저 운동을 통해서 근력이나 지구력 또 모빌리티를 증가시켜서 암으로 인한 어떤 신체 기능을 향상시킬 수 있겠고 또 운동을 통해서 암이나 암 치료를 인해서 발생하는 피로를 감소시키기 때문에 또 환자들이 또 규칙적인 운동을 계속하고 또 체중을 조절하게 되면서 또 근육량도 유지하게 되면서 림바디 매스를 이제 유지하는 그런 효과도 있습니다. 그리고 적당한 운동을 지속하면 면역 기능을 향상시켜서 잠재적으로 암의 발생이나 재발을 예방하는 데도 도움이 될 수 있겠습니다. 최근에 엑서사이즈 온콜로지에 대한 그런 리뷰 아티클에서 운동은 이제 파티그나 캔서 카케시아의 심텀을 감소시키고 코그니티브 펑션을 향상시켜서 그럴 뿐만 아니라 이제 튜머 비헤이버에 영향을 줘서 이뮨 모듈레이션이나 메타볼릭 패스웨이를 변화를 준다. 그리고 캔서 리스크를 이제 감소시키고 또 안티캔서 트리트먼트에 대한 부작용을 감소시키기 때문에 이런 스탠다드 케어에 그러니까 암 환자를 치료하는 데 있어서 엑서사이즈를 하나의 중요한 영역으로 포함시켜야 된다라고 이제 권고를 하고 있습니다. 그래서 또한 운동이 암 환자의 불안이나 우울증과 같은 이런 정신적인 문제도 완화시켜주고 전반적인 스트레스를 이렇게 낮춰줄 뿐만 아니라 기분을 또 개선하는 효과가 있어서 또 환자들의 삶의 질의 향상에도 도움이 되고 특히 환자의 자신감, 자존감을 높여주고 에너지를 증가시켜주고 그렇기 때문에 성취감도 높여준다라는 이러한 결과들이 있습니다. 그래서 오늘 오전부터 선생님들께서 여러 가지 운동이 암 치료에 미치는 영향에 대해서 계속 보여주셨는데요. 이런 클리니컬 에비던스를 바탕으로 해서 운동이 특히 암의 예방에도 효과가 있을 뿐만 아니라 캔서 트리트먼트 중에도 피로감이나 신체 기능 향상의 효과를 가져오고 또 암 생존자의 회복에도 영향을 준다. 그리고 암 재발의 위험도 줄여주기 때문에 전체적인 암으로 인한 생존율을 향상시키는 결과도 있다라는 것들이 이제 데이터가 계속 나오고 있습니다. 그래서 아메리칸 콜리지 오브 스포츠 메디슨에서 퍼블리시한 2019년도 가이드라인을 보면요. 피지컬 액티비티가 암의 예방에 도움이 되고 특히 이제 콜론 캔서나 브레스트 캔서에서는 이제 스트롱 에비던스를 보이는 그런 결과를 보였습니다. 또한 암의 발생과 관련된 모탈리티를 전체적으로 감소시킬 뿐만 아니라 암을 진단한 이후에도 브레스트 캔서나 콜론 캔서, 프로스테이트 캔서의 경우에는 캔서 스페시픽 모탈리티와 함께 올코즈 모탈리티도 감소시키는 이런 효과를 보였고요. 그리고 캔서 서바이벌을 위한 엑서사이즈 가이드라인에서 보면 이런 에어로빅 또는 레지스턴스 엑서사이즈가 암 환자의 앵자이티나 디프레션 그리고 퍼티그를 감소시키는 그런 영향이 있을 뿐만 아니라 헬스 릴레이티드 퀄리티 오브 라이프를 향상시키고 림프이데마를 호전시키는 그런 효과가 있었고요. 이런 운동의 효과가 도즈 리스폰스는 이제 명확하지 않았지만 슈퍼바이즈드 엑서사이즈인 경우에는 더욱 효과가 있었다. 그리고 대장암이나 전립선암을 비롯한 여러 가지 암종에서도 효과가 있는데 특히 브레스트 캔서에서 주로 이런 에비던스가 있다는 결과를 보였습니다. 그래서 이런 운동이 수술이나 항암 치료, 또 방사선 치료나 요즘 항호르몬이나 또 타겟티드 이뮤노세라피에도 역시 효과를 주는데요. 특히 환자의 카디오바스쿨러 펑션을 이제 좋게 하고 본 헬스나 GI 펑션, 그리고 이뮨 펑션이나 메타볼릭 신드롬이나 또 코그니티브 체인지, 또 렁 펑션 이런 부분에도 긍정적인 영향을 줄 뿐만 아니라 퍼티그나 페인을 감소시키는 그런 효과가 있었다라는 이제 에비던스들이 나왔습니다. 그래서 이러한 결과들을 바탕으로 피지컬 액티비티나 엑서사이즈가 암 환자에서 전반적으로 효과도 있고 안전하다라는 이런 에비던스가 나오면서 이제 아메리칸 콜리지 오브 스포츠 메디슨이나 아메리칸 캔서 소사이어티, 아메리칸 소사이어티 오브 클리니컬 온콜로지 이런 여러 가지 암 관련 학회나 단체들에서 이제 가이드라인을 퍼블리시하고 또 항암 치료 중이나 또 치료 후에 보시는 표와 같이 이제 치료 중에는 에어로빅 엑서사이즈와 레지스턴스 엑서사이즈를 이제 제공을 하고 치료 이후에는 좀 더 에어로빅 엑서사이즈를 더 하도록 권고를 하고 있습니다. 그래서 최근에는 이런 치료 중이나 치료 이후뿐만 아니라 치료 전에도 이런 재활을 하는 것이 도움이 되겠다. 즉 우리가 보통 치료를 하고 나서 어떤 문제가 생기면 재활을 하는 이런 형태로 가는데 그게 아니라 치료 전에 이런 문제가 생기기 전부터 이런 엑서사이즈를 하면은 더 환자에게 도움이 된다라는 것인데요. 보시는 것처럼 치료를 시작하기 전에 환자의 상태에 맞게 엑서사이즈나 뉴트리션 그리고 사이코로지컬 서포트를 제공하면 치료 후에 회복이 더 빨라질 뿐만 아니라 치료 이후에 정상보다도 더 좋은 그런 효과를 보이는 그런 가설로 이제 진행이 되고 있고 특히 폐암 환자에서 수술 전에 몇 주간 금연을 하면서 인스피레토리 머슬 트레이닝과 함께 엑서사이즈를 병행하면 수술 후에 카디오 풀모너리 펑션이 회복이 더 빨라지고 삶의 질이 향상된다는 그런 결과를 보였습니다. 그래서 그럴 뿐만 아니라 또 저희가 이제 저는 이제 유방암을 개인적으로 보고 있는데요. 조기 유방암 환자들이 운동을 하면 운동을 하지 않았던 컨트롤 그룹에 비해서 카디오 레스피레터리 피트니스가 좋아지고 머스큘러 스트렝스나 플렉시빌리티가 더 좋아질 뿐만 아니라 특히 이런 것들이 이코 퍼포먼스 스테이스가 나쁜 전반적인 신체 상태가 나쁜 환자들에서 더 효과가 크게 나타나는 것을 보였고요. 그럴 뿐만 아니라 응급실이나 입원 또 외래 방문을 사용하는 그런 비용이 감소되면서 전반적으로 코스트 세이빙 하는 효과도 있었다라는 결과들이 이제 발표가 됐습니다. 그래서 이러한 운동의 효과가 완치가 가능한 조기 유방암 환자뿐만 아니라 우리가 메타스틱 브레스트 캔서, 즉 완치가 불가능한 그런 유방암 환자들에서도 슈퍼바이즈드, 스트럭처드, 인디비주얼라이즈드 엑서사이즈를 제공하면 삶의 질도 좋아지고 피지컬 퍼티그도 좋아지더라라는 이런 결과를 랜더마이즈 컨트롤드 트라이얼을 통해서 보여주었고요. 그리고 진행성 암 환자들에게 이런 팔리에이티브 케어 페이지에서 운동을 하는 그런 연구 결과들을 쭉 이렇게 모아서 분석한 결과를 보면 이렇게 이런 환자들이 프레일리티가 조금 높거든요. 그렇기 때문에 이제 부작용이 생기지 않을까를 걱정을 하게 되는데 어드버스 이벤트가 조금 더 생기는 경향은 보이기는 했지만 이 메타아날리시스 결과를 보면은 퍼티그나 페인, 글자가 너무 작아서 죄송합니다. 등과 또는 증상이나 이런 신체 기능, 또 삶의 질이 호전이 되고 이러한 것들이 엑서사이즈의 모드나 듀레이션, 또 슈퍼비전과 관계없이 또 모든 암종에서도 이렇게 포지티브 이펙트를 보였다라는 그런 결과가 있었습니다. 그래서 이렇게 암 환자의 전 주기에 걸쳐서 운동이 효과가 있다라는 그런 에비던스 가이드라인들이 있기 때문에 우리가 암 환자를 진료하는데 엑서사이즈 온콜로지를 적용하는 것이 이제 필요한데 어떻게 하면 이제 이것이 좀 더 현장에서 가능할까 이런 고민들을 하게 되는데요. 먼저 저와 같은 이런 암 전문의들이 재활의학과 선생님뿐만 아니라 운동 전문가나 또 물리치료사와 협력하는 것이 일단 필요할 것 같고요. 또 각 환자의 상태에 맞게, 즉 환자의 체력 수준이라든지 또 치료 단계에 맞춰서 환자 맞춤형 운동 프로그램을 제공하는 것이 필요하겠고요. 또 암 환자들이 이런 운동을 지속하는 것이 중요한데 그러기 위해서는 운동의 중요성과 또 그 효과를 교육해서 자발적으로 운동을 지속하도록 돕는 이런 것들이 앞으로 필요하겠습니다. 그래서 먼저 우리가 엑서사이즈가 아까 앵자이티나 뭐 디프레션, 그리고 퍼티그나 QOL, 또 피지컬 펑션, 림프이데마 이런 데 다 효과가 있다라는 결과를 스트롱 에비던스를 갖고 있고 또 슬립이나 또 본헬스에도 도움이 된다 이런 결과들이 있기 때문에 이제 운동이 치료제와 같다, 암 환자에서 라는 이런 이제 가이드라인이 나오기도 했는데요. 그래서 우리가 이렇게 되기 위해서는 먼저 종양을 환자들을 일선에서 보는 종양 전문의들이 환자에게 자주 이러한 부분에 대해서 질문하고 또 어드바이스 주고 그리고 필요할 때는 리퍼를 하고 이런 것들이 이제 중요하겠습니다. 그래서 저희 병원 같은 경우에는 재활학과 선생님께서 이렇게 암 재활에 굉장히 관심이 많으세요. 그래서 제가 열심히 보내드리고 있고 도움도 많이 받고 있는데요. 이제 보통 이제 온콜로지 클리니션들이 환자를에게 먼저 상태를 체크하는 것이 먼저 첫 번째인 것 같습니다. 그래서 뭐 유산소 운동이나 근력 강화 운동을 어느 정도 하는지 그리고 환자에게 스스로 할 수 있는 운동이 있는지 이런 것들을 물어봐서 환자가 퍼포먼스가 괜찮고 스스로 운동이 가능하다라고 하면 앞에서 말씀드린 것처럼 이렇게 에어로빅 엑서사이즈를 뭐 모더레이트 인텐시티로 주 3회 30분 이상 하세요. 그리고 근력 강화 운동도 주 2회는 하세요. 이렇게 리커멘데이션을 주면서 이런 환자들이 지역 사회에 가서 이런 운동을 지속할 수 있도록 하는 것이 이제 필요하겠고요. 근데 환자가 뭐 본인이 스스로 할 수 있는 운동이 없다, 난 자신 없다 이렇게 얘기를 하면 또 퍼포먼스가 별로 좋지 않은 환자들인 경우에는 우리가 재활의학과로 좀 보내서 환자들이 조금 더 전문적인 그런 리해빌리테이션을 받도록 하는 것이 더 도움이 되겠습니다. 그래서 우리가 환자의 상태에 따라서 아까 전문적인 재활 치료를 받게 되기도 하겠고 또 환자가 이제 지역사회의 커뮤니티 엑서사이즈 프로그램을 또 받도록 하는 것도 필요하겠고요. 그래서 이런 것들을 위해서는 서로 간에 커뮤니케이션을 잘 하는 것과 함께 전반적으로 코디네이션을 하는 것 또한 필요하겠습니다. 그래서 우리가 엑서사이즈 프로그램이 특히 캔서 서바이벌 중에서도 뭐 본메타가 있다거나 또 림프이데마나 오스토미를 갖고 있다거나 특히 나이가 또 많은 경우 또는 환자의 오베시티가 갖고 있다거나 여러 가지 이런 환자들의 컨디션에 따라서 좀 다양한 프로그램을 적용해야 된다라는 이런 가이드라인이 이미 나와 있고요. 그렇기 때문에 우리가 환자의 상태에 따라서 어떤 운동을 어느 정도의 강도로 얼마나 해야 할런지에 대해서 이런 처방이 필요하겠고, 또 환자의 상태를 고려해서 프리시즌 엑서사이즈 처방이 필요한데요. 특히 저희가 mTOR 패스웨이라고 이제 하는 경우에 단백질 합성을 떨어뜨립니다. 그래서 이런 게 이제 항암제로도 쓰이게 되는데, 그렇기 때문에 이제 픽3 이니비터를 이제 사용하는 환자들의 경우에는 단백질 보충과 함께 근력 강화 운동을 더 열심히 시키는 것이 이제 필요한 거죠. 그리고 우리가 환자의 이제 치료 상태에 따라서도 치료를 하는 동안, 또 치료 직후, 또 환자의 유지기에 따라서 퍼스널라이즈드 엑서사이즈 프리스크립션이 이제 필요합니다. 그래서 특히 환자가 치료 중인 경우에는 우리가 이제 처방을 하고, 또 이게 치료의 이렇게 항암 치료 주기에 따라서도 환자의 상태가 왔다 갔다 하기 때문에, 치료 중에 만약에 환자가 힘들어할 때는 운동의 강도를 좀 줄여서라도 계속해서 운동을 지속하도록 하는 이런 것들이 또한 필요하겠습니다. 또한 환자들이 운동을 계속해서 하도록 하는 것 중요한데, 그러기 위해서는 패키지드 프로그램을 제공하고, 또 커뮤니티와 파트너십을 가지고, 또 엑서사이즈 프로페셔널들의 지식과 기술을 향상시키는 것이 필요하겠고, 또 지역사회에서 접근성을 이제 높이고, 또 슈퍼바이즈드 프로그램을 제공하는 것이 이제 도움이 되겠습니다. 그래서 이제 버추얼라이즈드, 이제 집에 가서도 환자가 계속 운동을 해야 되니까요. 암 환자들이 집에 있으면서 이제 집에서도 운동을 지속할수록 하기 위해서는 이렇게 버추얼, 또 슈퍼바이즈드 그룹 베이스드 엑서사이즈를 시키는 그런 연구가 작년에 이제 마스크 학회에서 발표가 됐었는데요. 이제 버추얼 슈퍼바이즈드 엑서사이즈를 하게 되면은 이제 인터넷도 연결이 돼야 되고, 환자들이 이런 프로그램도 쓸 수 있어야 되기 때문에 리크루트먼트 레이트는 이렇게 50% 정도밖에 안 됩니다. 그런데 환자가 한번 참여를 하면은 참여율이 굉장히 높고, 또 참여 이후에 지속률도 굉장히 높은 이런 결과들을 보여서 우리가 이런 것들을 또 한번 고려해 보면 어떨까라는 생각을 하게 되고요. 그리고 우리나라는 또 스마트폰이 굉장히 보편화되어 있기 때문에 환자가 집에서도 이런 핸드폰을 활용해서 어떤 모니터링을 계속하면서 관리를 하도록 하는 것이 또한 도움이 될 수 있겠습니다. 특히 엘더리 페이션트의 경우에는 환자들이 캔서 카케시아가 잘 생기거든요. 그래서 이런 캔서들은 한 50% 이상에서 캔서 카케시아 신드롬이 잘 생기는 암종들인데요. 우리가 캔서 카케시아가 있으면 보통은 이제 환자가 이제 근육량이 떨어지고 이제 이렇게 비쩍 말라 있고 이렇게 되니까 뉴트리셔널 서포트만 하는 경우들이 많은데, 단순히 이런 피딩만 열심히 해서는 도움이 안 되고, 환자가 이런 메타볼릭 홀이 생깁니다. 즉 머슬은 감소되면서는 이런 계속 카타볼리즘이 계속 증가가 되기 때문에, 이런 메타볼릭 홀을 감소하기 위해서는 운동을 함께하는 것이 도움이 되겠다라는 그런 것들이 우리가 이미 잘 알려져 있는 것들인데요. 그래서 엑서사이즈와 뉴트리션을 함께 제공하는 이런 연구가 또 진행이 되고 있고요. 그래서 애니토라는 이런 연구인데요. 여기에서는 이렇게 각 암종에 따라서 여러 기관에서 연구들이 지금 진행이 되고 있고, 이런 프로그램을 코디네이션 하는 것과 함께 이제 전체 이제 NCI에서 이런 것들을 이제 디렉션을 하고 있습니다. 그래서 보시는 것처럼 환자들의 치료의 톨러러비티에 따라서 또는 뭐 비헤이비어나 오간 펑션, 또 셀룰러 이뮨 펑션까지 이런 것들을 여러 가지를 디바이스를 통해서 이제 측정을 하면서 같이 이런 대규모의 연구들이 지금 진행이 되고 있고요. 앞으로 우리나라에서도 좀 이런 연구를 진행을 해보면 참 좋겠다라는 부러운 생각이 들었습니다. 그래서 우리가 이런 엑서사이즈를 이렇게 암 환자들에게 적용을 하기 위해서는 여러 가지 배리어들이 있는데, 이런 배리어들을 어떻게 우리가 해결을 할까를 고민이 되는데, 특히 여러 가지 배리어들 중에 가장 크게 문제가 되는 게 오가니제이셔널 문제였습니다. 그래서 우리가 어떤 이런 환자들을 잘 케어할 수 있는 시스템이 좀 필요하겠다라는 생각이 들게 되는데요. 그래서 우리가 환자를 케어하는 데 있어서 사실은 환자 중심적이 됩니다. 예, 그래서 그 환자가 어떻게 이것을 느끼는지 똑같은 치료를 받더라도 거기에 대한 부작용이나 이게 다 다르기 때문에 환자들의 느끼는 것을 직접적으로 확인하고 모니터링하는 것이 중요하겠고, 이제 보통 환자가 제시하는 것을 Patient Reported Outcome이라고 하는데요. 이런 페이션트 리포티드 아웃컴이 우리가 이제 케어 프랙티스나 또는 어떤 클리니컬 트라이얼뿐만 아니라 이런 디지털 바이오마커로서도 우리가 모니터링하고 관리하는 것이 중요하겠는데, 우리가 사실 진료실 안에서 환자를 이렇게 상담하고 처방하고 이러는데 굉장히 시간이 5분? 굉장히 짧습니다. 진료가 뭐 한 타임당 저희가 거의 막 50명씩 넘어가는 환자들을 이렇게 봐야 되는데, 이런 시간적인 제한 때문에 환자하고 이렇게 뭐가 힘든지를 충분히 이렇게 커뮤니케이션 하기가 어렵고요. 환자들이 실제로 의료진들한테, 이게 사실 미국 같은 데서도 진료 시간이 상당히 길어도 실제로 의료진한테 다 얘기를 못 한다고 합니다. 50%만 전달이 된다고 해요. 그래서 또 대부분의 증상은 집에 있으면서 나타납니다. 병원에 올 때는 거의 증상이 좋아져서 올 때거든요. 항암 치료 하러 오는 이기 때문에 집에 있으면서 환자의 증상이 생겼을 때 실시간으로 모니터링 하는 것이 또한 이제 필요하겠습니다. 그래서 저희가 이제 이런 ePRO라는 것을 활용을 해서 환자에게 디지털 페이션트 모니터링을 하는 것이 이제 필요하겠고요. 오전에 남병호 박사님께서도 이제 이런 얘기를 이제 해 주셨는데요. 아까 이 데이터도 아까 보여주셨죠. 그래서 환자들의 삶의 질이 좋아지고 응급실 방문율이 이제 떨어지고 심지어 생존 기간이 연장되더라. 그래서 생존 기간이 연장되는 그 이유는 이렇게 심통 모니터링을 했던 그 환자들이 훨씬 더 삶의 질이 좋아지면서 치료를 더 오래 받았습니다. 그래서 항암 치료 받았던 기간이 더 늘어났기 때문에 이런 생존 기간 연장도 있었는데요. 그래서 이 연구를 미국의 한 52개 기관에서 같이 연구를 진행을 했었고, 각각 한 600여 명 정도, 한 1200명 환자들이 이제 전체적으로 포함이 돼서 봤더니 환자들의 펑션 스코어가 좋아지고 또 환자들의 삶의 질이 전반적으로 좋아지더라. 또 심통 컨트롤도 잘 되더라. 이런 결과들을 이제 보였습니다. 그래서 저희가 스마트 캔서 케어라는 이런 프로그램을 저희가 개발을 했고요. 그래서 저희가 항암 치료를 받는 동안에 환자가 집에서도 리얼타임으로 어떤 증상이 생겼을 때 자신의 증상 정도가 어느 정도인지를 이제 스스로 체크를 하고 그 단계에 따라서 어떻게 관리하라는 그런 메시지를 주는 그런 프로그램이 되겠습니다. 스마트 캔서 케어라는 이 프로그램은 저희가 이제 항암 치료를 하는 4대 암종, 우리나라에 제일 많은 게 위암, 대장암, 폐암, 유방암이거든요. 그래서 이 4개의 암종에서 흔하게 나타나는 주요 증상들, 그리고 그 암종뿐만 아니라 또 항암제의 스페시픽한 그런 증상들이 있습니다. 그래서 그 증상들을 환자들이 이제 모니터링 할 수 있도록 하는 그런 프로그램이 되겠고요. 그래서 환자가 자신의 증상이 어느 정도인지를 이렇게 체크를 하게 되면은 저희가 그 단계가 어느 정도인지 마일드, 모더레이트, 시비어로 나누어서 이제 환자에게 리포트를 해줍니다. 그래서 마일드 같은 경우는 주로 이제 예방적인 단계에서 관리만 하면 되는 단계거든요. 예를 들어서 환자가 이제 노지아가 있긴 한데 식사는 다 정상적으로 할 수 있는 단계가 되겠고, 이때는 식사를 좀 더 어떻게 하세요라고 이렇게 가이드라인을 주면 되겠고, 모더레이트 단계는 이제 노지아가 있긴 한데 환자가 식사량이 좀 줄었다. 그러나 너무 아주 못 먹는 건 아니다. 이런 정도의 단계고, 삶의 질에도 어느 정도 유지가 되는 단계거든요. 그래서 이때는 우리가 치료적인 매니지먼트를 해주면 되겠고, 시비어한 단계는 저는 이거 구토 때문에 아무것도 못 먹어요 하는 그런 단계이기 때문에 이때는 이제 병원에 와야 됩니다. 그래서 그 각각의 단계에 맞게 이제 환자들에게 어떻게 관리하라는 이런 메시지를 주는 그런 프로그램이 되겠고요. 또한 환자들이 어떤 증상이 생기면 되게 궁금해합니다. 그래서 이게 지금 당장 병원에 가야 되는 거야, 어떻게 해야 되는 거야, 힘들어하시기 때문에 여기에 대한 정보들을 제공하는 게 되겠고요. 그럴 뿐만 아니라 환자분이 특히 이제 시비어한 심톰이 있는 경우에는 즉각적으로 병원에 오게끔 빨리 올 수 있게끔 해줘야 되기 때문에 이러한 경우에 있어서는 간호사 전화 상담을 같이 하는 그런 프로그램이 되겠고, 특히 이제 제가 유방암을 보다 보니까 이제 유방암 환자들은 항암 치료뿐만 아니라 뭐 수술, 방사선, 호르몬 치료 여러 가지 이제 변화들을 겪게 되거든요. 그래서 각각의 치료에 따른 이런 다양한 증상들이 있습니다. 그래서 뭐 항암이나 수술, 방사선 그리고 이제 뭐 재활과 관련된 여러 가지 문제들, 특히 페인이 있다거나 아니면 특히 머스큘러 스켈레탈 심통이 있다거나 또는 환자들이 림프이데마나 페리페랄 뉴로패시 이러한 문제들이 있는 것에 대해서 어떻게 또 관리하라. 그런 내용들을 담아서 저희가 스마트 캔서 케어 2.0을 이제 개발을 했고요. 그래서 이 부분에 대해서 저희 피저빌리티 스터디를 환자분 80여 명과 이제 의료진 20명 정도에게 이제 피저빌리티 스터디를 했을 때 평균 3.8, 3.9점으로 좀 높은 점수를 보였었고 이걸 가지고 저희가 RCT를 이제 진행을 했습니다. 그래서 보니까 각각 한 100명씩 인롤이 됐는데요. 전반적인 삶의 질이 이제 저희가 수술하고 나서 환자들을 이제 모니터링을 하면서 관리를 하기 시작을 했는데 보시는 것처럼 1개월, 3개월, 6개월째 점점 더 벌어지는 이런 결과들을 이제 보였고요. 그리고 피지컬 펑션도 주로 이제 3개월째 제일 많이 벌어지고 이제 조금 그 갭이 조금씩 줄어들게 되고요. 또 심통 컨트롤도 역시 이렇게 3개월째 더 제일 많이 벌어지는 이런 결과들을 보였습니다. 그래서 우리가 이런 증상들을 잘 모니터링하면서 사실 최근에 마스크 학회에서는 림프 이데마가 있는 환자들에서 어떻게 프로필락시스를 할 건지에 대한 가이드라인이 올해 발표가 됐고 그 가이드라인을 양은주 교수님께서 얼마 전에 또 발표도 해주셨었거든요. 그래서 저희가 환자들이 문제가 생기고 난 다음이 아니라 이렇게 심통 모니터링 하면서 그 증상에 맞게 또 환자의 상태에 맞게 적절하게 운동 치료를 같이 또 할 수 있도록 하는 그런 프로그램들을 한다고 하면 우리가 조금 더 환자의 삶의 질을 더 향상시킬 수 있지 않을까라는 그런 생각이 들고요. 그래서 앞으로는 환자의 상태에 맞는 맞춤형 이런 운동, 특히 또 웨어러블 디바이스나 이런 것들을 로 모니터링을 할 수 있기 때문에 환자에게 운동을 지속하게 할 수 있도록 하는 것이 필요하겠고 또 이러한 아까 뭐 벌추얼이나 여러 가지 모니터링 방법들을 통해서 환자가 좀 더 쉽게 운동에 접근할 수 있도록 하는 것도 필요할 것 같습니다. 이제 그러기 위해서는 저희 같은 종양을 전문으로 하는 의사들과 또 재활의학과 선생님, 또 치료하시는 선생님, 여러 선생님들이 함께 이런 고민들을 하면서 우리나라에 맞는 어떤 시스템들을 좀 만들어가면 좋겠고 또 이런 연구들도 같이 하면 좋겠다라는 생각을 하면서요. 네, 제가 더 앞으로 선생님들을 자주 뵙고 이런 연구들을 해나가면 좋겠다 하고 오늘 생각하는 자리였습니다. 네, 경청해 주셔서 감사합니다.
네, 고수진 교수님 감사드립니다. 자, 그다음 발표자는 세브란스 병원 가정의학과장님이신 이지원 교수님이십니다. 이지원 교수님께서는 그 메디컬 뉴트리션 분야를 개척하시고 활발하게 지금 연구를 하시는 교수님이십니다. 큰 박수로 환영 부탁드리겠습니다.
Thank you for your introducing me. Good afternoon, everyone. I'm Dr. Jiwon Lee from the Department of Family Medicine at Yonsei University College of Medicine. I'm honored to be allowed to present on the effect of the Mediterranean diet on metabolic profiles of breast cancer patients. Severance Hospital became the first hospital in Korea to establish a nutrition metabolism clinic in 2022. Offering integrated care from nutrition assessment to treatment. Over the past 5 years, we have conducted over 30 clinical studies on chronic diseases, metabolism, and nutrition, supported by multiple national government grants. I believe these experiences have given me the chance to speak here today. In today's presentation, I will cover breast cancer and diet, the Mediterranean diet, epidemiological studies using the Mediterranean diet adherence score, clinical studies on the Korean Mediterranean diet in breast cancer patients, both post and pre-treatment. According to the National Cancer Registration statistics, breast cancer accounted for 21.5% of all female cancers in 2021, ranking in first among women. Over the past 5 years, breast cancer cases have risen by 6.9%. Korea's 5-year survival rate for breast cancer is 86.6%, achieving a world-class level comparable to that of advanced countries. With the high prevalence and survival rate, highlight the importance of cancer prevention and proper management. According to the American Institute for Cancer Research report, 5 to 10% of cancers are due to genetic predisposition, and the remaining 90 to 95% are linked to lifestyle and environmental factors. Approximately 30% of cancers can be prevented by the healthy diet. Recommendation includes eat a diet rich in whole grains, vegetables, fruit, and beans. Limit fast food, processed food, red and processed meat, sugar-sweetened drinks, and alcohol consumption. Rather than focusing on individual nutrients, dietary patterns may be more effective for understanding nutrition and cancer. Numerous studies have shown that adherence to the Mediterranean diet offers protective effects against various cancers. Every year, U.S. News and World Reports with info from nutritionists, physicians, and dietitians evaluate and rank the best diet among 30 diets. They consider criteria such as how easy the diet is to follow, the ability to achieve weight loss, nutritional completeness, and safety, preventing and managing diabetes and heart disease. For 7 consecutive years, the Mediterranean diet ranked first as the best overall diet in 2024. It was followed by the DASH diet, known for helping with high blood pressure, and the MIND diet, which supports cognitive health. The Mediterranean diet is a plant-based diet with low saturated fat content, high monosaturated fats, and abundant dietary fiber. It includes vegetables, fresh fruits, legumes, non-refined cereals, nuts, poultry, a moderate amount of seafood and dairy products, a low intake of red and processed meat, and moderate alcohol consumption. The Mediterranean pattern was associated with reduced all-cause mortality and a 61% decrease in cancer incidence. In addition, a primary preventive effect of Mediterranean diet with extra virgin olive oil on breast cancer was reported. The figure shows how the Mediterranean diet may improve breast cancer outcomes by reducing inflammation, balancing of bacteria, providing antioxidant, lowering cholesterol, promoting autophagy, and preventing cancer cell growth. Indeed, a Mediterranean diet rich in fruits, vegetables, fish, olive oil, and whole grains present numerous advantages for the prevention and recurrence reduction of breast cancer, such as the following. Over the years, various methods have been used to estimate adherence to the Mediterranean diet through diet quality indices. Our research team developed the Korean Mediterranean Diet Adherence Score, K-MEDAS, modifying the original 14-point screener used in PREDIMED trials to better reflect the dietary habit of the Korean population. The 13 questions of the K-MEDAS are as follows. In the K-MEDAS, low consumption of meat, water, sugary drinks, sweet bread cakes, result in a higher adherence score. Scoring 10 or more points indicate adherence to a healthy dietary pattern. In addition, our research team recently developed the K-Kid Med questionnaire, which can be used with children and adolescents. Studies have shown that higher adherence to the Mediterranean diet, as indicated by a higher MEDA score, protects against cardiovascular disease, diabetes, hypertension, and other chronic diseases. Recently, an epidemiological study across 9 European countries found that breast cancer survivors with low Mediterranean diet adherence score had a 13-point higher all-cause mortality rate. Thus, adhering to a Mediterranean diet after a breast cancer diagnosis may improve long-term prognosis. I will introduce our research conducted on breast cancer patients. In creating therapeutic diets, we first gather evidence from epidemiological research and design diets based on that evidence. We then test the effectiveness through clinical trials and explore the underlying mechanisms with animal studies, completing a whole translational research process. To understand the dietary habits of breast cancer patients, we conducted a case-controlled study with newly diagnosed breast cancer patients and cancer-free controls from the Korean National Health and Nutrition Examination Survey. After propensity score matching, breast cancer patients consumed fewer calories and carbohydrates, but more protein and fat than the general population. They also had higher intakes of healthy foods such as fish, seaweed, vegetables, and so on. However, they also consumed more soup, stew, and red meat. This survey shows that newly diagnosed breast cancer patients exhibit some healthy dietary habits compared to the general population. However, there is considerable room for improvement in their diet quality. Our findings underscore the importance of tailored dietary recommendations for breast cancer patients during diagnosis and post-treatment to enhance diet quality. Overweight and obesity are linked to increased risk of cancer recurrence and mortality in breast cancer survivors. And therefore, our study aimed to investigate the combined effect of a Mediterranean diet and anti-obesity medication treatment on body weight, metabolic parameters, and quality of life in overweight or obese breast cancer survivors. To ensure ethical benefit for all participants, we provided education based on the Mediterranean diet and measured adherence. We also assessed whether anti-obesity medication offered additional benefits compared to the Mediterranean diet alone. We divided breast cancer survivors into 2 groups. Group A received the Mediterranean diet combined with anti-obesity medication, and Group B followed the Mediterranean diet alone. Both groups experienced similar weight loss and improved fasting glucose, insulin, and insulin resistance markers. However, combining the Mediterranean diet with anti-obesity medication did not demonstrate superior effect compared to the diet alone. This suggests that breast cancer survivors who consistently follow a Mediterranean diet can achieve weight loss compared to that seen with anti-obesity medication. In our following study, we evaluated the impact of a Mediterranean diet intervention on the extracellular vascular microRNA signatures of breast cancer survivors. Our findings suggest that the Mediterranean diet may have the potential to reduce the risk of breast cancer metastasis or recurrence. MicroRNA is a type of small RNA that can detect changes in the body before clinical symptoms appear. It is used to diagnose or treat diseases. The Mediterranean diet affected the expression of microRNA in extracellular vesicles. It was revealed that 36 out of 800 microRNAs were upregulated, and 6 was downregulated after the Mediterranean diet. In addition, pathway analysis found that these microRNAs were related to energy metabolism, blood sugar control, and insulin control mechanisms related to breast cancer. It seems that the Mediterranean diet can reduce the risk of breast cancer metastasis or recurrence. I wanted to develop a Korean version of the Mediterranean diet that aligns with Korea's unique dietary culture. This diet doesn't require traditional Mediterranean dishes like spaghetti, but fits naturally with Korean food preferences and traditions. We developed the Korean Mediterranean diet with a carbohydrate to fat to protein ratio of 5:3:2 and 500 kilocalories per serving. This diet features healthy fats with a balanced omega-6 to omega-3 ratio and has been patented. In 2020, we transferred this technology to as food, which led to the creation of Medisola, a company that now offers various home meal replacement products based on the Korean Mediterranean diet. With this Korean Mediterranean diet, our team also studies how this diet affects obesity-related gene variants, FTO and MC4R, in breast cancer patients. FTO gene variants are linked to increased fat accumulation, and MC4R variants are associated with impaired appetite control, contributing to obesity risk. Notably, we found that the diet effectively suppressed the function of obesity gene variants. Our findings highlight the Korean Mediterranean diet potential for mitigating the effect of these genetic variations and promoting better health outcomes. We randomized breast cancer patients into a Mediterranean diet group and a conventional diet group. We further divided each group based on the presence or absence of FTO and MC4R gene variants. Our findings revealed that patients on the Mediterranean diet experienced a reduced risk of obesity and improved metabolic markers, regardless of the presence of FTO and MC4R gene variants. In contrast, in the control group that did not follow the Mediterranean diet, those with FTO and MC4R gene variants were more prone to obesity and had worse metabolic indicators than those without the variants. This research is the first study to show that dietary interventions can overcome genetic predispositions to obesity. Our subsequent study, currently under review, involved an 8-week randomized controlled trial comparing the effect of a Mediterranean diet with a control diet in overweight or obese postmenopausal estrogen receptor-positive breast cancer patients. Following the dietary intervention, we conducted multi-omic analysis, making this the first study to explore the molecular changes driven by the effects of the Mediterranean diet. The clinical trial included human data analysis and animal studies, where mice were fed the same diet composition under identical conditions. We compared the Mediterranean diet and control groups to identify significantly differentially expressed genes and performed epigenetic sequencing to examine the relationship between gene expression and RNA changes. To the best of our knowledge, this study is the first to investigate the molecular alterations underlying the Mediterranean diet effect in a randomized control trial with humans and non-animal models. Multi-omic analysis identified key gene networks related to mitochondrial function, energy metabolism, inflammation, and cell proliferation, highlighting several genes, as shown on the slide. These findings elucidate the molecular mechanisms underlying the Mediterranean diet's health benefits. Cross-species validation in human and animal models demonstrated conserved molecular responses, underscoring the diet's translational relevance for metabolic and inflammatory health improvements. The research highlights the Mediterranean diet potential for personalized nutrition strategies to enhance metabolic and cancer-related outcomes. Before undergoing breast cancer surgery, patients often experience anxiety and a waiting period without any intervention. Our ongoing study, in collaboration with Professor Jung Jun in Gangnam Severan's Breast Surgery Department, aims to evaluate the impact of the Mediterranean diet before surgery. The study focuses on estrogen receptor-positive breast cancer patients, examining whether a short-term Mediterranean diet intervention during the pre-surgery waiting period can influence the expression of Ki67, a marker of tumor cell proliferation, and other breast cancer-related target genes. Additionally, we aim to determine if combining the Mediterranean diet with hormone therapy can synergistically reduce Ki67 expression. Since Ki67 is closely associated with cancer growth and serves as a critical indicator of prognosis and outcomes, a reduction in its expression following a Mediterranean diet intervention would suggest potential benefits in preventing and reducing breast cancer recurrence. Although our clinical study is ongoing, we hope for positive results. This is the last slide of take-home message. The Mediterranean diet significantly benefits metabolic health and breast cancer risk reduction by reducing inflammation, providing antioxidants, lowering cholesterol, promoting autophagy, and preventing cancer cell growth. Clinical results using the Mediterranean diet adherence score indicate that adherence to this tailored diet can lead to weight loss, improve metabolism, and alter microRNA expression, potentially reducing breast cancer recurrence and metastasis risk. The Korean Mediterranean diet can mitigate genetic predispositions to obesity and improve metabolic markers in breast cancer patients, while driving molecular changes that may lower cancer recurrence, as demonstrated through both clinical and multi-omic analysis in human and animal models. The Korean Mediterranean diet effectively enhances metabolic health and offers tailored, evidence-based dietary interventions for breast cancer prevention and patient care. Thanks to the researchers in our research team. Thank you for your attention.
네, 이지원 교수님 감사드립니다. 자, 이번 세션 마지막 발표자는 연세대학교 스포츠영상학과 전영광 교수님이시고요. 어떻게 소개를 시켜드릴까 제가 고민을 하다가 저희 전영광 교수님은 지금 살루토제네시스 이 개념을 여러 분야에 적용해서 활발하게 지금 연구 중이시고 체육학의 다양한 분야에서 고트, GOAT이신 것 같아요. Greatest of all time. 그냥 그렇게 저는 생각을 합니다. 그래서 전영광 교수님 큰 박수로 환영 부탁드리겠습니다.
네, 정말 너무 과찬을 말씀해 주셔가지고 감사드립니다. 오늘 발표는 제가 앞에 부분 한 10분 하려고 그랬는데 제가 한 6분 정도로 줄이고 제가 박흥세 대표님을 모셔서 좀 말씀을 듣는 식으로 하려고 합니다. 살루토제네시스가 뭔지 개념 좀 잠깐 설명드리고 제가 어떻게 엑서사이즈 온콜로지라는 분야를 시작하게 됐는지 간략하게 설명드리도록 하겠습니다. 저는 캐나다 알버타 대학교에서 석사하고 박사를 했고요. 그 다음에 제가 하버드대학교 의과대학 가서 거기서는 주로 제가 브레인, 뇌 쪽에 주로 연구를 했고 인슐린 저항성 관련되어진 그리고 비만이 어떻게 염증을 유발하고 그게 당뇨병이라든가 심혈관 질환, 암을 유발하는지 그런 쪽 연구를 하다가 그리고 또 운동하면 어떻게 되는지 연구를 하다가 연세대학교에 와서 지금 제가 이제 거의 20년째 되고 있습니다. 조금 전에 사실 발표하신 우리 이지원 교수님과는 다양한 우리 임상 연구들을 거의 20년 동안 같이 진행해주고 계신데 이렇게 발표도 해주셔서 너무 오늘 감사드립니다. 근데 제가 이제 2010년부터 이런 암에 대해서 관심을 갖게 됐는데 왜 그랬냐면 제가 수업 시간에서 치료 레크레이션 시간에 만약에 말기 4기인데 그러니까 뭐 터미널 캔서라고 우리 얘기를 하지만 사실 요새 그렇게는 잘 안 하는 표현이긴 한데 그런 분들이 만약에 마지막 한 달 남았다고 할 때, 2달 남았다고 할 때 그때를 최대한 행복하게 살 수 있도록 우리가 많이 도와드리면 근데 그렇게 행복하게 살다 보면 더 오래 살지 않을까? 라는 생각을 제가 자연스럽게 하게 됐고 수업이 끝나고 제가 와서 펀메드에 검색하기를 운동과 캔서 모탈리티라고 쳐봤더니 이 논문이 떴어요. 그래서 이 논문은 일주일에 전혀 운동을 안 하는 사람에 비해서 3시간 이상 걷기 정도의 운동만 해도 유방암 환자가 재발과 생존율이 거의 2배가 아까 재발이 반으로 줄고 생존율이 2배 이상 올라간다는 얘기를 보고 와 이건 정말 대단하다. 운동이 이렇게 좋은지 몰랐다. 저도 이제 운동에 대한 연구를 했지만 이 정도로 좋은지 몰랐던 거예요. 그래서 그 대장암 환자도 그런 비슷한 효과를 나타낸다는 걸 알게 됐고 그러면서 왜 제가 그거에 대한 이해도가 있었냐면 옛날 제가 연구하던 게 운동하면 암 환자에게 늘어나는 게 오늘 막 염증 막 여러 가지 얘기 나와 있는데 이게 비만하면 염증이 올라가고 그게 또 암을 유발하게 되어지고 또는 비만하면 인슐린 저항성을 유발하고 인슐린이 올라가서 그게 암세포의 에이포프토시스를 억제하고 암세포가 잘 자라도록 하는데 그거 운동하면 다 좋아지거든요. 근데 운동하면 실제 저게 좋아지는지 본 연구가 이때만 해도 없었어요. 2010년도에. 그래서 제가 이지원 교수님하고 함께 그리고 우리 추상희 교수님하고 함께 우리 김남기 교수님을 찾아가서 이거 우리가 이런 연구를 좀 할 수 있도록 좀 도와주세요라고 제가 인사드리려고 했는데 김남기 교수님께서 오히려 저한테 환자들이 맨날 운동 뭐 해야 되냐고 물어보는데 뭐라고 얘기할지 몰라서 그냥 걸으라고만 한다. 제발 scientific 베이스, 과학적 근거 기반 운동 프로그램을 만들어주라라고 저희한테 요청을 하셨고 그래서 저희가 어떻게 하면은 과학적 근거 기반으로 운동 프로그램 만들 수 있는가 하고 봤더니 없어요. 그런 시스템 자체가 있지 않고 많은 연구들이 막 메타 분석했다고 하는데 실제로 그러면 운동을 일주일에 몇 번을 어떻게 시키는 게 좋은지에 대한 그런 것들이 사실은 이게 하여튼 그렇습니다. 그래서 처음에 저희들이 이런 메타 분석을 하고 그 다음에 환자들을 서베이해서 환자들이 원하는 운동이 뭐고 환자들이 왜 운동을 못하는지 환자들은 왜 운동을 좋아하는지 하고 싶은지 이런 것들을 이해하고 그거에 근거해서 이런 외과, 내과, 종양내과 그리고 뭐 재활의학과 뭐 저희 이렇게 만나서 운동 프로그램을 만들고 파일럿 스터디를 하고 그리고 나서 환자 인터뷰를 하고 요 과정이 어떨 때는 한 번 하지만 어떨 때는 2번, 3번을 이렇게 반복해 돌아서 환자들에게 최적화된 안전한 운동들을 만들고 그 다음에 그걸 가지고 다시 한번 개정해서 우리가 이 효과성 검증을 하는 랜더마이즈 컨트롤 트라이얼을 하는 식으로 10단계로 저희들이 이 과정을 만들게 되었고 이렇게 한번 과정을 다 돌고 나면 논문들이 사실 쭉 나오게 돼서 한 10편, 15편 이상의 논문들이 저런 과정 중에서 발표가 되게 됐습니다. 그래서 이런 연구를 이렇게 저희들이 어떻게 저 10단계를 할 수 있을지에 대한 논문들을 저희가 퍼블리시했고 저게 대장암으로 시작을 했지만 요새는 유방암, 부인암, 뭐 전립선암 다양한 암으로 저희들이 확장을 해서 감사하게도 지난 한 15년 동안 우리 정말 대학원생들과 우리 여기 김수 교수님도 계시는 다양한 콜라보레이터들이 많이 도와주셔가지고 암 관련 논문들을 운동과 암 관련 논문을 거의 한 80에서 100편 정도 저희들이 하면서 이런 지식들이 이렇게 많이 쌓이게 된 것 같아요. 이게 이제 저희가 앞에 파트인데 그런데 저는 운동과 다이어트 너무나 중요한 줄 알고 그렇게 하면 다 되는 줄 알았는데 이걸 봤더니 운동, 다이어트, 금연 열심히 하면 사망률이 68% 낮추는데 친구들 만나고 수다 떨고 성격 좋으면 사망률이 65% 낮춘다는 거예요. 그래서 야 이거 그러면 라면을 친구랑 먹으면 좋은가? 운동 혼자보다 함께 하는 게 좋은가? 이거 도대체 무슨 의미지? 라고 보니까 실제로 주변 많은 사람들을 많이 만나지 않고 사회성이 결연된 경우 유방암으로 인한 사망률이 높고, 예를 들면 자원봉사 안 하고 종교활동, 문화활동 안 하고 친구들 만나지 않는 경우 유방암으로 인한 사망률이 높다. 그래서 와 이거 운동만이 아니라 이런 전체적인 개념을 우리 바라보는 게 중요하겠다라는 생각에서 저희가 찾아보던 중에 살루토제네시스라는 개념을 알게 되었는데요. 이거는 최근에 나온 개념이긴 한데 여기 보시면 논문이 벌써 4,300개 이상 논문들이 발표가 되어졌고, 그리고 여기 보면 이 첫 번째 이게 이 살루토제네시스 개념을 설명한 논문은 17,000번 인용된 거예요. 그러니까 이 정도 인용되면 이 분야를 새로 만들었다는 얘기고 이게 지금 확산되어지고 있다는 얘기인데, 그래서 살루토제네시스를 알아야겠다는 생각이 들었고, 이 살루토제네시스의 개념은 뭐냐면 살루스가 이 건강과 웰빙의 여신의 이름이고, 그리고 제네시스는 오리진, 그거의 근원이 무엇인가에 대한 거예요. 그러니까 지금까지 우리가 얘기한 오늘 하루 종일 얘기한 거는 패토제네시스에 대해서 얘기를 했어요. 어떻게 하면 그 질병의 원인을 알아서 그게 뭐 우리가 마이오카인도 했고 여러 다양한 걸 했는데 질병의 원인이 뭔지를 알아서 그거를 제거해주면 건강해질 줄 알았어요. 그런데 그렇지 않은 경우가 많다는 거예요. 근데 이 살루토제네시스는 뭐냐면 질병의 원인이 아니라 건강의 오리진이 뭐냐, 건강의 오리진이 뭔지를 알아서 그거를 what makes people healthy, 그러면 그거를 하면 되지 않겠냐라는 게 개념이 이 살루토제네시스의 개념입니다. 그래서 우리가 모두 다 스트레서, 이런 삶에 살다 보면 뭐 부도도 나고 뭐 친구도 배신하고 뭐 사이도 안 좋고 이런 것들이 스트레서가 되면 텐션을 유발하는데, 이 텐션이 유발했을 때 이거를 잘 극복하면 살루토제네시스로 더 건강해지지만 이거를 극복하지 못하면 패토제네시스가 돼서 그때 가서 몸이 망가지고 암이 재발하고 여러 가지 안 좋은 일이 생길 수 있는 거죠. 그래서 요거를 어떤 사람이 그러면 저렇게 살루토제네시스로 잘 가냐 했더니 세 가지인 거예요. 하나는 comprehensibility가 높은 사람이에요. 자기가 처한 상황과 자기가 처한 질환들 이런 것들을 잘 이해하고 자기가 어떻게 자기 생활을 바꾼다던가 암을 극복하기 위해서 내 주변의 자원들을 어떻게 잘 활용하고, 그리고 자기의 처한 상황에 대한 이유를 찾는 사람, 이런 거죠. 예를 들면 이런 사람이 있어요. 안 좋은 일이 생기면 더 좋은 일이 생기려나 보지 뭐. 이런 사람들이 자기가 처한 상황을 잘 극복하고, 그리고 오히려 포스트 트라우마틱 그로스라 그래서 PTSD가 아니라 PTG로 잘 가더라. 그래서 이거를 살루토제네시스를 높이는 게 중요한데, 왜냐하면 예전에 패토제닉 어프로치는 sick and healthy예요. 바이너리. 둘로 나눠서 보니까 이 사람은 환자야? 정상이냐? 우리 이렇게 보던 개념에서 이 살루토제닉은 뭐냐면 디스이즈와 이즈의 컨티뉴엄인 거예요. 그러니까 정말 안 좋으면 죽음이고 정말 좋아서 드라이빙, 완전히 잘 사는 우리는 그 중간에 어딘가에 있는 거지, 우리가 아프거나 안 아프거나 이렇게 둘로 나눌 수 없다는 거예요. 그래서 우리가 이런 컨티뉴엄에서 그렇게 하다 보니까 옛날에 병원에 오는 사람들이 진단받은 사람만 우리가 치료를 했다면, 이제는 진단받기 전인 사람도 더 건강해질 수 있도록 해주는 그런 어떤 어프로치, 이런 게 너무나 중요하고, 그거에 운동, 식습관만이 아니라 이런 살루토제닉 라이프 스타일이 너무너무 중요하다. 그래서 예전에는 이렇게 큐레이티브 케어는 이렇게 물에 빠져 죽기 전인 사람을 건져내고, 지금 우리 의학이 다 이렇게 하고 있잖아요. 시케어를 하고 있는데, 그게 아니라 이 프로액티브 헬스케어를 넘어서 살루토제닉 헬스케어로 나가서, 우리가 의료비를 보면 거의 엔드 오브 라이프의 의료비, 우리나라 의료비의 상당 부분, 거의 대부분 거기 막 쏟아지고 있는데, 그거를 좀 미리 땡겨서 청소년들한테 살루토제닉 환경 만들고, 암 생기기 전에 우리 많은 국민들이 운동하게 하고, 이렇게 하자고 하는 게 이런 살루토제닉의 관점입니다. 그래서 살루토제닉이 기존의 시케어하고 이게 대비되는 개념이 아니라, 지금 사실 저희 연구의 대부분은 시케어들을 어떻게 운동을 해서 건강하게 하는 걸 저희 연구하고 있어요. 근데 그것도 살루토제닉이 될 수 있는 거예요. 그래서 살루토제닉이라는 거는 기존의 시케어, 리액티브 헬스케어 이런 거를 모두 포괄한, 정말 우리가 어떻게 하면 더 건강해질 수 있나 하는 그런 더 큰 개념이라고 생각할 수 있습니다. 자, 여기까지 제가 사실은 7분 좀 넘은 것 같은데, 이 정도 얘기하고, 이 살루토제닉을 몸으로 사신 분이 한 분 계신데, 제가 소개를 해드리고 싶은데, 박흥세 대표님은 제가 연세대학교 오자마자 저희가 옛날에 막 비만 캠프하고 할 때 우리 선배님하고 같이 막 일을 하고 했었어요. 그런데 어느 날 갑자기 우리 박흥세 대표님께서 암이 발병을 하셨는데, 그게 사실은 오래 전인데 지금도 사실 너무 건강하게 살고 계셔서 우리 박흥세 대표님을 앞으로 모셔서 좀 살루토제네시스와 본인의 라이프에 대한 얘기를 좀 듣도록 하겠습니다. 네, 맞습니다.
박흥세 대표님 박수 한번.
14년 차 암환우 박흥세입니다. 보시는 바와 같이 저는 대학에서 20여 년 동안 강사로만 대학에서 20년 동안 강사로만 버티기가 쉽지 않아요. 그리고 이제 스포츠와 레크레이션 관련돼서 1000번 이상의 행사를 성공적으로 한 경험이 있는 그래서 이렇게 대학생들과 그린맵 대장정도 한 10년 정도 했고요. 이렇게 연예인들하고 행사도 많이 하고 또 스포츠와 관련된 평창올림픽 관련돼서 행사도 기획하고 또 G-3년 총연출도 했습니다. 그런데 어느 날 갑자기 저한테 암이 찾아왔습니다. 근데 사실 뭐 암이 갑자기 찾아왔을까요? 그 전부터 사실 조금씩 커져가고 있었겠죠. 그래서 이렇게 보면 2011년 신장암 1기, 그래서 아주 가볍게 5.7cm였지만 다른 데로 전이가 안 돼서 1기라고 그러더라고요. 아주 가볍게 수술하고 끝났습니다. 그런데 수술하고 나니까요 너무 아픈 거예요. 그런데 수술하고 끝나자마자 이튿날부터 제 배를 보니까 복강경으로 수술했는데도 호치키스를 막 찍어 있고 핏자국이 있더라고요. 그런데 내가 윗몸 일으키기 한번 해볼까? 하고 윗몸 일으키기를 했더니 그렇게 되는 거예요. 그래서 이튿날부터 윗몸 일으키기도 하고 운동도 했죠. 근데 의사 선생님이 이건 뭐 수술로 끝나는 거니까 그냥 사시는 대로 잘 먹고 그냥 똑같이 살면 돼요. 이렇게 얘기를 해준 거예요. 그래서 제가 그 암을 너무 가볍게 생각했다라는 것을 지금 생각하면 큰 오차였던 것 같습니다. 그래서 이제 5년이 지나서 이제 암 완치 판결을 받으려고 갔는데 담낭으로 전이가 됐다고 그러는 거예요. 원격 전이라고 그러더라고요. 그래서 또 가볍게 쓸개를 담낭을 또 수술해서 제거를 했죠. 그리고 이제 병원을 좀 옮겨봐야 되겠다. 좋은 병원, 세브란스 병원으로 옮겨봐야 되겠다 해서 라선영 교수, 저랑 이제 학번이 좀 비슷하고 인맥으로 이렇게 가서 이제 치료를 받게 됐어요. 그런데 그 교수님이 하는 얘기가 피검사를 할 때마다 야, 일반인보다 더 좋으네. 암으로 죽지는 않을 것 같은데요. 그러면서 죄송합니다. 제 표현이 뭐 다른 표현이 없어서 의사 선생님이 좀 빈정대듯이 저한테 얘기를 하시는 거예요. 그냥 이렇게 그냥 왔다 갔다 하라 이거예요. 그런데 2018년 폐에 암이 생겼어요. 그랬더니 아이고 암이 생겼네요. 수술할래요? 수술할래요? 항암하실래요? 그래서 제가 그때서부터는 좀 진지해졌습니다. 깊게 생각하고 아무것도 안 하겠다고. 그리고 그냥 지나갔어요. 그리고 계속 검사만 했어요. 그런데 2020년 췌장으로 또 전이가 된 거예요. 의사 선생님이 이제는 항암을 해야 됩니다. 위험합니다. 제가 여러분 몸에 췌장에 암이 생겼고 폐에 암이 있고 그렇다고 그러면 여러분 제가 웃으면서 얘기하지만 여러분들은 어떻게 생각하겠어요? 저도 하루 종일 우울했어요. 그리고 눈물도 조금 나고 우리 자녀들은 어떡하지? 그런 걱정이 되더라고요. 그런데 제가 이제 깊게 생각해 보니까 항암을 하면 부작용도 많다고 그러는데 내가 이제 암이 왜 생겼는지 아주 곰곰이 생각하면서 말기암 환자 중에 살아남은 사람들을 이렇게 수소문 해서 찾아가서 그 사람한테 얘기를 그대로 들었어요. 저분을 따라하면 나도 살 확률이 크겠다. 그래서 강원도와 양평에서 자연치유를 2년 동안 했는데요. 사진을 찍어보니까 암이 하나도 안 자라고 그대로 있었던 거예요. 자연치유라는 건 가만히 있는 게 아니라 자연에서 걷기도 하고 텃밭도 가꾸고 하늘도 바라보고 이런 아주 좋은 생활을 한 거죠. 그러니까 저는 오히려 사람들이 만날 때마다 암 환자가 얼굴이 왜 이렇게 점점 좋아져? 이러더라고요. 그런데 2년 동안 있으면서 경제활동을 못하니까 나 이제 이렇게 건강한데 다시 옛날처럼 일을 해야 되겠다. 그리고 일을 했는데요. 더 열심히 하게 되더라고요. 그러자마자 이제 췌장에 있는 암이 커지기 시작한 거예요. 그래서 이제는 현대의학의 도움을 받아야 되겠다 해서 이제 그 혈액 종양내과에 가서 면역항암 키타루타 27차 표적항암 18개월을 쭉 받으면서 췌장에 있는 암이 거진 4cm에서 2cm로 줄이는데 걸리는 시간은 약 20개월이 걸렸어요. 20개월. 그러다가 다시 커지기 시작하는 데는 1, 2개월 만에 20개월 동안 들어간 비용이 1억 원이 넘는데 다시 그 암이 커지는 시간은 한두 달 만에 다시 암이 커지기 시작한 거예요. 그리고 또한 그 암이 좌측 허리 쪽에 전이가 돼서 이제는 다른 치료가 방법이 없으니 방사선으로 허리와 췌장과 폐를 동시에 하자. 그래서 총 46차를 했습니다. 많은 사람들은 방사선 10차 하기도 힘들었는데 46차 하면서 멀미도 나고 어지럽고 왜 이렇게 피곤한지 몰랐어요. 그런데 저는 제가 한 가지 터득했던 것은 하늘이 무너져도 솟아날 구멍이 있는데 그동안 내가 해왔던 운동 또 내가 어렸을 때부터 어려울 때마다 기도를 했었던 하나님을 찾아야 되겠다. 그러면서 본격적으로 이제 그 자연치유와 운동과 병행하는 그러한 삶을 살았습니다. 근데 이 다시 허리에 암이 작아지고 좋아지는 것 같더니 다시 허리가 너무나 아픈데 어느 정도로 아프냐면 고무줄로 탱탱 이렇게 묶는 그런 아픔이 계속되는 거예요. 그러니까 나는 아무것도 안 했는데도 옷이 젖어 있어요. 너무나 통증이 심해서. 그래서 병원에 갔더니 다시 방사선을 15차를 추가로 하자고. 그런데 말이죠. 이거 100% 또 전이가 됩니다. 그래도 뭐 방법이 없어서 15차를 해서 총 66차의 방사선을 했는데요. 한 달 만에 그 암이 뇌로 전이가 된 거예요. 그래서 이제 산에 오르고 맨발 걷기 하고 내 몸이 너무 좋아지는 것 같은데 한 이틀 전부터 쓰러지기 이틀 전부터 카톡에 문장 구성이 안 되는 거예요. 친구들한테 카톡을 보내는데 문장이 엉망이라는 거예요. 그러더니 어느 날 산에서 내려오면서 저도 모르게 툭 쓰러졌어요. 다행히 손을 쓰러지면서 이렇게 돼가지고 얼굴은 멀쩡하고 코만 살짝 나갔는데 주변에 청년들의 도움으로 이제 응급실을 가게 됐어요. 응급실에서는 큰 암이 4개 정도가 있는데 한 달 살 것 같다. 요거는 제가 얼마 전에 방사선 의사 허락을 받고 사진을 찍어 왔는데요. 2024년 4월 12일 요 하얀 거, 요 부분, 요게 암입니다. 이런 게 4개가 있었는데 스테로이드를 먹고 또 방사선 치료를 하고 석 달 만에 다 없어지는 것 같이 이렇게 된 거예요. 이럴 때 박수 한번 보내주셔야 되는데. 근데 그냥 된 게 아니라 3일 동안 병실에서 제가 보통 난리를 친 게 아니래요. 그래서 간호사들이 5명이 저를 붙잡고 처치실에 갔었고 저는 이제 3일 후에 깨어나서 어떤 치료를 했냐면 말이 안 나오는 겁니다. 혀가 굳어가지고. 그래서 성경책을 펴고 그 성경책을 주기도문을 계속 읽기 시작했어요. 3일 만에 발음이 정상으로 돌아왔어요. 그리고 링게로 꽂은 상태로 병원 문 밖을 나갔어요. 그 환자가 어디 간 거야? 간호사들이 막 찾았는데요. 병원에서 탄천 그 거리를 1시간 동안 오전 1시간, 오후에 1시간 누가 가지 말라고 그래도 제가 걸었는데요. 마침 이날이 봄이 되는 그런 날씨였는데 따뜻한 햇볕이 제 몸으로 쫙 들어오면서 제가 이런 걸 느꼈어요. 나 한 달 산다고 그랬는데 계속 살 것 같은데? 이런 느낌이 드는 거예요. 그래서 3주간을 하루도 빠지지 않고 오전 오후로 제가 걷기 운동을 했죠. 그러면서 제가 내 몸에 생긴 암의 원인은 무엇인가 올바르게 진단하는 게 굉장히 중요한데요. 지금은 병원에서 병리학적인 것에만 치중을 했는데 제가 생각해 보니까 물을 먹지 않았어요. 야채를 먹지 않았어요. 그래서 물을 먹지 않아서 하루에 소변을 2번밖에 안 봤어요. 그것도 조금만 나오고 소변 색깔이 노랗더라고요. 그리고 이렇게 여러 가지 이런 내면적인 그런 그 원인이 있었어요. 그래서 제 몸속에는 병리학적인 이유도 있었지만 마음적인 이유가 더 많이 있었습니다. 욕심과 가로로 인해서 그 암이 찾아왔던 것을 저는 스스로 깨우쳤어요. 그래서 하나님은 이 암을 통해서 저에게 강제적인 쉼을 주신 것 같아요. 그래서 건강은 단순히 육체적인 질병뿐만 아니라 마음의 질병이다. 그래서 병원에서는 우리가 의학적인 도움을 받고 제 나름대로 이렇게 암 치료를 제 자가 치료를 방법을 했습니다. 그래서 제가 살려고 강원도에 갔었고 믿음 생활을 하고 태도를 바꿨습니다. 매일 기도하기, 찬송하기, 성경 보기, 동물 먹이 주기, 또 내가 잘못했던 일을 회개하고 남을 용서하지 못한 것을 용서하고, 그리고 음식을 가려서 먹고 균형 있게 먹고, 그리고 매일 빠지지 않게 2시간에서 저는 한 4시간까지 2시간에서 한 4시간까지 제가 운동과 활동을 끊이지 않게 했습니다. 그래서 제가 이렇게 지금 건강하고 병원에서 누워 있는 시간 외에는 건강하게 또 이렇게 활동도 하고 한 번도 일을 안 한 적이 없습니다. 그래서 역시 치료비도 많이 들어갔지만 제 재산도 줄지 않고 또 여러분과 이렇게 좋은 시간을 갖게 됐는데요. 가장 저한테 큰 힘이 됐던 것은 무릇 지킬 만한 것 중에 더욱 내 마음을 지켜라. 생명의 근원이 이에서 남이라. 제 마음을 지키면서 치료하는 것이 도움이 되었다고 합니다. 좀 길게 해서 죄송합니다. 네. 마음의 즐거움은 양장이라도 사람의 근심은 뼈를 마르게 하느니라. 이렇게 성경 구절을 매일매일 써서 벽에다가 쫙 썼는데요. 300개의 성경 구절을 벽에다 쓰면서 들어갈 때 읽고 나갈 때 읽고 이런 식으로 했는데 그게 치료에 정말 도움이 많이 된 것 같습니다. 그래서 저는 오늘 늘 감사하는 마음을 했고요. 이렇게 제가 바닷가를 걷기, 또 황토길을 걷기, 또 여기 아까 우리 교수님 말씀 중에 나오는데 치앙 태국에 가서 시골에 가서 선교 활동도 하고 레크레이션도 활동도 하는 이러한 활동을 통해서 현대의학과 또 운동과 마음의 치료를 같이 한 사례를 여러분에게 전달하면서 마치도록 하겠습니다.
네, 여기 같이 계셔도 됩니다. 네. 사실 제가 선배님 전화를 4월 달에 받고 너무 깜짝 놀랐거든요. 말씀을 잘 못 하시더라고요. 그래서 어떡하지? 네, 그랬는데 연락이 안 오시는 거예요. 네, 근데 사실은 한 3개월 전에, 2개월 전인가 제가 그 심장의 날 걷기 대회를 가서 행사를 하려고 갔는데 거기서 행사를 진행하고 계시더라고요. 저는 병원에 누워 계신 줄 알았는데, 그래서 선배님 저희 우리 심포지엄 하는데 꼭 와서 한번 말씀해 주세요라고 말씀드렸는데 이렇게 또 말씀해 주셔서 너무너무 감사합니다. 감사합니다. 네. 제가 이제 슬라이드 하나만 보여드리고 마치려고 합니다. 그러니까 우리가 이 하드 사이언스, 저는 되게 하드 사이언스를 하는 사람 중에 하나라고 생각하거든요. 그 말은 우리가 다 랜더마이즈 컨트롤 트라이얼 하고 그런 애니멀 스터디 하고 저희가 분자 생물학 연구하고 제가 원래 그렇게 하는 사람인데 최근 들어서 그거를 넘어서는 것들도 있는 것 같다는 생각이 더 들어요. 그래서 우리가 물론 우리 아까 패토제닉 연구해서 정말 질병의 원인인지 뭔지 알아서 그걸 운동을 통해서 다 제거하는 것도 해야겠지만 정말 우리가 더 어떻게 하면 더 살루토제닉한 라이프를 살지. 왜냐하면 그렇게 연구하는 사람이 제일 사실은 패토제닉한 라이프 스타일을 사는 경우가 많아요. 저도 찔리는데 운동 연구원으로 바빠서 운동 못하고 막 그런 일이 생기긴 하는데, 그럼에도 불구하고 더 이렇게 긍정적인 그런 아까 3가지 comprehensibility, manageability, 그리고 meaningfulness. 그래서 이 연구를 보니까 이렇게 삶의 자기 목적을 뚜렷하게 아는 사람들에 비해서 그렇지 않은 사람들은 2.24배 사망률이 더 높대요. 그러니까 우리가 운동을 왜 하는지 꾸준히 이해하고 하는 것도 중요하다고 생각합니다. 제가 사실 더 말씀드리고 싶은 건 많지만 이 정도 해야 또 우리 또 질문도 받게 하기 때문에 이 정도로 마치도록 하겠습니다. 감사합니다.
감사합니다. 저희 시간이 약간 초과되긴 했지만 발표자분들 잠깐 앞으로 보시고 질의응답 시간을 좀 가질까요? 네. 의자 좀 부탁드리겠습니다. 강조 대표님께 혹시 질문 있으신 분 자유롭게 하시면 될 것 같습니다.
이주원 교수님께 질문 하나. 여기는 한국어 세션. 네, 한국말로 하시면 됩니다.
이주원 교수님께서 여러 가지 그 영양과 관련된 그런 좋은 자료들을 보여주셨는데 여러 식단들을 실제로 보여주셨잖아요. 근데 그 중에서 그 메디테리언 다이어트 같은 경우가 1위로 뽑혔다고 얘기를 하셨는데 이게 식단들을 보면은 되게 비슷하게 오버랩되는 부분들도 많이 있잖아요. 뭐 이렇게 채소를 많이 먹고 과일을 많이 먹고 뭐 리파인드 칼 같은 거 덜 먹고 뭐 이런 식으로 겹치는 것들이 있는데 그럼 특히 이 지중해식 식단에 있어서의 좀 어떤 특별한 그런 장점들이 있는지 그런 어떤 부분들이 좀 이렇게 뭐 대사 질환이라든지 이런 암과 관련된 부분에 있어서 효과가 있다고 생각하시는지 그런 부분들 좀 한번 의견 들어보고 싶습니다.
사실 이게 뭐 지중해 시기가 1위로 계속 뽑히기는 했는데요. 이게 지중해 유네스코 뭐 문화유산으로 지정돼서가 아니라 이 다이어트가 가진 퀄리티하고 그다음에 캐릭터리스틱스 때문에 사실은 뽑혔다고 생각해요. 아까 슬라이드에 나오긴 했었는데 여러 가지 뭐 안티 인플라마토리, 안티 옥시다티브 뭐 이런 효과가 있고 어토파지를 좋아지게 하고 그다음에 프로그램드 셀 데스를 갖다가 좋아지게 하고 그 밖에 여러 가지 대사적인 콜레스테롤을 낮춘다든지 아니면 안티 오베시티 효과라든지 이런 게 여러 가지가 있습니다. 근데 보면 1위, 2위, 3위 이렇게 보면 1위가 메디테라니안, 2위가 아까 대시, 그 다음에 3위가 마인드였는데 비슷하기도 했긴 했었는데 정말 비슷한 캐릭터리스트를 갖고 있어요. 몇 년 전에는 사실은 1위가 지중해식이고 그 다음에 2위가 대시고 3위가 플렉시테리언이었어요. 근데 보면 저희가 보통은 정말 뭐 하이 카보냐 아니면 하이 팻이냐 이런 거를 많이 따지잖아요. 근데 1위는 사실은 하이 팻 다이어트였고 엄밀히 말하면 메디테라니안 다이어트는 하이 팻 로우 카보하이드레이트 다이어트입니다. 그다음에 사실 2위 대시 같은 경우에는 밸런스 다이어트라고 해서 보통 USA랑 그다음 우리나라랑 레코멘데이션 하고 있는 비율이에요. 보통은 카보하이드레이트가 60% 조금 넘는 거를 권장하고 있고 그다음에 플렉시테리안 같은 경우에는 사실은 하이 카보 그 다음에 로우 팻이거든요. 그래서 어떻게 보면 굉장히 다른 다이어트 같지만 제가 보기에 여기서 중요한 거는 뭐를 하는 거를 중요한 게 아니라 이게 좋은 카보, 좋은 팻, 그러니까 퀄리티를 중요시하는 게 양보다는 중요하지 않을까 이렇게 생각이 됩니다. 네.
네. 좋은 발표 해주셔가지고 너무 감사드립니다. 저는 이제 앞에 계신 모든 교수님들께 공통적으로 질문을 드리고 싶은 게 있는데요. 그 이제 그 운동을 통해서 암의 효과가 있거나 또 이제 암과 관련된 여러 바이오마커 효과가 있기 위해서는 그 연구 디자인을 또 이제 RCT로도 많이 이제 하는 걸로 제가 이제 많이 좀 이제 공부가 됐는데 그러면은 그 온콜로지 그 암 중에서 좀 이제 크리티컬한 단계에 있는 분들한테 이제 운동을 적용한 그룹이랑 인터벤션을 적용하지 않는 컨트롤 그룹으로 조금 적용해서 효과를 검증해야 되는 연구 디자인을 구성해야 되는 걸로 좀 알고 있는데 그러면은 컨트롤 그룹으로 배정이 되는 분들 중에서도 그 운동이 필요하신 분들이 계실 텐데 혹시 이런 부분에 대해서 어떻게 어려움을 통제하셨거나 혹시 관리하셨는지 궁금합니다.
네, 아주 좋은 질문인데요. 그러니까 보통 우리 운동군하고 그리고 다른 그룹 유주얼 케어라 그래서 운동 빼고 일반적으로 하는 치료들을 다 똑같이 하는 걸 유주얼 케어라고 얘기를 하죠. 그래서 그분들한테는 제가 운동을 하지 마세요라고 막 강조하지는 않고 그냥 보통 본인들의 삶을 사시라고 하고 그리고 저희들이 신체 활동이 어떤지를 모니터링만 하는 정도로 일반적으로는 하고 있고요. 근데 그분들 중에서 자기가 운동하고 싶어서 실험에 참가했는데 운동을 못한 경우가 생기니까 그런 분들한테는 저희가 이 중재 기간 3개월이 끝나면 똑같은 운동을 똑같이 가르쳐 드리고 여기 오시면 저희가 일주일에 한 번씩 만나서 12주 동안 운동을 똑같이 가르쳐 드립니다. 그러면 대부분 좋아하시고 연구에 참여하시지만 막상 또 연구가 끝나면 오셔서 운동을 배우는 경우는 또 많지는 않습니다. 네, 이 정도 답변 드릴게요. 네.
감사합니다.
저는 사실 고수인 교수님께 좀 여쭤보고 싶은 게, 그러니까 그럼 교수님께서 실제로 아까 운동의 중요성과 사실 다양한 이 전문가들이 함께 운동 프로그램 뿐만 아니라 사실 라이프 스타일 바꾸는 거에 대해서 말씀하셨는데, 교수님 실제 임상에서는 그럼 어떻게 하고 계신지 한번 말씀해 주시면 감사할 것 같습니다.
저는 이제 유방암 환자들을 주로 보고 있기 때문에 아까 여러 가지 에비던스들이 상당히 많이 있는 편이고요. 일단은 유방암 치료를 시작하는 시점에서 저는 재활의학과 먼저 보냅니다. 네. 그리고 저희가 유방암 치료를 할 때 항암 교육도 이제 해드리고 동시에 뉴트리셔널 이제 그러니까 저희 암 영양 상담해 주시는 영양사 선생님이 계시거든요. 그래서 영양사 선생님이 또 상담을 같이 해주세요. 그래서 암을 치료하는 시점에서 아까 재활의학과, 그다음에 영양사 선생님, 그리고 항암 교육 이런 것들이 이제 같이 일단 들어가게 되고요. 그러면서 아까 제가 이제 심톰 모니터링을 한다라고 말씀드렸는데 이제 연구 목적으로 하지만 저희 병원에 이제 그런 프로그램들이 이제 저희 원내 환자 처방 프로그램 안에 같이 들어가 있기 때문에 제가 그거를 같이 이제 환자들 보고 사용해서 체크를 하도록 해서 이제 증상들을 계속 모니터링하면서 진료실에서 제가 그걸 보고 관리를 계속 해주거든요. 그렇게 되면은 환자들이 훨씬 더 증상에 대해서 잘 조절이 되는 것 같고요. 그래서 치료를 하는 동안에는 제가 그렇게 자주 보니까 이제 계속 관리가 되는데 이제 항암 치료가 이제 딱 끝나고 환자분들이 이제 서바이벌로 넘어가는 그 시점에 있어서는 요 시점에 또 교육이 굉장히 중요합니다. 그래서 이게 제가 논문으로도 썼는데 환자분들이 곧 이제 병원에 계속 오다가 이제 치료가 다 끝나고 본인이 이제 스스로 관리를 해야 되는 그 시점에서 되게 불안해하시고 그렇기 때문에 이때 교육을 잘 해드리면은 잘 가르쳐드리면은 환자분들이 그 가르쳐드린 대로 잘 따라가시는 경우들이 많은데 이거를 안 하고 이 시기를 넘겨서 어느 정도 본인이 삶의 패턴을 예전처럼 그냥 간 다음에 교육을 하면 사실은 별로 효과가 없더라고요. 네, 그래서 이게 티처블 모멘트가 딱 있거든요. 그래서 그 시점에 교육을 잘 해서 사실 저희가 이렇게 암 생존자에 대한 교육 습관은 아직 없습니다. 그래서 참 암 재활 습관도 없어요. 아직. 그래서 여러 가지로 임상에서 적용하기 참 제한적인 부분들이 있지만 제가 참 그래도 이렇게 인복이 많아서 아까 재활의학과 교수님도 열심히 잘 도와주시고 또 이제 암 생존자로 넘어가는 그 시점에 제가 암 생존자 클리닉 그러니까 암을 열어서 그 시기에 환자들이 이제 오면은 거기서 상담을 해드리고 저희 이제 제가 다 얘기할 수는 없거든요, 교육을. 그래서 그런 환자들을 저희 간호사 선생님, 외래 간호사 선생님이 한 분이 이제 그걸 계속 교육을 해주세요. 그래서 이제 그걸 교육을 하면서 지금은 이제 관리를 계속 하고 있습니다.
그리고 저희가 사실 저희 연구실과 우리 사실 국립암센터랑 우리나라 5개 암 환자 표준화 운동 프로를 만들어서 통합지지센터에 보급을 했는데 거기에 가장 열심히 사실 참여하시면서 환자들에게 운동 가르쳐 주시는 센터가 있는데 그게 울산 통합지지센터였는데 거기 센터장님이시더라고요. 그래서 실제로도 그렇게 처방을 많이 하는 걸 저희가 이렇게 옆에서 보아왔습니다.
저희 이제 시간 관계상 이번 세션은 여기서 마무리해야 될 것 같은데요. 오늘 멋진 발표를 해주신 발표자분들께 마지막으로 박수 한번 부탁드리겠습니다. 수고하셨습니다.
장윤정 교수님은 아마 패밀리 메디슨 가정의학 전공하셨고 내셔널 캔서 센터의 센터장으로 재직하고 계십니다. 전용관 교수님은 스포츠응용산업학과 연세대학교 교수님이시고요. 우리 양은주 교수님은 대림 세인트 메리스 하스피털 리해빌리테이션 교수님이고, 우리 이지용 교수님은 아까 소개하셨겠지만은 연대 세브란스 병원 가정의학과 교수님으로 재직하고 계십니다. 그리고 저랑 같이 좌장 맡아주실 우리 김석희 교수님 소개 좀 해주시죠.
네, 안녕하십니까. 저는 카이스트 디지털 인문사회과학부에 재직 중인 김석희입니다. 저 운동생리와 가르치고 있고, 저는 노인 건강하고 대사증후군 관련돼서 연구를 진행하고 있습니다. 네, 반갑습니다.
저는 체육교육학과 서상훈 교수입니다. 저는 운동생리학 전공했습니다. We'll discuss the issue of cancer management from different perspectives, which include non-limited to nursing and family medicine, exercise, rehabilitation medicine, and public health, and so on. 아마 이제 계속 이렇게 진행을 할 텐데 혹시 audience에서 any questions, comments, and would be very much welcomed. 해주시고요. 제가 이제 첫 번째 질문으로 이렇게 5분 모셨으니까 tell us about the punchline message from your expertise. 김수 교수님부터.
제가 자리를 잘못 잡은 것 같네요. 맨 앞에.
네, 잠깐만, 좋습니다. 그러면 우리 이지영 교수님부터 해주시죠. 예.
아니, 하시려고 그러는데.
이지영 교수님 시간을 좀 드려야 될 것 같아요. 예. 이지영 교수님부터 그냥 펀치라인 메시지 하나씩만 우리가 잘 기억할 수 있도록. 암 케어에서 암 프리벤션에서 이거는 꼭 지켜야 된다. 이런 것들 있잖아요.
이제 전용환 교수님 맨날 운동이 약이시라고 말씀하시는데 저는 거꾸로 얘기하거든요. 그래서 운동은 밥이고 그 다음에 음식은 약이다 이렇게 말씀드려요. 그래서 운동은 맨날 하시고, 네, 그 다음에 음식은 정말 귀하게 약처럼 드셔라 이렇게 하셔서 어떻게 보면 교수님 말씀을 조금 더 말하자면 강조하는, 네, 운동을 더 강조하는 거라고 보시면 되겠습니다. 사실 그렇게만 하시면 모든 분들이 다 건강하실 것 같습니다. 네.
운동하라 이거죠? 알겠습니다. 그다음에요.
이렇게 하는 거군요. 무엇을 위한 운동이 아니라 움직임 자체가 삶이다. 네, 멋있죠.
굉장히 철학적인 그런 어프로치 같은데 알겠습니다. 예.
요새 철학도 다시 공부하고 계시잖아요. 네. 네, 우리 양은주 교수는 사실 우리가 첫 번째, 두 번째, 3년째 지금 계속 우리 같이 참여해 주신 재활의학과 전문이시고요. 저는 원래 운동이 약이다가 제 모토였는데 요새는 사랑이 약이다. 네, 옥시토신. 네, 사랑하면 그게 치유의 힘이 있더라고요. 그래서 그렇게 좀 생각하고 있습니다.
저는 이제 환자들이 물어봐요. 뭐 먹어야 돼요? 어떻게 해야 돼요? 할 때 생활의 루틴으로 집어넣으라고. 그래서 그분이 아침에 일어나서 잘 때까지 어떻게 생활하는지 봐서 그럼 그 안에 운동을 어떻게 집어넣을 것이냐를 본인이 얘기하라고 하거든요. 그래서 이게 특별히 무언가 특정한 시기에만 하는 게 아니라 생활의 루틴 안에 들어가야 될 거라고 생각합니다.
네, 저는 주로 이제 early breast cancer 그리고 이제 moderate fatigue 이상이 있는 유방암 환자들하고 RCT를 진행했었고 지금 하고 있는 연구는 유전쌍암 연구인데요. 제가 드리고 싶은 말씀은 괴테의 명언으로 서두르지 않듯이 멈추지 않습니다입니다. 그래서 조급한 마음 없이 언제라도 시작하면 가능하다. 그런 말씀 드리고 싶습니다.
여러분들 지금 이제 전문가로부터 테이크 메시지 들으셨는데 nothing special입니다. 그죠? 운동하고 뭐 생활의 루틴이고 사랑하고 서두르지 않고 움직여라. 그러면 캔서도 우리가 해결할 수 있는 게 아니겠느냐 이런 생각이 듭니다. 이제 조금 구체적으로 들어가서 이지은 교수님한테 제가 질문 하나 던지겠습니다. 아까 그 이동문 교수님 질문하셨는데요. 그 지중해식 다이어트 관련해서 그 캔서 환자들한테 굉장히 도움이 된다고 그랬는데요. 제가 이번 세션 준비하면서 페이퍼를 좀 봤어요. 근데 보니까 키토제닉 다이어트야말로 굉장히 로우 카보하이드레이트 다이어트거든요. 근데 지중해식 다이어트는 약간의 로우 카보하이드레이트. 하지만 카보하이드레이트 타입이 다르거든요. 그래서 그런 부분들이 어떻게 비교가 되고 그리고 어떻게 캔서 셀에 작동을 하는지 예를 들면 키토제닉 다이어트 같은 경우에는 캔서 셀이 에너지로 글루코스나 글루타민 쓰는데 키토제닉 다이어트 먹으면 캔서 셀은 마이토콘드리아 디스펑션, structural damage followed by dysfunction. 그래서 no energy from mitochondrial oxidative phosphorylation. 그래서 글루코스, 글루타민 depleted to starve the cancer cell. 그런 메커니즘이 제 머릿속에 떠오르는데 메디터리안 다이어트는 어떻게 how they work on cancer cells?
네, 사실 이전에 전용관 교수님하고 키토제닉 다이어트로 인터뷰션을 할까도 사실은 고민을 했었습니다. 근데 말씀하신 것처럼 캔서셀은 중요한 게 사실은 패스 시그널보다는 글루코스 시그널이 중요하기 때문에 사실 카보하이드레이트를 감소시키는 게 키토제닉 다이어트가 그 치료에 도움이 될 수 있다라고 하는 동물 연구나 여러 가지 기초가 되는 셀 연구들 많이 봤는데 사실은 휴먼 데이터에 있어서는 약간 한계가 있습니다. 왜냐하면 사람들은 말씀하신 것처럼 좋은 카보랑 좋은 팻만 먹지는 않거든요. 그래서 사실은 자칫 잘못하면 좋은 팻을 드시는 게 아니라 무조건 카보하이드레이트만 낮추면 오히려 저는 인플라메이션이 증가하거나 아니면 옥시다티브 스트레스가 증가하거나 안 좋은 영향을 미칠 수도 있다고 생각합니다. 근데 말씀하신 것처럼 지중해식 다이어트는 약간의 말하자면 한 40% 팻 있는 키토제닉 다이어트보다는 조금 팻을 낮춘 함량이기는 해요. 근데 이제 주로 메커니즘 스타디 뭐 저도 아까 말씀드린 것처럼 뭐 엑스트라셀러라 베시클도 보고 RNA 시퀀싱도 보고 그다음에 다른 여러 가지 메타볼릭 파라미터들도 보는데 임상 데이터를 보면 확실하게 메디터리안 다이어트는 팻셀을 약간 리덕션 시킵니다. 머슬 매스는 메인티넌스를 합니다. 그 다음에 인플라메이션은 확실하게 줄여주고 그 다음에 옥시다티브 스트레스 마커들을 조금 줄여줍니다. 그래서 이런 것들이 그냥 글루코스 시그널링에 단순히 이제 그것만 본다기보다는 전반적인 포괄적인 포지티브한 이펙트가 이게 이제 캔서 셀을 그로스하는데 막고 리커런스를 막지 않나 이렇게 생각이 들긴 합니다. 조금 더 저도 연구를 하려고 합니다. 기초 연구를 하고 아까도 말씀드린 것처럼 저는 클리니컬 스타디를 하고 거꾸로 사실은 동물 연구를 갖다가 증명을 하는 연구를 하고 있는데요. 사실 이게 첫 단계고 앞으로는 사실은 그 에비던스를 보려면 더 많은 연구가 이루어져야 되지 않을까 생각합니다. 네.
그 연장선상에서요. 김수 교수님이나 뭐 장윤정 교수님이나 우리 양은주 교수님 대답해 주시면 되는데요. 스트레스 관련해서 암 환자들은 굉장한 스트레스를 받고 있어요. 우리 박흥세 교수님은 예외적인 상황이 아닐까 싶은데요. 그러면 스트레스 관련해서 딱 떠오르는 게 스트레스 호르몬, 코르티졸 같은 경우에는 프로틴 브레이크다운도 증가시키고 리피드 브레이크다운도 증가시키고 따라가지고 신장이라든가 간에서 글루코네오제네시스도 증가시키고 그래서 글루코스 레벨을 상당히 증가시키거든요. 근데 글루코스 아까 말씀드렸지만은 암세포가 주요하게 사용하는 에너지거든요. 그런 차원에서 스트레스 매니지먼트가 굉장히 중요할 것 같은데 어떻게 하면 잘 매니지를 할 수 있을까? 말씀 좀 해주십시오.
사실 저는 이제 가정의학과 의사고요. 암센터에서 가정의학과 의사가 뭐 하냐? 이제 암 치료하는 것도 아닐 텐데라는 얘기를 많이 듣습니다. 근데 제 원래 이제 이 근무의 시작은 호스피스 영역이었어요. 근데 아까 이제 호스피스랑 리해빌리테이션 말씀을 해주셨는데 그 세인트 크리스토퍼 호스피스라는 곳이 이제 영국에서 모든 호스피스의 시조인 곳인데 거기를 가니까 리헵 룸이 있는 거예요. 말기 환자인데 리헵 룸에 우리나라 물리치료실 가면은 이렇게 침대 있고 이렇게 핫팩 있고 막 이렇잖아요. 근데 이렇게 볼이 있어요. 네. 그리고 이제 운동을 할 수 있는 것들이 있는 거예요. 그래서 그리고 그 리플렛이 있는데 rehabilitation in dying이 있어요. 죽어가는 중에서 할 수 있는 리헵이라는 그런 개념들. 그러니까 사실 리헵이라는 것이 뭐 기능의 개선이냐 이런 것만이 아니라 좀 편안하게 죽을 수 있는 최소한의 컨디션을 또 만들어줄 수 있는 그런 목적이라는 게 또 있는 거거든요. 근데 제가 이 말씀을 드리는 이유는 사실 제가 환자를 바라보는 관점은 저는 암의 크기를 줄이자, 암 세포에 영향을 주자로 보면은 그거는 이 환자 전체를 놓치는 일이라고 생각을 합니다. 그러니까 우리가 이제 아까 제가 피지컬 액티비티냐, 리헵이냐, 엑서사이즈냐 이런 거를 물어본 이유는 결국에 사람이 살아가기 위해서 기본적으로 필요한 것은 당연히 그걸 못하기 때문에 사실 이렇게 병태가 오는 건데 그거를 놓치면서 암의 크기와 암 세포에 영향 주는 것에 타겟팅을 하면은 그것이 장기화될 수가 없는 거거든요. 그러니까 항암 치료가 그게 가능한 이유는 단기이기 때문이라고 저는 생각을 합니다. 그래서 이 생활 속에 이걸 실천을 하면서 영향을 줄 수 있는 것이 무엇일까라는 것이 그게 좀 저희가 보편적으로 접근해야 되는 부분이고 그게 그 다른 리헵이나 이런 거랑 좀 차이가 있을 거라고 생각을 하고 아까 이제 말씀해 주셨던 부분에 있어서도 같은 맥락이지 않을까. 아, 네. 근데 그것이 이제 아까 그 말씀을 들으면서 제가 느낀 거는 이제 요즘에 이제 프리시즌 메디슨으로 가잖아요. 근데 프리시즌 메디슨으로 가게 되면은 에비던스를 바라보는 관점이 달라져야 돼요. RCT를 할 수가 없어요. 왜냐하면 프리시즌은 나만에게 맞춰지는 거거든요. 그래서 에비던스를 바라보는 시각 자체가 파라다임이 바뀌어야 되는 거고 그렇기 때문에 지금 이제 항암 치료나 이런 데서도 RCT의 방향이 바뀔 수밖에 없어요. 타겟이 다르고 그 맞지 않은 것을 다른 사람한테 적용하는 것 자체가 비윤리적이거든요. 그러니까 이게 지금 우리가 이 엑서사이즈를 바라보냐, 피지컬 액티비티를 바라보냐, 어떤 특정 타겟을 해서 어떤 특정 시기에 임팩트를 줄 거냐에 따라서 좀 저는 접근이 달라져야 된다고 생각하고 지금 이제 교수님이 추구하시는 방향이 그거에 이제 굉장히 많은 부분에 영향을 줄 텐데, 그러니까 제가 조금 우려하는 거는 그런 암 세포에만 타겟을 하는 것 자체는 좀 그거는 암 치료에서도 많이 하니까 암 환자를 건강하게 해주시면 좋겠다라고 생각합니다. 네.
저는 사실 여기 올 때마다 느끼는 건데 이제 이런 행사의 에너지가 너무 좋은 거예요. 이제 다학제이기도 하고 또 다 같이 이제 함께할 그 몫에 대해서 늘 열려 있는 것 같아서요. 네, 앞에서 장 부장님 말씀하신 거 이제 이어서 생각을 하면 오늘 오전에도 이제 여러 국가기관 평가에 좀 관여를 할 기회가 있어서 갔다 왔는데 거기서 이제 같이 평가하시는 분들 나눈 얘기가 전부 지표들이 너무 제한돼 있다. 그리고 그 의학적인 지표조차 삶의 질로 딱 끝. 근데 사실은 환자 경험이나 환자의 심리사회적 지표라든지 또 다른 어떤 주변의 환경적인 거라든지 관계적인 거 이런 부분들이 너무 없다는 그런 얘기 이제 아쉬움을 저희가 평가에 반영을 하기로 하고 이제 그런 얘기를 나누다 왔는데 한편으로는 또 이제 이런 운동도 그렇지만 라이프스타일도 스트레스도 어떻게 보면은 이게 이제 본인 선에서 할 수 있는 부분이 있고 정책적인 부분이나 분위기가 같이 이제 대화지 되는 부분들이 있어서 운동 관련 연구를 하시더라도 이제 앞에서 말씀하신 거에 조금 더 구현을 한다면 네, 그런 좀 지표를 좀 다양하게 가져가시는 부분들로 좀 말씀드리고 싶습니다.
네, 제가 다음은 좀 가벼운 질문을 좀 드리고 싶습니다. 그리고 여기는 지금 대학원생들과 학생들, 특히 또 체육, 운동 전공인 학생들이 많을 거로 생각이 되는데 제 임상에서 특히 의료 현장에서 같은 일을 콜라보레이션 하기 위해서 운동 전문가 혹은 거기에 필요한 인력으로서 같이 참여하기 위해서 어떤 준비를 미리 아니면 어떤 연구 능력을 갖고 있어야 앞으로 더 확대 혹은 콜라보레이션 하는데 더 도움이 될 수 있는지 전용관 교수님 제외하고 네 분만 말씀을 해주시면 좋을 것 같습니다. 네.
네, 저는 좋아하고 호기심이 중요할 것 같습니다. 제 주로 연구하는 주제가 제 이렇게 논문을 쓰거나 물론 SCI 임팩트도 중요한데요. 궁금한 거를 연구를 합니다. 그래서 환자분들 뵈면서 이거 어떻게 하면 도와드릴 수 있지? 사실 이렇게 시작된 게 식단을 개발하거나 아니면 역학 연구를 하거나 이게 계속해서 트랜스레이션으로 리서치까지 이어지게 됐기 때문에 좋아하고 궁금하는 거를 찾으시는 게 제일 중요하고 왜냐하면 그러면 아무리 힘들어도 견디실 수 있을 것 같습니다. 그 다음에는 계속 시간의 투자와 노력이 필요할 것 같습니다. 그 다음에 제가 펠로우 때 많은 논문들을 읽으면서 그러면서 계속해서 뭔가 탐구하고 이렇게 여기까지 되어 왔는데 앞으로는 뭐가 될까라는 거에 대한 계속적인 트레이닝과 함께 사실 또 연구를 하시려면 또 통계적인 분석할 수 있는 기본적인 능력도 함양하셔야 될 것 같고 네, 그다음에 객관적으로 사고할 수 있는 여러 방법을 배우려면 남들이 해놓은 좋은 것들을 어떻게 하면 따라갈 수 있을까 고민하시는 과정이 필요할 것 같습니다.
저는 사랑하는 마음인 것 같은데요. 진짜 암 환자를 위한 운동은 암 환자를 사랑하는 마음이 가장 기본이 되어야 되는 것 같고 쉽게 개입하려 하거나 인과론적으로 쉽게 해석하려 하지 않는 그런 조심성 이렇게 항상 무언가를 도와주려고 하면 주체가 항상 내가 주인이 되고 객체가 이제 환자분이 되기가 쉬워서 그렇게 되지 않도록 늘 조심하려는 마음, 그래서 주인이 환자가 될 수 있도록 하는 마음이 중요하지 않을까 생각합니다.
전 사실 이제 저희 영 인베스티게이터인 민지 박사님과 교수님 이제 제자가 저희 같은 팀으로 있는데요. 그 영 인베스티게이터를 꿈꾸시는 분들에게 얘기하고 싶은 건 이제 밸런스를 갖는 건데 사실 수업 중이나 이제 다른 교수님 밑에 있을 때는 내가 관심이 없어도 해야 돼요. 그거는 주어지는 업무고 그거를 해내야지 나중에 이제 PI가 될 수 있는 건데 그래서 내가 관심이 없는 주제라도 나에게 맡기면은 그걸 따라가면서 이 방법론을 익혀야 돼요. 내가 원하는 주제가 되면은 이 방법론을 적용할 수가 있거든요. 그래서 다양한 방법론을 익혀가는 게 이 학생 과정 등 이런 러닝 프로세스 중에서 일어나야 되는 거고 그 중에서 접하는 여러 분야 중에 내가 관심 있는 분야가 무엇인가를 찾으셔야 돼요. 네, 그리고 그거가 내가 할 수 있는 만큼의 역량이 되면 그걸로 뛰어들 수가 있는 건데 내 관심 분야를 찾지도 못했고 방법론도 없으면 나중에 연구자가 될 수가 없어요. 그래서 그 부분이 이제 좀 필요하시겠다 싶습니다.
약간 짜고 온 것 같이 되버렸는데 저도 사실 비슷한 얘기를 하고 싶었는데요. 저는 다양한 방법론을 좀 접하셨으면 좋겠다는 말씀드립니다. 그래서 뭐 오늘 이제 RCT라든지 하드 에비던스에 대한 얘기가 많이 나오기도 했지만 계속 회자가 되고 있는 거는 이제 뭐 사랑 또는 관심 그리고 살루토제닉한 헬프 기반한 헬프-베이스드 어프로치를 얘기를 하고 있는데요. 그러려면 환자들의 이야기, 환자들의 이제 경험들 그런 부분들을 알아야 되기 때문에 이제 뭐 예를 들면 질적 연구라든지 또 다른 어떤 뭐 프래그매틱 트라이얼이라든지 뭐 다양한 방법론을 좀 접하시고 배우시고 적용하실 수 있으면 좋을 것 같습니다.
저는 가벼운 질문으로 드리려고 했어요. 스튜던트를 여러분이 좀 부담을 드리게 된 결과가 아닌가 좀 생각이 되고요. 그 앞에서 지금 잠깐 말씀해 주셨는데 또 우리는 또 연구를 일부 하고 있고 앞으로 관심 있는 분들이 많이 모여 있기 때문에 사실 운동의 가장 큰 효과를 보기 위해서는 퍼스널라이즈나 아니면 인디비주얼라이즈가 가장 중요한데도 불구하고 연구 환경에서는 지금 RCT를 가장 또 선호하고 많이 쓰고 그걸 통해서 객관화하는 과정이 언젠가부터 스스로 이렇게 익숙해지는 게 없지 않아 있거든요. 근데 실제 연구를 많이 해보셨으니까 RCT 연구를 하는 과정에서 어떤 이 퍼스널라이징 된 어떤 환경의 페이션트하고 아니면 표본 샘플을 만났을 때 이걸 어떻게 처리를 해야 되거나 아니면은 이제 그걸 가지고 논문을 진행하느냐 마느냐 결정을 할 때 어떻게 어떤 의견을 갖고 있으신지 뭐 저 역시 뭐 이거와 관련은 없지만 그런 경우 혼동이 없지 않아 있거든요. 네.
굉장히 무거워 보이는데
잠깐 서서 질문을 드리겠습니다. 네.
그거 제가 간단하게 제 생각을 말씀드리겠습니다. 사실 아까 저 장윤정 사장님 말씀하실 때 되게 우와 그렇네라고 생각을 했거든요. 그러니까 옛날에 우리가 다 RCT, 에비던스 베이스드 하던 게 이제는 personalized precision medicine으로 가니까 기존에 이거 하나가 다 맞다라고 얘기할 수 있는 어떤 그런 근거가 나오기엔 좀 애매한데 그런데 저는 오히려 그런 생각을 해볼 수도 있을 것 같아요. 그러니까 RCT는 RCT인데 RCT는 그룹을 랜더마이즈 하는 거지만 트리트먼트로 갈 때는 그 어떤 알고리즘 안에서 그 사람 안에서도 예를 들면 저는 셀루토제닉 RCT를 하려고 하거든요. 그러면은 예를 들면 운동이랑 그냥 간단하게 만들면 운동, 뭐 식이, 수면, 그리고 스트레스 매니지먼트 이 네 가지 요소가 있는데 만약에 이거를 RCT 디자인을 한다면 운동을 이미 다 하고 있고 메디테리언 다이어트 열심히 하고 있는 사람한테 이거 더 하라고 할 필요가 없잖아요. 그러면 그 사람한테는 수면과 그 밖에 스트레스 매니지먼트를 조금 더 강조하는 인터벤션이 주어진다거나 그래서 앞으로는 이거는 제가 이제 라이프 스타일 면이지만 그래서 또 더 사실 프리시전 더 가면은 거기 뭐 유전자의 뭐 변이에 따라 뭐 이렇게 더 갈 수 있겠지만 그런 것들이 랜드마이제이션이라는 방법 자체를 다 버릴 필요는 없이 그거를 어떤 형식을 유지하더라도 인터벤션 안에서 좀 인디비주얼라이즈 되는 것들이 좀 있지 않을까라고만 교수님 말씀 들으면서 생각만 했는데 마침 질문하셔서 그 정도의 말씀드립니다. 또 다른 아니면 교수님 더.
제가 영어가 잘 못해가지고 영어 질문을 못 드렸는데 사실 림프 부종을 보는 입장에서 림프 부종이 있는 군 없는 군 운동을 하면 어떻게 되는지가 점점 림프 부종에 대한 이벌루에이션이 진행되면서 군이 있고 없고가 아닌 이제 정말 스펙트럼이구나. 초기에 스타시스라는 어떤 정말 플루이드의 스타시스에서 조직학적 변화가 진행이 되는 어떤 하나의 스펙트럼에서 컷오프를 정할 수 없구나. 그럼 어떻게 환자를 인터벤션을 하지라는 그 기준에서는 가장 중요하게 운동에서 생기는 가장 에센스의 변화들을 가지고 그 기준을 삼아야 되더라고요. 그래서 운동을 하면서 진행돼서 안전하고 부종을 일으키는 가장 처음에 그런 센스의 변화, 진행이 되게 하는 거거나 완전하게 하는 그 변화들이 이제 들어가 보면 림파틱 베슬에 있는 베슬라테이션에 대한 처음에 그런 거를 측정해 주는 것이 필요한데 이런 인터벤션을 측정할 때 인터벤션에 우리가 뭔가를 구성을 할 때 림프 부종이라는 한 예에 있어서지만 어떤 중요한 타겟팅되는 증상의 가장 초기 단계의 변화를 우리의 세이프티 마진으로 보고 그걸 어떻게 측정할 수 있는지를 보고 그렇게 측정하는 것을 가지고 환자의 세이프티에 대한 어세스를 규정을 해놓는다면 굉장히 보기에는 다양한 어떤 1kg짜리 하기도 하고 5kg짜리도 하고 보기에는 환자별로 다양한 어떤 인터벤션이 들어갈지 모르지만 그 인터벤션을 결정하는 크라이테리아가 결정이 된다면 우리가 장애 정해진다면 그것이 통일되어서 하나의 인터벤션으로 말할 수 있겠구나라는 고민을 했었습니다. 그러면 그 인터벤션과 그렇지 않은 군을 우리가 RCT를 본다면 조금 더 개별화되면서도 과학적인 방법으로 환자를 접근할 수 있지 않을까 한번 생각해 보았습니다.
머지않은 국내 노벨 생리의학상도 이곳에서 나오지 않을까 이렇게 기대를 해봅니다. 다들 아시죠? 노벨 문학상. 어느 학교 출신이죠? 자, 이제 오디언스 여러분들 뭐 궁금한 질문이 좀 있으실 것 같은데 좀 성함 말씀해 주시고 소속 말씀해 주시고 질문 좀 해주시면 대단히 감사하겠습니다.
질문 나올 때까지 한 가지만 말씀드리죠. 우리 공인덕 우리 원주 세브란스 그러니까 원주 거대 학장님 오셨는데요. 사실 공인덕 교수님 방금 전에 생활 습관 병 학회인가요? 네, 방금 우리 동시에 진행되는 데 갔다 오셨는데 교수님께 와주셔서 감사드리고 혹시 교수님 한 말씀 해주실 수 있을까요? 거기서 뭘 배우셨거나 아니 하신 말씀
갑자기 시키셔가지고 인사부터 하고요. 제가 누구한테 선물한 적도 있지만 우리 말로 번역되기를 암 그들은 이렇게 치유되었다라고 하는 미국 책이 있고 한국말로 번역된 게 있습니다. 결국은 제가 제일 좋아하는 것 중에 하나는 치료적 목적의 라이프 스타일 체인지이고 그건 하나의 컴포넌트가 아니다. 오늘 다 그렇게 말씀해 주지 않았습니까? 그래서 세계보건기구는 Health for all for health 이렇게 말하고 있는데 하나 더 하고 싶다 그러면 우리 all in one이라고 하죠. 이런 라이프 스타일 체인지가 여러 구성 요소가 있지만 실제 소비자가 원하는 거는 그 중에 하나가 아니라 그것들이 복합되어 있는 것을 필요로 하고 있다는 거 하고 마지막으로는 아까 수가도 말씀해 주셨는데 여기서 시작돼야 되겠죠. 우리 사회가 또 우리 국가가 이런 것들이 가치 있는 일이고 효과가 있고 지속 가능하다면 이게 우리 사회에 어떻게 전반적으로 퍼져나가서 정책이 되고 제도가 되고 그런 혜택을 우리 국민들이 받고 암 환자들 또 암 생존자들의 삶의 질 거기에 기여하기를 기대해 봅니다. 원론적인 얘기였습니다.
2명이고 패널 멤버는 5명이라서 수적으로 열세 있습니다. 여러분들 도움이 절실히 필요합니다.
네.
안녕하세요. 저는 연세대학교 종양내과 교수님 밑에서 석사과정 진행하고 있는 김치호라고 합니다. 저는 개인적으로 이지원 교수님께 조언을 하나 구하고자 해서 하게 됐는데, 일반적으로 제가 만나는 환자들은 이제 암 환자들은 아니지만 폐질환 환자들이지만 이제 좋은 그것도 이제 식단이 중요하기 때문에 저희가 이제 설명드릴 때 뭐 좋은 탄수화물, 좋은 지방 이런 것들에 대해서 설명을 해드리는데 50대 분들은 괜찮은데 이제 70대 분들이 이제 딱 간단하게 그 식단 적어온 거 보면 이제 저희가 보고 왜 어떤 밥 드셨어요? 이러면 쌀밥 이렇게 하시는데 저희가 이거 말고 이거 드시라고 했잖아요 하면 갓 지어서 좋아 약간 이렇게 하거나 아니면 또 갓단 채소 뭐 새벽 시장에 나오는 싱싱한 뭐 이런 것들 그게 이제 좋다고 생각하시는 경우들도 있어서 그게 좀 뭔가 직관적으로 알아듣기 쉽게 이렇게 설명할 수 있는 방법이 있을까 해서 조언을 구하고자 합니다.
매우 어려운데요. 네, 그래서 제가 메디컬 뉴트리션 각 질환마다 개발하는 걸 하고 있습니다. 환자분들을 뵙는데 말씀하신 것처럼 70대도 있고 60대도 있고 80대도 있으시고 90대도 있으시고 하세요. 10대도 있고 한데 제일 싫어하시는 게 뭐냐면 뭐 드셨어요? 하고 조사하는 걸 제일 싫어하세요. 그 다음에 FFQ가 그 설문 문항이 150가지인가 160가지가 넘습니다. 그거 하고 식단 조사하고 하는데 30분 이상 걸려서 저도 싫어요. 그래서 지금 현재 제가 세브란스에서 하고 있는 거는 어떻게 하면 이 사람들을 빠른 시일 내에 식습관을 조금 좋고 나쁜 거를 디텍션을 할까. 그리고 사실 아이들도 그 관련된 산자부 과제를 하고 있습니다. 가장 쉽게 조금 식습관을 조언해 줄 수 있는 툴. 그래서 아까 설문도구 이런 것도 개발을 했지만 다른 AI 도구도 개발을 하고 있고요. 그다음에 아무리 말씀드려도 좋은 카보하이드레이트, 좋은 프로테인, 좋은 팻을 이 어르신들이 사실 해 드시기 힘들어요. 그래서 아무리 말을 해봤자 집에 가서 딴 거 드시면 아무 소용이 없거든요. 그래서 되도록이면 손쉽게 쉽게 구할 수 있는 그래서 임상시험을 할 때도 배달을 해드립니다. 전국 각각으로 제주도까지도 배달을 해드리는데 얼마 전에 끝난 만성 크로닉 키드니 디지즈 환자분들 평균 나이가 CKD 3단계, 4단계 75세셨어요. 그분들에게 아무리 교육을 해드려도 집에 가서 딴 거 드시면 소용이 없습니다. 그래서 시작한 게 가장 손쉽게 본보기로 샘플을 보여드리고 드시게 하고 그 다음에 이후에 따라서 드시게 하는 방법을 저는 하고 있습니다. 아직까지도 저에게는 그게 가장 큰 숙제예요. 네.
이제 예를 들면 운동이든 다이어트든 그 모든 많은 에비던스들이 있으면서 우리가 많은 환자들도 이제 어웨어니스는 많이 증가한 상태인데 이제 운동이 좋은 거 다 알잖아요. 뭐 환자들도 운동해야지 알고 이제 다이어트도 잘 먹어야지 하지만 이 점점 이제 커지는 갭이 그저 intention and behavioral gap 그 부분에 있어서 이제 여러 가지 이제 모든 인터벤션들이 있다고 하면은 이제 여러분들께서는 어떻게 이 갭을 제 생각에는 점점 더 필요해지는 이 갭을 줄이는 방법 중에 어떤 방법들이 좋을지 어떻게 생각하시는지 좀 들어보고 싶어요.
누가 답하시겠어요?
짧게 하겠습니다. 굉장히 순전히 개인적인 의견인데요. 제가 지금 모 보험회사의 보험을 들었는데 하루에 7,000보 이상 50대 여성의 평균 걸음이라 하더라고요. 7,000보 이상을 걸으면 보험료를 깎아준대요. 열심히 걷게 됩니다. 근데 이제 환자분들의 경우에는 꼭 그런 직접적인 인센티브가 아니어도 이렇게 하는 일이 정말 의미가 있고 아까 박흥세 대표님처럼 이제 그런 어떤 좋은 사례들을 접하면서 이제 새로운 어떤 패러다임, 새로운 라이프스타일로의 어떤 전환에 가는 그런 부분으로 이제 적절한 타이밍에 좀 모티베이션을 다시 좀 부스팅해 주시는 예를 들면 예방접종해도 저희가 부스터샷을 맞잖아요. 그런 것처럼 아마 또 그런 중요한 시점들에 대한 파악을 하면서 좀 그런 부분들을 격려해드리면 어떨까. 결국은 그분들을 이제 같이 연구팀의 일원으로 같이 모시면서 그런 아이디어들을 좀 개발하는 게 어떨까 생각합니다.
저도 저는 중요한 내용들은 아니었는데요. 오늘 그 닥터 슈미츠 선생님이 말씀해 주신 것 중에 그 Strengths ABC라는 프로그램이 실제로 그 연구 단계를 거쳐서 실제로 프랙티스까지 적용되는 것들을 잘 봤잖아요. 근데 한국에서는 그렇게 진행되고 있는 프로그램이 제가 없다고 알고 있어서 네네. 혹시 그런 부분들이 똑같이 한국에서도 좀 이렇게 잘 되기 위해서는 어떤 것들이 필요하고 안 되고 있다면 어떤 부분들 때문에 그런지 그런 부분들 한번 말씀해 주시면 도움 될 것 같습니다.
아주 좋은 예시가 바로 여기 전용관 교수님께서 암종복 과제로 아까 대장암 환자라던가 이제 암 환자 운동 프로그램을 만드신 거를 국립암센터에서 암 생존자 통합지지 사업이라는 걸 하고 있고 이제 13개 지역 암센터 국립암센터의 그 복지부 사업으로 이제 센터가 있습니다. 그래서 그 센터를 통해 지금 확산을 하고 있고 이제 질 관리와 여러 방안으로 또 계속 지원을 해주고 계십니다. 그래서 기본적으로 저희는 이제 에비던스로 있는 프로그램을 국가 사업화 시키는 거를 계속 하고 있기 때문에 혹시 좋은 연구 성과 있으시면 저희에게 알려주셔서 확산하는데 저희가 그 루트가 될 수 있거든요. 근데 좋은 에비던스를 많이 만들어 주시면 좋겠습니다.
그걸 또 커뮤니티 확산하신 연구도 하시잖아요. Okay, we're just talking about how we disseminate, our research finding to community, just like Strength ABC. Yeah. So, any suggestion to Korean?
How to?
Yeah. Yeah. Or any tip to all of us?
I think it's been said already today, but we have to meet people where they are. I think Justin Brown said that in one of the early talks. And I think we have to pay attention to the people who are saying no to our trials. We have to know what's happening with those people, and we have to talk to them to find out why they're not interested. We have to talk to the clinicians who are not recommending exercise and find out what they would need to know in order to change their minds for them to do it. And then I think we really have to lean into technology. I think technology is going to be an enormous, enormous help to all of us for nutrition and for exercise.
저 한 가지만 저도 추가해서 말씀을 드리면 사실 여기에 지난번도 그렇고 이번도 그렇고 현장에서 많은 분들한테 운동을 가르치는 필라테스를 가르치시는 분들도 계시고 또 PT를 하고 계시는 분들도 계시고 근데 그분들한테 제가 요새 강의를 하게 되는 경우가 있었는데 본의 아니게 자꾸 환자가 오신다는 거예요. 네. 환자가 오는데 어떻게 해야 될지 몰라서 그냥 보내기도 하신다고 얘기를 하시더라고요. 그래서 앞으로 저희가 좀 그런 부분들을 좀 신경을 써야겠다는 생각이 들긴 해요. 근데 사실 운동해도 되는데 왜냐하면 혹시 시키다가 그분들이 뭐 문제가 생기면 어떡하지 하고 그분들을 배려하는 마음으로 사실은 못하는 경우들이 있거든요. 그래서 앞으로 여기 계신 우리 교수님들도 그렇고 함께 좀 우리 일반 그런 운동을 가르치는 현장의 지도자들이 활용할 수 있는 그런 암에 대한 정보들 또는 어떤 부분들을 주의해야 되고 어떤 부분도 어떻게 해야 될지 이런 것들을 조금 가르치는 그런 작업들을 해야 되지 않을까. 지금 시대가 그걸 요청하고 있기 때문에 그렇지 않을까 생각이 들고 한 가지 바람은 만약에 저희가 지금 올해가 3년 차 하고 있는데 이제 내년이 4년 차인데 한번 저희가 이제 한번 우리 예전에 얘기도 했었는데요. 신체 활동 가이드라인을 암 환자 신체 활동 및 운동 가이드라인을 좀 만들 때가 되지 않았나 해서 저희가 우리 공인덕 교수님도 계시고 우리 고수진 교수님도 계시고 한데 저희가 의료계와 운동과 그리고 퍼블릭 헬스 그런 폴리시 메이커 이런 분들이 국가 정부의 그런 부처들 좀 이제는 좀 암 환자들을 위한 어떤 가이드라인을 만드는 일들을 이제는 시작해야 되지 않을까라는 그런 생각을 했습니다. 혹시 교수님 어떻게 생각하세요?
이제 아마 에비던스를 다시 이제 정리를 하면서 가야 될 것 같고 그 과제를 씨앗으로 진행을 했었죠. 네. 근데 사실 그 암 환자의 가이드라인을 만드는 부분은 진짜 이 교수님께서 진행하셨던 것 같은 많은 연구. 근데 대부분의 연구가 이제 외국 자료이기 때문에 진짜 그걸 우리 환자에게 적용할 수 있느냐. 그것이 우리에게 정말 합당한 에비던스가 될 거냐라는 이제 그런 검토부터도 또 진행이 돼야 되지만 정말 작은 연구들이 우리 내부에서 충분히 또 같이 활용이 되면은 초기가 만들어지고 업데이트가 되고 할 수 있을 거라고 생각합니다.
저는 그냥 제가 요즘에 생각이 들 때 그 가이드라인이나 무언가를 정해놓는 거가 환자의 개별화된 접근에 혹시나 제한이 되지 않을까 하는 조심성이 있어서 그런 논의들을 같이 환자분하고 충분히 이야기하는 자리도 있으면 너무 좋을 것 같고 오늘 사실 저는 너무 대표님 강의 잘 들었습니다. 그래서 같이 오셔서 강의를 들을 수 있는 시간이 있다는 게 참 좋았습니다. 덕분에 감사합니다. 그리고 이런 시간들이 더 많이 있었으면 좋겠다 생각합니다.
만약에 앞으로 우리가 가이드라인이라는 걸 만들게 되면 정말 환자가 함께 주도하는 그런 어떤 것들이 있으면 좋겠네요. 네. 네.
그 가이드라인 말씀하셨으니까 또 무거운 질문 하나 드리겠습니다.
시간이 다
됐는데 그냥 질문만 들으셔도 됩니다. 가이드라인이 그 암 종류가 무지 많잖아요. 그리고 암의 단계도 굉장히 다양하죠. 그리고 개인 차이도 많이 있고요. 그래서 그거를 아우르는 가이드라인 어떻게 만들까 이런 또 우려가 듭니다. 우리 죄송합니다. 우리 이지원 교수님 한번 말씀해 주실래요?
저는 운동에 대한 가이드라인보다 운동은 워낙에 전용현 교수님의 넘사벽이기 때문에 그쪽을 침범하려 하지는 않습니다. 대신 그 메디컬하고 먹는 거에 대한 가이드라인을 만드는데 사실은 좀 관심이 있어서요. 사실 우리나라 환자 데이터가 너무나 없어서 지금 아까 제가 처음에 하는 작업이 에피데미올로지컬 스터디를 먼저 한다고 했는데 대규모 데이터, 우리나라 데이터나 아니면 UKB, 그다음에 여기 이동훈 교수님 계신데 가능하면 미국 데이터도 조금 에비던스를 마련하고 지금 현재 세브란스 환자들 암 환자마다 다 생활습관이나 식습관 조사하는 거를 진행을 하고 있습니다. 그래서 정말 아까 유방암 잠깐 소개시켜드렸는데 코리안 파퓰레이션은 도대체 어떻게 먹고 있는가에 사실 관심이 있거든요. 그래서 아무리 좋은 다이어트도 유러피안하고 사실은 아메리칸에게 효과가 있고 코리안에게 효과가 없으면 사실 우리나라 사람에게 도움이 안 된다고 생각을 하는데 그런 데이터가 사실은 전혀 없습니다. 그래서 그거를 지금 하나하나 만들어가는 작업을 하고 있고 저희가 내년에 세브란스에서 메디컬 뉴트리션 센터가 생깁니다. 그래서 그렇게 되면 훨씬 더 많은 연구와 그 다음에 리서처들의 도움으로 더 많은 에비던스를 조금 마련할 수 있을 거라 생각이 듭니다.
네, 지금 조금 늦게 시작했지만 여러분들의 이제 관심과 또 우리 패널 분들의 적극적인 답변으로 이제 마무리할 시간이 된 것 같습니다. 저는 그 3년 동안 이 심포지엄에 참여하고 있는데 여러분을 이렇게 마주해서 앉아 있어 보니까 더욱 앞으로 더 확대 발전할 것 같다는 느낌이 들고요. 한 자리에서 암과 운동에 대해서 총망라해서 들을 수 있는 기회는 아마 제 경험으로나 뭐 식견으로나 봤을 때 대한민국에서는 이 자리가 아닐까 생각이 됩니다. 그리고 이 자리를 준비하시느라고 기획 준비해 주신 그 정용광 교수님, 스포츠 응용학과 또 여러분들도 감사드리고 그리고 융합연구센터의 또 후원 또 감사드리고 여기 앞에 계신 패널 여러분들께 큰 박수로 오늘 자리 마무리하겠습니다.
감사합니다. 제가 한 말씀만 드리고 제 마무리를 하려고 이거 끝나고 패널을 근데 사실 제가 지난번에 세션 때 중간에 말씀드린 적이 있었는데 작년에 저희가 이걸 매년 하다 보니까 그리고 매년 하려다 보니까 저희 준비가 미흡한 게 많을 수 있습니다. 왜냐하면 저희가 이번 준비의 100%를 하면 우리 대학원생들 다 휴학해야 되고 이것만 준비해야 되고 그렇잖아요. 근데 다 지금 논문 쓰고 있고 박동혁 학생은 오늘 아침에 박사학위 논문을 끝냈고, 네, 그래서 저희들이 좀 미흡한 준비가 있지만 다 저희들이 그냥 일하면서 조금씩 한 거라는 부분을 양해해 주시면 감사하고, 특히 오늘 이렇게 수고해 주신 우리 대학원생들 잠깐만 일어나시면 저희가 이번에 이동훈 교수님 연구실 대학원생과 저희 연구실 대학원생 함께 준비했거든요. 다 일어나세요. 네, 우리 박수 한 번만 참여해 주셔서 감사드립니다. 감사합니다. 저희 잠깐 사진을 이쪽으로 가서 앉으시면, so now we're going to take a picture. So you don't need to come. You can sit at the front, please.